I can see him. I think we can start with Dr. Nitin Burkule and Rishikesh rather than wasting some time. Will that be okay, Dr. Mittal and Dr. Amutan? Perfect. Dr. Nitin Burkule, please.
Good morning, everybody. I welcome you all to our simulation workshop at IMA's birthday. It's really a warm Sunday morning, and it really gives me great pleasure to introduce you and to show you off our simulator lab at IMA's birthday. We regularly do simulation workshops. So today, this is our simulation lab here. So today, I'm going to show you the various key views which we do it on simulator. These views are as per the IE guidelines which follow. So let us, without wasting time, let us go straight away and let me show you the views. So we essentially start first as a baseline view with 5 chambers, and that we keep as a fixed view or a baseline view from where we need to perform other views. So from 5 chamber, when I push my probe slightly in, I go to the 4 chamber view where I see LA, LB, RA, bilateral wall and furnace window. From there, I increase the angle to say around 45, 50 and slightly turn my probe leftwards, and I get typical what is known as bicommissional view. I typically get bicommissional view. So what I typically get in this view is 2 parts of the PML and 1 part of the AML, namely P1, A2, P3, and both the medial and lateral commissions. From here, I go further, I increase the angle, and I go to around 90 degrees, and I get our 2 chamber view. In this 2 chamber view, you just see LA and LB. The LA wall, which is bordering the LA anterior wall, while the LB wall, which is bordering the coronary sinus, the inferior wall. From here, I further increase my angle to say around 125 to 130 and get typical 3 chamber view. This view is similar to our apical plaques view.
I think the mic you have to be a little closer.
Okay. Can you hear me now? Is it okay?
Much better, much better.
Okay.
Speak louder.
Okay. So this is our 3 chamber view, and what we see in this view is basically the anterior septum and the posterior wall of the LP, along with aortic wall and alveoli. In the same view, if I reduce my angle slightly to 110 or something, and I pull out my probe, I will be able to see whole of the ascending aorta. I pull out my probe till I see whole of the ascending aorta up in RP. In real life also, you will be able to see whole of the ascending aorta in RP only. This is because beyond that there is a blind spot. A bronchus crosses and you will not be able to see the upper part of the ascending aorta. So now I come back again to our 5 chamber view here, and from here, without changing any angle, I start pulling up the probe. So this is my first view of higher esophageal view, where I see main pulmonary artery dividing into RPA and LPA. I don't see much of the LPA here, again because of the same problem, and bronchus traverses cuts through this, so not much of the LPA can be seen, but RPA can be traced right up to the highway. Then anteriorly to the RPA, long axis of the RPA, you can see short axis of the ascending aorta as well as SVC. So then further, I move my probe slightly down, and I find that now the RPA has been replaced by a vein, which is the right superior pulmonary vein, which is entering into the LA. I can still see SVC and I can still see some part of the ascending aorta. I further go down, and now slowly, the SVC has already joined the RA, and there is no more SVC there, and I can still see one more pulmonary unit which is joining the LA. Now this becomes the right inferior pulmonary. If I want to see both the right superior and right inferior pulmonary vein in one view, all I need to do is just go to around 30-35 degrees and turn my probe slightly rightwards, and you can see that I can see both the right superior and right inferior pulmonary vein in one view. I come back again. I come back to 5 chamber. As I said, my 5 chamber is my baseline view. Now here what I do is I go to 60 degrees and I get my inflow RV inflow outflow view. The various things which we see in this view is you can see the LA interaxial septum, RA tricuspid wall, RVOT, pulmonary wall, and in pulmonary artery. And in the center lies the aortic wall. You can see the 3 cusps of the aortic wall. The 3 cusps of the aortic wall can be identified. The cusp opposite the interaxial septum is MCC. The cusp opposite the RVOT is RCC, and the remaining one is the LCC. Now from here I move my probe further and to 90 degrees, and I get and slightly move my probe more rightwards, and I typically get what is known as bicaval view. In this view, I can see some part of the SVC, some part of the IVC, RA, LA, and I can see the right superior pulmonary vein draining into the LA. Now, if I want to look more better at the SVC, I have to slightly increase the angle to say around 100, 110, and slightly pull out the probe because SVC is a superior structure. So here you can see, I can see the SVC right up till RPA, and I can see SVC in this long axis. The way which is posterior to the SVC is right superior pulmonary. Now, to look for the IVC, I need to reduce the angle to say around 75 to 80 and push the probe inside much better. And now I can see the IVC. More important in IVC, you need to look out for is the eustachian wall. Remember, the eustachian wall is on the anterior limb of the IVC, and the IVC limb, the patient has a case, is on the posterior limb. And many times a long eustachian wall can be confused with an IVC limb. So to differentiate that, it is pertinent and it is important to look for IVC mouth or IVC opening and look from where the eustachian wall is coming. Now from here, I again go back to 60. And now I turn my probe leftwards, slowly, come to 2 chamber. Then I come to the LA appendage. I still turn my probe leftwards. And now here I come to left superior pulmonary vein. So this is the view in which I see the left superior pulmonary vein. Now to get the left inferior pulmonary vein, all I need to do is just increase the angle further to say around 125, 130, and still go further left slowly. And in this view, I can see both the pulmonary veins, the left superior and left inferior in one view. So in this view, basically pulmonary veins are extreme structures. So at 125, 130, extreme left, you see left-sided pulmonary veins. 35, extreme right, you see right-sided pulmonary veins. So now I come back again to 0 degrees, my baseline view, and this is our 5 chamber. From here now, I move towards the gastric views. So I push my probe again from 5 chamber to 4 chamber. Now I come back to 4 chamber view. Furthermore, pushing the probe down, you will see now in 4 chamber the LA has disappeared, and now it has been replaced by a pipe-like structure, coronary sinus. So this is the last view of esophagus before we go into the stomach. So you can see a goodbye view of the esophagus. So from here, I will further move my probe into the stomach, and now I have reached the stomach. Now in the stomach being a whole bag, you need to anti-flex the probe a bit so that it comes into contact with the stomach wall. Here you can see, now you are cutting at the level of the mitral wall. You can see the AML, which is closer to the septum, and the PML, which is far away from the septum. Okay, so this is at the level of the mitral wall. Now, when we go further down, slowly and slowly, you can see the tricuspid wall, because tricuspid wall is slightly lower than the mitral wall, and you can see all the three cusps of the tricuspid wall. Now here it is, we see very nicely 0 degrees, but at times you need to go anywhere between 30 to 60 degrees to visualize all the three cusps of the tricuspid wall. The three cusps of this tricuspid wall which you mainly see is STL, ATL, and PTL. So this is one view in which you can enter see the tricuspid wall in. Then I further go down, and now I reach at the level of papillary muscle. So this is where I come at the level of papillary muscle. Now this view is especially important for cardiac anesthetists to know the volume status as well as the LV function. So if both papillary muscles start kissing each other, we call them as kissing flaps, which is a sign of hypovolemia and hyperdynamic. Let's go further down and we reach cardiac apex. Now I again pull out my probe slightly at the level of the papillary muscle here, and then I start anti-flexing the probe. So when I start anti-flexing the probe slowly, I first open the RBOT, which you can clearly see, and some amount of pulmonary wall. I anti-flex more, and I start opening the LVOT. Now this is known as deep transgastric. This view is especially important to take gradients across aortic wall. Because this is the only view in which you can take gradients across aortic wall. So especially a patient of AVR and immediately who has undergone AVR and you want to see gradients, especially to rule out PPM, this is the best view to take. I again retroflex it back and come back to our original papillary muscle. Now here what I do is I'll increase the angle to say around 90. So I make it a long axis view. And this is nothing but two chamber in long axis. So I can see here and anterolateral and posteromedial papillary muscle, the bodies and the mitral wall. This view is especially important for surgeons for repair to know the length of the chordae, which is flail, which chordae is flail, and for all other that information. You can see LA appendage also. Now, then if you increase the angle slightly to 100, 110 here and slightly go rightwards, you can take gradients across the aortic wall. So this is an alternative view. If you don't get gradients in deep transgastric view or you are unable to get gradients in deep transgastric view, you can use this view to take gradients across aortic wall. I again come back to 90 here. 92 chamber. Now I want to see the right side of the heart. So what I do is I start rotating the probe on the right side slowly. I will first open the RVOP, then the LVOP, and this is RV inflow view. So what are the various structures which I see in this RV inflow view? The various structures are RA appendage, RV free wall, ATL and PTL. So this is one view in which you can see RA appendage very clearly and RV free wall. This view is especially important for surgeons, cardiac surgeons, to look for when you come out of the CPT to look for RV function. And this is the only way in which you get ATL and PTL in one. Okay. Right. So now let's come back to our original 5-chamber view. So I'm pulling out the probe and coming back in the esophagus again, slowly. Now I've come to 4-chamber and now I've reached 5-chamber view. Now I want to go and look for descending aorta views. So what I do to look for descending aorta views is I turn the probe leftwards slowly, and here I come. When I go posteriorly, I see a rounded structure that is nothing but a descending aorta in short axis. So what I do here is I start pulling the probe out. So I'm pulling the probe out slowly, and I'm looking out for plaques or any dissection flags there. I still pull out the probe and I can see that the circular structure, the descending aorta, which is circular, now is no more circular and it has become oblong. So the moment I reach there, that means I've reached the arch of aorta. Here what I do is I increase the angle to say 90 degrees and I start rotating the probe rightwards. So slowly I start rotating the probe rightwards. And this is the first vessel which I get. This is left subclavian. I further rotate and I get, you can see left common carotid. The another marker, you can see the pulmonary wall with main pulmonary artery. Whenever you see the pulmonary wall and main pulmonary artery, in the arch view, the corresponding arch branch is always the left common carotid. And I go further right, and you can see I can get the last branch, that is brachiocephalic. So these are the various main views of PE which we usually take it and which everybody should know how to take it. Now this simulation offers you a great advantage where in real time, whatever maneuvers you have to do, the same maneuvers you are able to do on the simulator. So the simulator is by no means a replacement to the real T, but all it does, it drastically reduces your learning curve and makes you more efficient in learning. There were some views I would tell which we never used to do, that especially the arch views and descending aorta views, but only after learning from simulation we started doing it and we started picking up a lot of plaques and a lot of this. So I thank you, all of you, and I now hand over to Dr. Nitin Burkule for cases.
Thank you, Dr. Rishikesh. I think that was very good.
Thank you, Dr. Rishikesh. My slides are, I think, visible and I'm audible, isn't it?
Yes, sir. Yes, they are. They are.
Am I audible now?
Yes, yes, you are.
Yeah, and it's not. Yeah, can you hear me now?
Yes, we can.
Yeah.
We can.
So the thing is now, Dr. Rishikesh has shown all the views that we had discussed in the Indian Academy of Echocardiography guidelines of transthoracic echocardiography. Now I'll quickly go through the mitral wall evaluation. Now this is the animation of the mitral wall, and this is the way, our T probe moves in relation to the mitral wall from the left atrial aspect, and we will get all the scallops examined by rotating the multiplanar T imaging plane. So these are the planes in which we will be evaluating each and every scallop of the mitral wall. So let us start with a 0-degree view, which is this blue plane in which you are seeing a P2 here and an A2 here. The moment this blue plane I pulled up, that means I go from 4-chamber view to 5-chamber view, I cut through the lateral commissure. Okay, so by cutting through the lateral commissure, I get the P1 in the view. Then if I go to say a 45 to 60 degree multiplanar view, then this is this red plane, and this red plane cuts through the P1, A2 and P3. So if I show you on the image, this is the P1 and this is the P3, and what comes and sits in between is the AML. And this is the lateral commissure and this is the medial commissure. Now from 45 to 60 degrees, if I go to 90 degrees, that is this green plane, okay, I am cutting through A1, A2 and a part of P2. So that is how it is. But however, in this plane, if I clockwise rotate, then the plane cuts through the medial commissure. So that is why if I have a 90-degree medial sweep, I will cut through the medial commissure and will get a glimpse of the P3. Then if I go to 120 degrees, this is this yellow plane, I will be cutting through the A2 and P2. And this is A2 and P2, and this is the central orifice. Now, now the color jets of the mitral regurgitation give you an extraordinary insight into the mechanism of mitral regurgitation. So how do we go about it? So what we do, we divide the left atrial cavity into superior and inferior, and those jets which are directed in the superior cavity are because of the prolapse of any of the cusps of the PML, and those jets which are directed inferiorly in the LA cavity are because of the prolapse or flailness of any of the AML scallops. Then we divide the left atrial cavity into lateral, middle chamber, and medial chamber. Okay, and those jets, okay, the like this yellow arrow, which are directed towards the interatrial septum, are through the lateral commissure, while those jets, like shown in blue, which are directed towards the LA appendage, come from the medial commissure. Okay, and those jets which are straight forward towards the LA roof are either coming from the orifice or from the clefts. So what we'll do is we'll look at certain cases because we have still some time. And this is a 55-year-old gentleman. You can see the jet is going in the superior chamber of the left atrium, anteriorly towards the aortic root, and you can see the PML flail, and this is the 120 degrees view. So you know that this is a P2 segment. And this is the bicommissural view, and one can see that the P1 is fine, the P3 is fine, the AML is fine, and what is prolapsing below the AML is the P2 segment, and this is actually the effective regurgitant orifice. And then again we are in 0 degree, and you can see the flail P2 there, and the 3D will always give an incremental information, and you can see this P2 segment prolapsing towards you. Now the color scheme in the 3D tells you about the depth of that particular tissue. So here you always orient it in the surgeon's view, where the aorta is at 12 o'clock and the LA appendage is at around 10 o'clock, interatrial septum is at 3 o'clock. Then so let us go ahead for the, this is from the LV aspect, and we'll look at the another case of a 65-year-old gentleman, and let us evaluate this case. So we are in 5 chamber. We can see that the lateral commissure is all fine. The P1 is fine there. And then we are in bicommissural view. And what I can see that the P3 is actually not co-opting well with the AML. And I can see a jet there, which is hugging the AML and is coming through the medial commissure. So I know that this is the P3, which is at a fault. And then with a 90-degree sweep medially, that means a clockwise sweep from 90 degrees, I can see the P3 here, and I can see that the P3 and AML are not co-opting, and you have got a regurgitation jet there. And then we go for a 3D, and in 3D you can see that this is the area of P3, and the P3 is prolapsing, and that is what, and the area of starting of the jet through the medial commissure. So a systematic evaluation can tell you about the mechanism of MR. Sometimes you have multiple jets and you have to really do it very, very carefully. And I'm going to show this case, a 55-year-old gentleman. This is the bicommissural view. What I can see here is that this is the P1, which is having a severe prolapse here. And this is the P3 and this is the AML. And I can see that there are 2 jets now. You have to give an explanation for both the jets. Now the jet which is going this direction, I know this is because of the problem in the lateral commissure. So that is why it is oriented towards the interatrial septum. But what is the cause of this central jet? So we'll go ahead, and here we again see the bicommissural view a little closely. We have got 2 jets. We have to give explanation for each of these jets. And here we are again in the same bicommissural view. I am now 90 degrees, and then I have a medial sweep. I am looking at the P3. There is absolutely competent medial commissure, so everything is problem from the lateral commissure. And then I'm going with a 90-degree lateral sweep, and I can see that there is hardly any contact between the P1 and the AML. There's hardly any contact. There's a big gap, which is very unusual to get it. Okay, and then we have got this 120, 130 A2P2 view, which is showing a very competent connection. And then we, from 120 degrees, I have got a lateral sweep to look at again the lateral commissure, and I can see that it's hardly making any contact there. So that tells me of the central jet. So I got 2 jets. I have to have an explanation for both of them. So what we do is that we have this one central jet, and then we have got another jet like this yellow, which is going towards the interatrial septum. And this I know is because of the P1, which is prolapsing, and that's why the lateral commissure, the jet is going towards the interatrial septum. But what is the problem of this central jet and the non-cooptation of AML and PML? And that you get by the incremental value of 3D echo. And I'll show you the 3D echo closely, and you can see that there is not only that there is a prolapse of the P1 segment, but there is a big cleft there in the PML. That is between P1 and P2, you have got a big cleft. What I will do is I will stop the video there and I will go. I will show this cleft in the successive imaging frames 1, 2, 3, 4, 5. And this is the big cleft between the prolapsed P1 and the P2. So the prolapsed P1 was causing the lateral commissure incompetence, giving me the medially directed jet, and this cleft is giving me that central jet. I think with the interest of time, I think we are at 9:30 now. I think I'll stop it here because we can have 5 minutes of discussions, because I think we have this session till 9:35. Over to the chairpersons. Thank you.
Thank you, Dr. Nitin and Dr. Rishikesh, for an excellent view in a very short time of all the views. All 28 ACE views were there, and Dr. Rishikesh showed them well. And the discussion on the 5 cases was remarkable. Dr. Rishikesh, a small question to you. Very often the cardiac surgeon puts in a IABP, peri-op or immediate post-op, and this is an era of mechanical devices. When you have this circulatory device and a catheter has gone in, a guide wire has gone in from the femoral artery into the aorta, you showed very beautifully the aortic branches. Very often we've got to immediately and instantly show how short is the guide wire of the subclavian, and taking the views in the upper esophageal view at that time becomes slightly daunting to especially a novice. Can you explain that in a brief minute, if you could? That would be really helpful for the PGs, because this view is very often asked in the exams also.
Right. So for IABP, usually the IABP balloon has to be just below the left subclavian. So what you basically do, what you do is when you go at 0 degrees, just go posteriorly to a descending aorta. Okay, and once you reach to a descending aorta, that means you are cutting the descending aorta horizontally at 0 degrees. Okay, so you just keep on lifting the probe up. Now, arch of aorta when you reach, basically it will at 0 degree will be in the long axis. So naturally the circularness will go and it will come as
elliptical,
an oblong, elliptical. So once you reach there, now you have to cut, because the arteries are opening in longitudinal fashion. So you have to cut it in the vertical. So you have to increase the angle to 90 degrees. And initially you had rotated your probe from the heart towards it on the left side.
Now you go on the right side.
So to bring it back, you have to go through the again to the right side. So the point at which you see the opening of the left subclavian, that is the point. So your IABP balloon has to be below the opening of that left subclavian. So suppose if somebody has pushed it more inside, you just ask them to pull it down. Or if it is too low, you just ask him to pull. The optimal IABP balloon has to be just below the left subclavian. And that is the most important view. So I mean, that will really help to all the cardiac anesthetists guiding the IABP catheter in the OT.
Very rightly explained, because the echolucent guide wire is just the tip that you see, and very often it could be misplaced. Just small question to Dr. Nitin sir. When you showed the P2 prolapse in your 3D echo, it was a very beautiful P2 prolapse, and that is what we see most often. How incremental value do you give to 3D TE for the P2 prolapse? Because very often we are confused between the flailness and the prolapsing nature of the P2 segment.
Yeah, so you want to say the incremental value of
3D
yes. In the P2 prolapse, in the P2 prolapse, yeah, extraordinary incremental value of 3D, because what happens is that when there is a flail leaflet, okay, you can actually see the ruptured chordae coming into the left atrium, and because of the blooming effect of the 3D, actually the chordaes look quite big. Okay, so you really know that this is a ruptured chordae and this is a flail and not just a prolapse. Okay, however, on the 2D, when you see the edge of the leaflet, which is still which is inverted towards the left atrium, you know that this is definitely a flail thing. But if it is still pointing towards the LV, then this is basically the main body prolapse and not flailness. Correct? That is one thing. Secondly, we need this 3D view for getting the flail width, and that flail width is very important for the mitra clip. Okay, that is another thing. And thirdly, most important is, while we are guiding for a mitra clip, we need this 3D view to orient the mitra clip perfectly perpendicular to the AML and PML cooptation line. So that is how the 3D is extraordinarily important for mitral valve.
One thing which Yeah, one thing which I wanted to ask and tell the PG students is that what we saw today was a mannequin. And there is a huge bit of difference when we do it in a practical life. Once we are doing in operation theater and in live people in the clinic, we have two kinds of motions which are add-on. One is a respiration motion. Mannequins don't breathe. Even in operation theater and in the clinics, the person breathes, and that changes the cardiac structure and cell health. So we have to have practice for that. Second thing is, when we are doing in clinic, we also have the swallowing reflexes and hawking reflexes, which can change a lot of structures and aerophagy and all. So we cannot undermine the importance of having hands-on in real people time and again, and experience has no second thought about it, that better experience, more experience is something which will lead you to understand the views better. About what
exactly.
Dr.
I think I will add to that is that once you get trained on the mannequin, I think you practice in the OR where the patient is under deep sedation and there is no discomfort. I think OR is the best place to learn the transesophageal and transgastric views. Definitely, there is no way that there is any replacement for the real experience in a real time patient. And I think once you are good experience in OR, and then I think you try on the OPD patients who are not sedated and who are just on the local anesthesia, so you don't create a discomfort to the patient.
Can I have a small comment? A small thing. So, Nitin, we have been looking at the carotid IMT thickness by Doppler. So, any incremental value of looking at the aorta and having measuring the IMT, because we have started looking at the TE so nicely. What are your thoughts?
Yeah, I think the T gives exceptional views of the arch of aorta. I don't know about the IMT, but calcific plaques, ulcerated plaques, plaques with the clots on it, it's very common. And I'll tell you, many cryptogenic strokes which are sent to you for evaluating for a cardioembolic source or for the PFO, many of them you actually find large plaques in the arch of aorta, especially the distal portion of the arch of aorta. And you know the cause of it, and you know that the PFO is finally hypothetical. The main reason for getting those embola is from these ulcerated craters, and it is easy to find even in the patients in their 5th decade of life also to get that kind of plaques. And I think about the IMT, probably I'm not sure, but when you get the calcific plaque, you at least know that this patient deserves a DAPT after the stroke, okay, rather than hunting for that PFO and its all the hypothetical consequences.
Also, the thickness, Dr. Shantanu, when you do the epicardial T, it's very important under all aseptic conditions. You can put in an epicardial probe there. The surgeon does it on the epicardium of the aorta. You can know that if this is a thick and calcified thing, where would I put my aortic cross clamp? And that putting of the aortic cross clamp in the right position is what the T gives a very good view about, which you may not have, you would have missed out on the transthoracic. So T today is helping a lot. A small PFO can help you when you put in a catheter onto the right atrium for, let's say, an ECMO or a VAD. We are in that transplant area today. So when you put in a catheter, these catheters migrate through a small PFO from the right atrium to the left atrium, and your ECMO flows become very, overnight you'll see the ECMO failed and the patient dies, or a diffusion hypoxia happens. When something like this is happening, you do a TE, then you can see that small PFO with the color flow across the two atria. So that's, yeah. I think shortage of time, Dr. Sanjay Muttil and Dr. Shantanu, I would request you to give the concluding remarks and end this session. I thank all the speakers, both of them, and all of us who joined in the morning.
Dr. Mittal, you can go ahead.
Yeah, so the importance is that transesophageal echocardiography today is our third eye, the surgeon's third eye. It has lots and lots of information there and a cleaner working space while operating and also while not operating. Now, it's very important for transcatheter procedures also. So I think what has been explained beautifully is what are the basic structures, what are the basic views. We have to have no undermining of a great experience. As Dr. Nitin said very rightly, After mannequin, go to the operating room, stand there, fiddle around with the probe because you are less likely to have the Hawking reflex, and then after go to the clinics and do that. But it was a wonderful desperation, and I thank you to the speakers.
Thank you.
Okay, I think we are ready for the next presentation. As far as I can tell, none of the other chairpersons are here, so it is my privilege to introduce the 3 speakers in the next workshop, which will be on 3D echo, tips and tricks of 3D visualization, a practical approach to use in your lab. So Dr. Amuthan, Dr. Alagesan, and Dr. Balasubramaniam will be expounding on this topic. All 3 are masters of echo and 3D echo. So we look forward to hearing from them. Over to you, sirs.
Good morning to all of you. We had a nice workshop on transducer electrocardiography by Dr. Nitin and Dr. Rishikesh. After that, we'll go on to the next step, that 3-dimensional electrocardiography. So here, 3-dimensional electrocardiography gives additional incremental information after transthoracic echocardiography and also transesophageal echocardiography. To discuss about this, I'm going to invite Dr. Amudan, who is an expert in transesophageal echocardiographic 3D and also transthoracic echocardiographic 3D. He will describe the views, how to get the various structures, and what are the usefulness of 3-dimensional echocardiography in, say, valvular heart disease, in structural intervention, and also in measuring the volumes and strain imaging. Over to Dr. Amudan, please.
Thank you, sir, for your nice introduction. I first of all thank our father of echocardiography in India, Dr. Parashar, sir, and the organizer of this excellent conference, Mrs. Simi, for giving me this opportunity, and our team. And now, first of all, we have our second edition of the textbook of echocardiography by Indian Academy of Echocardiography. By this time, I think most of you would have received and will be receiving this from Sun Pharma. And now, coming to the main, the advancements in cardiac 3D echocardiography was only possible because of these developments in excellence in the instruments, technology, and probes. Now, we have advancement of the probe, and the most important advancement is the C-sound, which miniaturized this probe size into a very small one, and you compare the probes elements in the sparse array transducer, which is seen with the 2D transducer, and you have the dense real-time 3D echo requires more than 3000 piezoelectric elements. And the basics, coming to the basics, are very important. And first of all, you should have the 2D probe. This is called as the azimuthal plane or the x-axis. And then you have this y-axis, which is the axial plane. In what adds in 3D echocardiography is the third dimension, which is called as the z-axis. So you have azimuthal plane and axial plane x and y, and this is the elevation plane, that is the z-axis which comes. And the most important thing which we forgot is, unless you have a good echocardiography window and you adjust your time gain compensation, you don't get a good 3D echocardiography. This is very important. And another thing is that you should have a good adjust the dynamic range is the ratio between the largest and the smallest values that a certain quantity can assume, and a low dynamic range, you have to set it to low dynamic range. And second most important thing is use of the second harmonics. This is the second harmonics. Harmonic imaging most commonly uses the second harmonic frequency, which is twice the fundamental. This is the fundamental frequency. This is the second harmonics which you use. So these things are automatically part of the big equipment. So we can see here, this is the harmonic image, how it improves on the basal imaging technique, and we do the all the maneuvers which are common for 2D echocardiography in the 3D echo also. And the same views, the long axis views, the short axis views are the same. You acquire the same plane long axis view. Then you have the axial plane and the azimuthal plane. This is the axial plane and this is the azimuthal plane and this is the axial plane. And then you can add the third dimension to that, that is the elevation plane. Now you can do all these rotations and go for the short axis, or simply press this is the sweeping and other maneuvers which you do, this probe rotation by 60 degrees. And what 3D adds is multiplane imaging. This is called as a multiplane imaging. You start here. 3D is nothing but an extended view of the 2D. So you do the apical 4-chamber, just switch on multiplane imaging. Now you have orthogonally opposite to this view, that is 90 degrees opposite to that. So by cutting at different planes, this is the plane at the level of the aortic valve, or you can move it towards the center of the mitral valve, or you can move it towards the lateral valve. So you have 3 different cuts from the same thing, or you can just go in for the triplane imaging. This is called as the triplane imaging, where you have the basal imaging, then rotated imaging at the 60 degrees. You get the by 2-chamber view, and still more rotated at 120 degrees. You have the long axis view, and you can go for the 12 tomographic segments in addition to your 4-chamber, 2-chamber, and 3-chamber. From the apex to base, you have 9 other tomographic planes. Totally 12 tomographic segments are there. And you can see the difference of adding the software manipulation by so many technologies, the importance of development. And you see this is adding the translating. So you have the images which are much more improved in the 3D echocardiography compared to the previous settings. This is the standard 3D, and what we have is the newer technology which adds lighting and other maneuvers. So you see this, the clarity of the images are increased. I will show these things in the EchoPack demonstration at the later point of this lecture. And this is the first clinical experience with the 3-dimensional echocardiographic trans-illumination. So this standard imaging, and you see this file P2 and P3. This is P1, P2, P3. You can see at a much greater accuracy by adding these further trans-illumination and transparency software modification of this. So you start with the multiplane imaging, then go for the bird's eye view, and you can increase the elevation plane. This is 10 degrees. You can increase to 30, 60, so that you have the complete pyramidal view of this 3D tech. Now this is a zoomed view where you select a particular valve and then zoom it, and then you go for the full volume. So this is view, standard view from the left ventricular side. This is the surgeon's view from the left atrial side. You can have simultaneously. The most important purpose of 3D echocardiography is the LV systolic function, and you can do that very simply. And experts use the eyeballing method, but this is subjective, experience dependent, and lack of standardization. And universally, I find in India we use M mode, which is deployed by the American Society of Echocardiography and all over the world. This has to be stopped. You have to either use 2D echocardiography or 3D echocardiography for getting a more perfect ejection fraction. for getting a good left ventricular ejection fraction, the most important thing is you have to acquire the four chamber view, and very important point is that it should be LV centered apical four chamber view, not the standard apical four chamber which you see where the IV interventricular septum is in the center of this. Now you have to move it. This has to be LV centered apical four chamber plane, so that you get all the walls of the apical four chamber plane, and then you go for placing 2 points over the mitral valve level and at the apical level. Then you have the 3D apical four chamber ejection fraction calculation, which is done very easily. Now this is with another vendor. This is with the Philips, and you can see this is the older method which is done with the E33, and this is the hot model which they have now, which uses artificial intelligence hot model. This is done for both LV, LA and RV also. They have developed models. Now another important point is regional calculation of the regional valve motion abnormality, and the 2D tomographic slicing helps you in this to differentiate. This is the case of anterior valve infarction, where you can see the differential regional valve motion abnormality in the tomographic planes. The anterior valve compared to the other valve, the ejection fraction is reduced. This is a case of dilated cardiomyopathy where there is a global LV hypokinesia, you can see in a single setup. And again, this is used in stress echocardiography, where stress testing methods, you use a triplane view. It's very easy. You get only one view from the apex, triplane view, and calculate the GLS, I mean bullseye plot. So this is low dose dobutamine stress echo. This is high dose dobutamine stress echo, where you see in the bullseye there is reduced strain in the anterolateral and infralateral areas, and this disappears in the recovery phase. See that? So all these things are possible with a single image acquisition from the apical four chamber plane using the triplane imaging. So that is that. Second most important thing is calculation of ejection LV diastolic dysfunction, where you use the left atrial dimensions. This is the left atrial dimension. Now you have to acquire the LA focused apical four chamber view for LV function. LV focused apical four chamber. This is for LA focused apical four chamber plane, and you can see here the image has to be optimized, and the temporal resolution has to be adjusted. Then set landmarks, and then you go for the end diastolic, end systolic and pre-A marking in the setting, and then you go for the left atrial size, emptying fraction, left atrial strain. All these things are possible in a single setup, and the normal data are widely available. And similarly for calculation of the RV, you can see the RV cannot be assumed, imaged in a single plane from the apex, because the infundibulum has a different angle. This imaging acquisition is different. 3D adds to this in this by using these advanced 4D transducers. You record the RV focused apical four chamber, and then go for this with a frame rate of more than 35 seconds. Then go for this. You have to slightly go above and tilt it down, so that you have the RV focused apical four chamber view where the apex is seen. And you mark these markers, and then you have the RV volume, 3D RV volume, which is very simple. And universally we use only TAPC and other measurements, 2D measurements, but 3D correlates very well with the CMR. So coming to the cardiac valves, the multiplane method gives you, see here, this is long axis view, whereas in short axis view, in the simultaneous plane, you see double orifice mitral valve. double orifice mitral valve. And you can have the double orifice mitral valve in the 3D echocardiography. You just add. So similarly, you can see this from the LV side. This is from the LA side, and by this sort of imaging is possible. This is the surgeon's view for mitral valve. This is a surgeon's. I mean, you can have the similar view for the IT valve, and then go for the IT valve acquisition, and calibrations can be used to assess that. 3D is very universally used in transesophageal echocardiography to assess the various cardiac valves, and two-click crop is used for this. This multi-panel reconstructions are useful, and this is the 3D TE anatomy, which just now Dr. Nitin was demonstrating to you, and 3D TE anatomy is very helpful to identify the scallops. And similarly, you can see the tricuspid valve. This is the entry atrial septum. This is the tricuspid valve. This has to be rotated 120 degrees so that the entry atrial septum is at 6 o'clock position. And now you have the anterior tricuspid leaflet and other leaflets. All the three leaflets are seen beautifully in this. This is the ID valve where you have the acquisition, and the calculation of the aortic annular diameter and areas can be done very easily. And similarly, pulmonary valve can be acquired. You can see here, this is the short axis at the mitral valve level from the transesophageal echocardiography. This pulmonary valve is seen. Just place 2 points here, one here and one here. This is called as two-click crop, and you have the 3D echocardiographic view of pulmonary valve. So these are the various views of mitral. I will just show, close this and show the cases, one or two cases. So how do you do that? Just adjust the size of this image so that this is from the echo pack. This is a case of this is a young gentleman who came from returned from United States, age around 50 years. The general physician, family physician there has done CT score directly, and this patient had a high CT score. And I will just demonstrate how do you do the LV quantification here. You go to volume and select LVQ. Yes. Align views, second end diastolic volume. Just place 2 points. I think this is much more easier than the M mode which you do regularly. And then adjust the borders if you want to adjust, and then select end systolic volume here. This is the volume waveforms which you get, and the ejection fraction calculation comes there immediately, 66%. And you can see the volume forms. So this is a very easy method of calculation of the left ventricular ejection fraction, and similarly you can calculate the I just show how do you calculate the LA volume. Just there is one adjustment here. Adjust the mitral valve center here, and then you have to set landmarks. Go for review. Most of the modern equipments have anatomical intelligence where only a minimal adjustments is needed. So you adjust the borders. This is the end diastole, and similarly you can set the end systole. This is end systole, and then go for the results. So now you have the left atrial volume 53 ml, and you have the strain minus 13%. So this patient with high CT score and low LA strain has a high risk and has to undergo regular coronary angiogram. So these things are possible. Decisions making can be easier. I will just show one or two cases of valves. See, this is a 70-year-old lady where you can see here there is a large calcification. You can see that large calcification is there, and this is a current 3D imaging which is called as trans illumination or fluxy light. This is by fluxy light with advanced instrumentation, where you can see add colors so that the calcification size and the nodule size can be easily adjusted, and you can see that. And similarly, this trans illumination is also used to assess the presence of mitral regurgitation and advanced techniques. So I conclude with this advanced techniques, and as this is a workshop, I try to show you some of the cases. Is there time, sir?
Yes. There is 8 minutes. We'll have discussion for the 8 minutes.
I will request our Dr. Balasubramanian to present a case.
Yes. Balu, if he has any case, he can present. Dr. Balasubramanian?
Yes, sir.
Present your case.
Yes, sir.
Present your case.
Good morning, sir. First of all, I thank Dr. Parashar and Dr. Amudan, sir, for giving this opportunity. This is the case of left atrial myxoma. Recently, we have seen in our department. He's a 39-year-old gentleman. He was working in Malaysia, and he was having breathlessness for the past 8 months. Presently, he's in NOH class 3, and he had syncopal attacks of for the past 4 months. On clinical examination, there was nothing significant, and he was sent to our department for routine cardiac evaluation. This is our 2D echocardiograph showing a large mass in the left atrium. This is the parasternal long axis view showing a large mass in the left atrium. This is a homogeneous mass that is prolapsing into the LV. This is short axis view. The apical four-chamber view showing a mass attached to the IAS that is prolapsing into the left ventricle. And it shows smoother surface, and at certain points it shows some villus-like structures in the borders. This is the apical two-chamber view. This is the transthoracic three-dimensional echo showing a mass in the LA that is prolapsing into the LV through the mitral valve. This is the transesophageal echo. This is the 0 degree four-chamber view. This is the mass in the LA, which is a pedunculated mass. It is attached to the IAS. It is seen here, and is prolapsing into the LV cavity. You can very well seen here. This is the three-plane view where we cut the full wall in 60-degree angles. This is the four-chamber. This is the two-chamber. This is the three-chamber view. The mass is nearly homogeneous mass. This is another view, 3D, transesophageal echo. We are focused the LA appendage. There is no thrombus inside the LA appendage. As he was having a recurrent palpitation, we are suspecting probably intermittent atrial fibrillation. Recently, he was in sinus rhythm only. And this is the mass that is seen in the LA that is protruding, collapsing into the LV cavity. Again, we can see in the four-chamber view, you can see the peduncle over the IAS here. It is attached here. This is the right atrial side of IAS. It shows that this is the IAS, and it is there is some patency of the foramen ovale. You can see the mass seen through this opening. This is the LA cavity where you can see the mass inside the LA. This color flow imaging across the mitral valve. There's no significant MR. The appendage is also free of thrombus. And this is the aortic valve view. This is short axis, this is the long axis, and the aortic valve is normal. This is the mass that is prolapsing into the LV cavity. And I got done stain imaging shows some wall motion abnormality, the IVS.
Thank you, Dr. Balasubramanian.
Thank you, sir. And
Nice case.
we have planned for coronary angiogram and showed some wall motion abnormality. Probably there may be a embolic occlusion of some coronary arteries. Sir.
Thank you.
Thank you, sir.
If any of the panelists have any questions to Dr. Amudan, Dr. Samitra Kumar, Vivek, have any questions to the...
Yeah, good morning. Yeah, Dr. Tandon, please carry on. I'm sorry, I joined late because of some technical problems.
But always welcome, sir. Always
Thank
welcome,
you.
sir. Dr. Balasubramanian, I have a question for you. You showed a very nicely demonstrated left atrial myxoma. But what additional information did 3D give you that you could not have got from 2D in this case, this particular case?
This case, we wanted to do a T examination, T evaluation for the LA appendix, sir. Because he was having a history of recurrent palpitation, but there is no documented atrial fibrillation. We want to rule out LA thrombus.
Okay, no, but how did 3D help in this particular case? LA appendage we can look at in 2D transesophageal also.
Yeah.
So what additional value did we get from using 3D? Because this is a workshop on 3D basically.
Okay.
So what was the additional value of 3D in this particular case?
Not much added information apart from routine TEs.
Okay,
Yeah.
okay, sir. So Dr. Muthan, would you care to comment on how 3D could have helped or did help in this particular case?
The peduncular attachments, whether it is single, double, you can just rotate. It is just like a dissection. Where all the other additional attachments are there, and you can view from RA side also, so that it is pushing into the intra-atrial septum. So if there is a damage to the intra-atrial septum, you have a 3D live view. This live view is not possible in 2D. The live view of the intra-atrial septum and foramen ovale, all these things can be seen in 3D. That's what Professor Balasubramanian has demonstrated, that it is hinging on that. That was not seen in the 2D.
Yes, the PFO was very nicely demonstrated, and the view of the mass through the PFO, that was a very intriguing view.
Also the nature of the sessility, the pedicle, as Dr. Amuthan pointed out, whether it's a sessile mass or a pediculated mass, and where is the pedicle coming from, that helps the surgeon a lot more. That's something.
Yes. I have a question for Dr. Amuthan. So we have 3D volume the left ventricle by biplate Simpson method, and we can also get the measurement of the LV volume by 3-dimensional echocardiographic method, and also by artificial intelligence you can get the say volume model. How much is the difference between these three modalities, and which one is has the artificial intelligence graduated to a good degree, so that we can rely on the volume obtained by the artificial intelligence?
Thank you, sir. It is a professional question asked by the super cardiologist, echocardiographer, father of echo in Tamil Nadu. Now, answer becomes difficult at that point. Now, simply you can say that M mode should never be done. So that's the point which we are clear. Second point, in 2-dimensional echocardiography, we are seeing only 2 planes. The third additional point is not there. So the correlation with CMR is a little bit not correlating. So that is the important point. Whereas 3D echo correlates very well with the CMR. So repeatedly you will not send the patient to CMR. It's a very costly investigation. You cannot do that. So when a patient has a LV aneurysm and a bulge on that side, that cannot be picked up by the 2D. And then coming to the artificial intelligence, this question was again asked during the Cardiology Society of India Echo session. The artificial intelligence is good, but you have to trim the borders. So it's very, very important. See, I do routinely in both the vendors' techniques. The borders have to be adjusted. See, in artificial intelligence, they select the borders, but these borders may not correlate with the actual borders at certain points. So that may lead to deviation. So the superhuman, the brain has to correct that. So artificial intelligence is there. It is a very good technique. It helps you. So you have to correct the borders where it is going beyond. Just I showed you the LA volume. LA volume, it was going again at a different point. You have to make a correction. So that has to be done by a professional echocardiographer. So ultimately it comes to the professionality and the superiority of the human touch rather than the artificial intelligence. Thank you, sir.
Yeah, I would like to ask a question. I mean, a slightly a different one. We are talking of additional information being provided by 3D echo. So this TAVI is becoming very commonplace now. So as far as the estimation, I mean, the analysis of the aortic root at the annulus is concerned, we still rely on the CT. So can 3D, has it reached that stage where it can replace CT for assessment of the aortic annulus and the root?
Sir, it has not come to the stage of replacing, but it helps. So when the interventional cardiologist does the TAVR procedure in the cath lab, the valve may sit in different positions, may not be accurately sitting. So this can be assessed. Prior to that, yesterday Professor Lang was showing where the artificial intelligence helps. So he can actually place the device which you are going to locate. It can be seated and you can see that prior to the technique. So by CT you select the valve, but this can be placed over the actual measurements and you can see actually. And the second point, the whether the seating is correct or not, and the TAVR leak of the valve can be assessed on the spot. If it is less than 7%, it's well and good. You can leave it like that. If it is around 7 to 14%, you have to make a correction. If it is more than 17%, the leak, you have to change the valve. So this decision can be done on the spot only with the use of echocardiography. So interventional cardiologist relies on echocardiographer in the cath lab. Thank you, sir.
Dr. Muthan, actually, to interrupt
the
you,
time is
sir.
up.
Since we are running short of time, I would request if you could sum up in next 30 seconds.
Dr. Muthan, I think it's value of the 3D TEA, particularly during the procedure, particularly TAVR as well as the mitral clip, is very, very important. And there is without the 3D, without the TE, without the transitional echo, we can't imagine it can be done. TAVR, we are doing it without any TE now, but I think 50% of the cases still require some help of the TE during the procedure. Where actually speaking, this is if we have a TE, the interventionist is much more comfortable because we can recognize any complication occurring during the valve shifts or any you cover the coronary. All this can be avoided if we are having a TE in place.
So since we are already out of time, I think I'll just thank all the speakers and the presenters for doing a wonderful job and an interesting discussion from the panelists and my co-chairs. Thank you all very much.
Thank you, sir.
Thank you. Thank you.
Wonderful discussions by all our speakers and very well moderated by our chairpersons. Thank you, everyone. Before moving on to the next session, I would request everyone to please switch on your cameras for an E-group photograph. Maybe let's have an E-group photograph. Great.
You can have a gallery view so that everybody will be seen.
Absolutely, sir. Just a moment. So let's say cheese. Great. All right. Thank you, gentlemen.
Thank you.
Moving on to the next session, I would like to invite our chairpersons, Dr. K.K. Kapoor, Dr. Sunil Bhora, Dr. Rekha Mishra, and Dr. Vanita. And as the speaker, I would like to invite Dr. Manish Bansal and Dr. Hardeep Grewal, and their talk is subjected on strain imaging. What is it, why we do it, and how to acquire and interrupt pitfalls and how to avoid them. Over to you, sir.
Good evening, everyone. I welcome Dr. Manish and Dr. Hardeep Grewal to start their session. Thank you, sir. Dr. Manish, you have to unmute yourself.
Good morning, everyone. It is indeed a great pleasure for us to do this workshop here for IA Delhi chapter annual meeting. So as we know, strain imaging has become an integral part of echocardiography today over the last 15-20 years. And now in the present era, it is impossible to do a good echo study if we don't have the basic understanding of strain imaging, why we do it, how we do it, and what its clinical applications are. So over the next 35 to 40 minutes, we will quickly go over how to do LV strain imaging, LA strain imaging, and RV strain imaging. And for this, I invite my colleague, Dr. Hardeep Grewal, to first discuss the basics of strain imaging. I will then show how to do it, and then we will briefly discuss its common clinical applications. Hardeep. Yes, Hardeep. You need to share your screen. Yes.
Good morning, everyone. Am I audible to everybody?
Yes, very much. Please go ahead.
You are.
Today we are going to discuss about strain imaging. I think before we discuss what is strain imaging, it is very important to discuss that why do we need to talk about strain imaging? So to understand that why strain imaging, I'm going to show this case. So this is a patient who had severe aortic stenosis, and these are apical images, and we can see that this patient has significant left ventricle hypertrophy. And from these images, we know that this patient, LV myocardial contractility appears to be reasonable. It is LV seems to be a pair contracting well. So when we estimated LV ejection fraction in this patient, this is 79%. So which is actually not normal, actually supernormal. So does this mean that this patient has normal LV myocardial systolic function as well? So when we calculated GLS in this patient, that is minus 10%, which is markedly reduced. So which indicates that this patient has myocardial dysfunction. Now, if we look at the number on LVEF, which is 79%, we would not appreciate this myocardial dysfunction, which is evident on strain imaging as shown by GLS of minus 10%. So why this happens, that that patient has myocardial dysfunction despite having normal LV ejection fraction number? So there are many limitations.
Dr. Hardeep can switch off the video, maybe.
I think some connectivity issue at her end. So if she's not able to join, I think I'll have the PowerPoint shared from my side and I'll do the presentation. Please allow me just a second. Yeah, Hardeep, you're there. So you switch off your video and then do the presentation. It will be better. Just switch off your video. I'm stopping my screen share. Yes. Now share screen now. Yes, we can see the slides.
Okay.
Perfect.
So LV ejection fraction is not a direct measure of myocardial contractile function. It is indirect measure of myocardial contractile function, because LV ejection fraction is just a ratio of LV systolic volume to and LV end diastolic volume. And this becomes especially relevant in the presence of LV hypertrophy, where LV end diastolic volume reduces. So because LV end diastolic volume is in the denominator, so if there is reduced LV end diastolic volume, we tend to overestimate LV ejection fraction. Another thing is that LV ejection fraction is a global measure of LV function. So it is not sensitive enough to detect subtle changes in the LV systolic function. So the LV ejection fraction drops when there is already a significant amount of myocardial damage has occurred. So we need a parameter which is more sensitive than LVEF and which can detect myocardial dysfunction at a very early stage. So here comes the role of strain imaging. So what is strain? Strain is actually literally it means change in the shape. And in echo, it means the percentage change in the length of the myocardial segment during any phase of cardiac cycle. So if strain, if this is a hypothetical example, if the myocardial segment is of 10 centimeter at baseline, and if it reduces to 8 centimeter, this means that there's a 20% shortening. And because the length has reduced, so we will say it is minus 20%. And if the myocardial segment increases in length, for example, from 10 to 12 centimeters, so there's a 20% lengthening, but because it has increased, so it is plus 20%. So the process, but that is why we need to measure LV strain to have better idea about the myocardial systolic function. Now, it is not that simple. There is a challenge, because the LV myocardial contraction is not a very straightforward process. It does not contract in length. It does not contract in one dimension. It is a multi-dimensional deformation. There's a change in the shape of the myocardial fiber in all dimensions. There is a shortening along its long axis, there's shortening of the circumference, and there is a increase in the thickness in the radial direction. And not just this, it also twists along its long axis during contraction, which is known as torsion. So with the help of strain imaging, we can measure all these components of the myocardial contraction. However, I would like to emphasize that the measurement of longitudinal strain is the most commonly used parameter and is the most recommended and validated parameter, because this is longitudinal strain is usually the first one to get impaired in most of the diseases. So there are two ways to measure strain imaging. One is a Doppler-based technique, which is in which we derive strain from tissue Doppler. However, we know that Doppler is highly angle dependent, so same limitations apply to this strain which is derived from tissue Doppler imaging. So that is why it is not very commonly used. But there's another technique which is grayscale based technique, that is speckle tracking echocardiography. Now, this is the technique which is by far the most commonly used technique. And now, what is speckle tracking echocardiography? Now, here we can see that this is a grayscale image, and we all know that grayscale image is composed of speckles. And these are the speckles. Speckles are actually generated by the scattering of the ultrasound beam by the tissues. Now, machine has this software of speckle tracking, with the help of which it can identify these speckles in the grayscale and then can identify the motion of these speckles frame by frame during each cardiac cycle. So by tracking the motion of these speckles, the software can calculate that in which direction the speckles are moving. So it can calculate the deformation of the myocardium or the contraction of the myocardium in all different components, in longitudinal, circumferential, and radial components. So with the help of this, we get all these strain curves once the data is analyzed by this speckle tracking. So next comes that how do we do it, which is the most important part of this workshop. So from here, I would like to hand over to Dr. Bansal for further elaboration.
Yeah, thank you, Rajeev. So you'll have to unshare your screen. So we've discussed why strain imaging needs to be done and what it means. I will now demonstrate how to do strain imaging for LV. We'll talk of longitudinal strain and then RV and left atrium. So we are discussing speckle tracking echocardiography, which is grayscale based strain. So for this, we need only grayscale images, no Doppler, no color Doppler, no tissue Doppler. Nothing is needed, only good quality grayscale images. So whether we are doing strain imaging of LV or left atrium or RV, the basic requirements are that we need to have good quality grayscale images. There should not be any foreshortening. There should be good endocardial border delineation, no artifacts. And importantly, all these images should be ECG gated with minimum 3 cardiacs. The reason why we want 3 cardiac cycles is that if we have 3, then at least one central cardiac cycle will be complete. There will not be any truncation at the beginning or end. So we get one full cardiac cycle, and that's why we want to record 3 cardiac cycles for each view. So for LV longitudinal strain, we need 3 images. That is apical long axis view, which is what we are seeing here, then apical 4-chamber view and apical 2-chamber view. Once we have these images, we need to go to speckle tracking software. So different machines have different controls for doing this, but the basic principle is same, and that is what I'm going to show here. So this is GE software. In GE, we have these options: AFI. AFI means automated function imaging, which is the term that they use for speckle tracking. They also have specific software for RV and LA. So we go to AFI. Now their latest generation system automatically detects the appropriate images. It will automatically identify this is 3-chamber, 2-chamber, and 4-chamber, and do the tracking also. But most of the people do not have this version of the software. So I'll show you the 3-click method, which is available in the machines. So here we open the image. We have to put 3 markers. One is on the base of posterior wall. The second is anterior septum base, and third is on the apex near the endocardium. And we allow the software to track the to detect the speckles and generate this ROI, region of interest. Now, once this ROI is generated, we have to make sure that it is of sufficient thickness to cover the whole of the myocardium, but it should not be too thick to go into the pericardium, because pericardium is relatively fixed structure, and if we include pericardium, we will be underestimating strain. Now, we also need to make sure that these pointers at the base do not go into the left atrium or aortic root respectively, and this ROI should be following the contour of the LV. Once we are satisfied with this, we process this analysis. Okay, so now the software has done this tracking. Once this is done, we have to see this moving image to make sure that this tracking is following the actual myocardial motion. There should not be any discrepancy. If you are satisfied with this, we look at this lower part. Here we have numbers for each segment. And for each view, the software divides this entire circumference into 6 segments and then calculates strain separately for these segments. So if the software is not happy with tracking quality, it will not give you any number. It will put a cross mark here. In that case, we can manually check whether tracking is good or not, and then we can override it by clicking here. So here the tracking seems to be perfect. all the numbers are there. These are different strain curves. I'm satisfied with this, so I will accept it and go to the next view. So now it says you select the image. Let us go to this. You can select either 4-chamber or 2-chamber. I have picked 4-chamber, and these software is automatically identified that this is 4-chamber view into the LV cavity. I will make some minor adjustments and process it. Okay, now again tracking is done, and tracking seems to be satisfactory. Software is also happy. It has generated strain numbers for all the segments. So we accept it and go to the next. Okay, now we have to select the 2-chamber view. So here is 2-chamber. So for 2-chamber also, the software has automatically done created this ROI and done segmentation. But as I said, if we don't have this option, we can go to 3-click method, which will again require us to put 2 markers at the base and third one at the apex, and then we process it. Okay, now here the software, the tracking seems to be of good quality. This ROI is moving with the myocardium, but no number are mentioned here, which means that the software is not satisfied with the quality of tracking here. Maybe because of inadequate number of speckles, or maybe because of artifacts. For this, we can decide in each individual case. Here I'm accepting the tracking, so I'm clicking this, and then we have done tracking of all the three views. So we can now generate the bullseye. This is the summary of peak systolic strain of all the segments. This number in center is the four apical segments averaged. This is the value that we are interested in, GLS minus 17%. Normal value is close to around 20%. Less than 15, 16 is definitely abnormal. Minus 17 would be in the range of, is borderline, may or may not be normal. The software also gives us strain for all the three views separately, but the most important value is this. Now, not only GLS value is important, this bullseye pattern also gives us a lot of information, as we are going to discuss. In some cardiomyopathies, we may find apical sparing. In some, we may have impairment of some other segments. If there is MI, we will have impairment of strain belonging to a particular coronary vascular territory, and so on. So looking at the bullseye pattern is also very important. So this is about LV GLS. I'm not going to go into other components of LV strain because they are not that useful for routine clinical practice. Instead of that, we'll go to RV strain because that is what is more important. Okay, so for RV strain, we have to have RV focused 4-chamber view. In the conventional 4-chamber view, if you do RV strain imaging, we will be underestimating strain. So that is what we need to remember. We should always use RV focused 4-chamber view, and this was explained by Dr. Amuthan also in his workshop. What it means, basically we have to go more lateral from the LV apical position and extreme lateral, and then we get this RV focused apical 4-chamber view in which we are able to see the whole length of the RV. So here, now the latest generation of speckle tracking softwares have option for RV strain imaging separately, but if we do not have that option, we can use LV strain software, and we can treat this as LV view. We can put 3 markers here. This we assume as septum, and this we assume as lateral wall, and then basically we trick the software to get LV strain. But if we have dedicated software, it becomes very easy. The basic principle remains same. We need good quality grayscale image. Here we have to use 3-click method, 2 pointers at base and third one at the apex. So again, we have to make sure that it is following the contour of the myocardium. The thickness should not be too less or too much. It should just be sufficient to cover the myocardium. Once we have created this, we process it. Okay, look at the tracking quality. This seems to be tracking well, so I will accept it. Once we accept the measurements, we get strain values for all the 6 segments. Now, RV, we are interested mainly in the RV pre-wall. So we need to take the average of these 3 segments. If we are using LV strain software, then we can simply exclude these. If we exclude this, then only 3 segments are left, and we can take this average here. So this white line is average. So peak strain would be 5%. But in the software that I use, this software itself calculates RV pre-wall strain separately. As you can see here, this is pre-wall strain minus 27% and global RV strain minus 22%. The global RV strain includes septum, which is part of LV also. So we don't use it. We look at only RV pre-wall strain, which is usually higher than global strain. So here it is minus 27%. Anything more negative than minus 25% is considered to be normal. Minus 20% is definitely abnormal for right ventricle. And then we go to LA strain, because LA strain is also becoming increasingly useful in day-to-day clinical practice. So for LA strain, we ideally need 2 views, apical 4-chamber and 2-chamber views. But if we have only apical 4-chamber, then also we can manage. But important thing is that this should be LA focused view, in which we should be able to see the whole length of the left atrium. And this may require foreshortening of the LV, because LV and LA are not in the same plane. So once we get proper LA 4-chamber view, then we go to the same AFI. In many equipments, we don't have a dedicated option for LA strain imaging, so they have to use the same LV strain software and trick it to measure LA strain. But if we have dedicated software for LA, then it will make our task much easier. So I select it. And this is 4-chamber view. I have told the software that this is 4-chamber. Now we have to put 3 markers: septum base, lateral wall base, and LA roof. Once we do that, it will create an ROI. Now we have to make sure that this ROI follows the contour of the LA wall. We should not enter into the pulmonary veins or left atrial appendage. Also, because LA wall is thinner than LV or RV walls, we need thinner ROI. The recommended thickness is roughly 3 millimeters. So we can manually look at this, and we need to make sure that it is not to include pericardium. Once we have done that, we allow the software to process signal. So it has processed and it has generated this strain curve. Now, LA strain curve will vary depending on what is the initial reference point. If we start from QRS, we will get a different kind of LA strain curve. If we start with P wave, we will get a different kind of strain curve. In routine practice, we have been using nowadays QRS based method because it is simpler to interpret. Compared to this, P wave based method does not add any incremental value. So we are not talking about this, and this is easier to perform and interpret. So if we look at strain curve that we have derived using QRS based method, so what happens is that when the QRS begins, that is the end of ventricular systole, left atrium is at its smallest size because it has emptied into the left ventricle. From here, when the ventricle contracts, mitral valve is closed, LA gets filled from pulmonary veins, so LA size increases, and therefore we get stretching of the LA wall resulting in positive strain. So strain value increases till the end of ventricular systole when the mitral valve opens, and once mitral valve opens, there is sudden reduction in LA size, so we have this strain curve coming back towards the baseline. Then once the initial filling is over, then we have a phase of diastasis during which LA size does not change, so we have this plateau, which is followed by another negative wave because of atrial contraction. So we can measure three points here. This peak, which is known as LA reservoir strain, is the most important measurement, and this is for all practical purposes LA strain. Here it is 42%. Anything more than minus 30, more than 35% is normal, and less than 25% is definitely abnormal. This value here will be contractile strain, because this occurs because of LA contraction, and the difference between two will be conduit strain. So because these two values are negative, in these two cases LA is contracting, so these are negative. So we have contractile strain minus 13%, conduit strain minus 29%, and addition of these two will yield 42% as the reservoir strain or LA strain. So this is all I wanted to show. There are so many other things about strain imaging, but because of the paucity of time, we'll not discuss or go into those things. And now we will talk about some common applications of strain imaging. Hardeep, you can share your screen again.
So, what are the situations where we would like to use strain imaging? So we need to understand that reduced GLS has two meanings. One, that it indicates that prognosis is worse, and secondly, it tells us that the prognosis is worse, and secondly, it tells us that there is evidence of myocardial dysfunction. So in any cardiac condition, if GLS is reduced, it indicates worse prognosis. So there are two main reasons that we use strain imaging. That is to detect early myocardial dysfunction, and second, to prognosticate. So there are many scenarios where GLS estimation is useful, and we will briefly discuss some important ones. Now, this is the most common scenario in which we use GLS, that is patients who are receiving chemotherapeutic agents. Now, there are certain chemotherapeutic agents like anthracycline and trastuzumab, which are notorious to cause cardiotoxicity. Strain can help in early detection of myocardial dysfunction in patients who are receiving these chemotherapeutic agents, and so that a timely action can be taken either by starting cardioprotective therapy in those patients or by changing the regime, chemotherapy regime in those patients. Now, for this 15%, more than 15% fall in GLS from baseline is considered significant. Now here I would like to give an example. Now this is a patient, a 48-year-old patient. She had CA breast and she had received epirubicin in past, and now she was receiving trastuzumab. So her baseline echo LVEF was normal, GLS was minus 22.2%. So after 3 months, while she was still receiving trastuzumab, LVEF was within normal range. However, there was a drop in GLS, and this drop was more than 15%. So we started this patient on beta blockers, and over a period of time, eventually GLS improved, and she could continue her chemotherapy without any problem. So for these reasons, even guidelines recommend that routine measure of GLS in patients who are receiving chemotherapeutic agents should be done. Now, another scenario is patients who have valvular heart disease. Now, as we all know that patients who undergo, who have aortic stenosis or aortic regurgitation or mitral regurgitation, the fall in LVEF is class 1 indication for intervention. But there is a lot of data which has shown that if we are just waiting for LVEF to fall, that may not be a best thing to do, and because it occurs very late in the natural course of illness. So, this is a study which was published 4 years back, 294 patients with severe aortic stenosis, and investigators found that patients who had reduced LVEF, they had significantly higher mortality compared to those who had normal LVEF and relatively preserved GLS. But if we look at patients patients with normal LVEF but impaired GLS, we can see that they had almost similar mortality as patients who had reduced GLS. So there are many studies which have shown that GLS is a good predictor of events in these patients, and in aortic stenosis, about 14 to 15% cutoff of GLS is the value below which mortality increases suddenly. So we have similar findings in AR, in patients of AR and MR also. However, unlike aortic stenosis, in patients with AR, the inflection point is around minus 19%, beyond which the mortality increases. And it has been shown that that if GLS is preserved, then it really does not matter whether the patients are managed conservatively and surgically, but increased mortality has been increased mortality has been seen in patients with reduced GLS when they are treated conservatively. And same finding has been observed in patients with mitral regurgitation also. If the GLS is preserved, then surgery versus no surgery have similar outcomes. However, if GLS reduces, then there is increase in mortality. Now, in mitral regurgitation, the inflection point occurs at minus 21%. Another very common subset where we use GLS is in patients who have cardiomyopathies. Now, in cardiomyopathies, we know that if the GLS is reduced, that indicates myocardial dysfunction and also indicates poor prognosis. Now, with the help of GLS, we can also differentiate between different subsets of LV hypertrophy. For example, impaired GLS can differentiate between patients of patients who have hypertrophic cardiomyopathy versus those who do not who have athlete's heart. So we can see that strain is markedly reduced in HCM, whereas in athlete's heart, the strain is completely normal. Now, apart from this, strain imaging can also help in diagnosing specific forms of cardiomyopathy. Like in cardiac amyloidosis, we can see that the strain is markedly reduced, but there is LV apical sparing. Whereas if patients who have apical hypertrophic cardiomyopathy, we can see that there's marked reduction in the strain at LV apex. So another subset is patients who have heart failure. Now, in patients, in cases of HFpEF, reduced GLS helps in making the diagnosis of HFpEF because it confirms that there is a myocardial disease. And this is the reason that GLS is included in recently proposed European Society algorithm for diagnosing HFpEF. And not only this, like in many other conditions, reduced GLS is a marker of prognosis and can help in selecting appropriate therapies. For example, there is some evidence that HFpEF patients with reduced GLS, they can benefit from beta blockers. And even in patients with HFrEF, where LV dysfunction in the form of reduced LVEF is the main problem, GLS has an incremental value. Patients who have lower GLS, they have higher mortality compared to patients with same LVEF but better GLS. Now, in patients who have as far as coronary artery disease is concerned, strain has been used for a number of different purposes in patients with CAD. But here we will have to use the segmental strain rather than global strain. So, however, it is important to remember that segmental strain is not reproducible. So, as of now, it is not recommended for routine use. Now, another important utility of strain is for chambers like right ventricle and left atrium, because we don't have any good measure of contractile function for these chambers. So in case of right ventricle, we can use strain for any disease where we want to assess RV function. For example, in patients with pulmonary hypertension, ARVC, RVMI, or also in patients who have undergone TOF surgery and we are following them up for development of any RV systolic dysfunction. Then patients, LA strain can also be very useful, especially for, it's a good measure of LV diastolic dysfunction, and it is also a good predictor of AF occurrence, and also predicts the chances of AF recurrence in patients who undergo radiofrequency ablation or who undergoes cardioversion. Thank you.
Thank you so much. I think this was in very brief why we should do strain imaging, how we do it, and what its common clinical applications are. And we can now take some questions if we have time.
Thank you, Dr. Manish and Dr. Hardeep. It was a very lucid presentation on the basics of strain imaging and their indications especially. I don't think there's any question in the chat box, but I had one query. We have a lot of cardiac anesthetists who do routine echo. So is there any role or any guidelines wherein TE-based strain imaging can be done, or is it validated? Can it be done?
No, there are studies in which TE-based strain has been used for a variety of indications, but I don't think it's been validated in any large study. However, the basic principles are same. 2D strain that we described is totally angle dependent. So if we can obtain images from any modality, and we can do strain imaging, and the same indications will apply there also if in the operating room they are of any consequence. That is the more important question: how much incremental value of strain will have in the operating room or in a critically ill patient. So if it has a value, it can be used.
Oh. Yes, we have done this, and right now we finished some 200 patients on LA strain imaging for diastolic dysfunction, and our results are showing very promising results. Anything above or minus 2025 is a very big harbinger for the development of atrial fibrillation, particularly in valvular heart disease patients. So you have a patient with a controlled ventricular rate coming for an AVR or a mitral valve replacement, and suddenly you see that the strain goes up to higher values than 25. We are seeing that the diastolic dysfunction on coming off bypass is really bad, and we need to step up our inotropes in such patients. So it has a lot of value in the TE peri-op period, especially the LA strain, which was so underused and underutilized earlier. We didn't know how to do it, but with the coming of better imaging and strain, especially with the DG strain imaging with Vivid 95, has shown very good results. And this is where we are today, at least at AIMS. I can say that RV strain, LA strain, and LV strain is something that we do on most of our valve patients who are coming for redo surgeries or redo cabbages as well.
Thank you, ma'am. If there are no more questions, in the interest of time, we'll end the session. But here I would like to insist that those who are looking forward to do strain imaging and those who are very much interested, you have to do it routinely. So if you don't do it routinely, then you will miss the bus. So practice makes one perfect. So I would suggest everyone whoever is watching this to use strain imaging on a routine basis, at least in chemotherapy patients, cardiomyopathy patients, and the valvular heart disease patients. Thank you, Dr. Manish and Dr. Hardeep. And I also thank all my co-chairs for chairing this session. So we'll
Thank you so much. Thank you.
By Dr. Sunil Gora, and fantastic presentations by all our speakers and fantastically moderated by our chairs. So again, before moving on to the next session, I would request everyone to please switch on your cameras. Let's take a quick group photograph. If we could have Dr. Alagasan, Dr. Hardeep, Dr. Rekha to please switch on their cameras. All right, Dr. Singh. Wonderful. I see a beautiful background behind Dr. Saji Philip. Great. All right, we have almost everyone. So let's hear it for all our speakers and our moderators for this session. Amazing. Thank you. Thank you, ladies and gentlemen, for the wonderful session. Moving on to the next session, which is session 10, cases presentation in congenital heart diseases. I would take the honor to invite our chairpersons, Dr. K.S. Iyer, Dr. I.B. Vijayalakshmi, Dr. Sivakumar, and Dr. Saji Philip. Welcome, sir. I would now quickly hand over to our chairpersons to invite the speakers.
Good afternoon, everybody. Dr. Iyer is not to be seen. Is he there? And Dr. Iyer and Shiva. Dr. Iyer is a pioneer and he's a doyen in pediatric cardiac surgery, and he's a well-known person. And Shiva is a young, energetic pediatric cardiologist from Madras Medical Mission. I think they will join us. And in the meantime, we have Saji Philip from Kerala and myself. So we call upon the first speaker, that is Dr. Munish Tomar, my good friend. And Munish is going to speak about Ull's anomaly, an uncommon cause of right heart failure. Munish, please.
Thank you, ma'am. Very good morning to
looking
everybody.
lovely, and welcome.
Thank you. My screen is visible?
Yes. You're also looking beautiful, and screen is also nice.
Thank you, ma'am. And thank you, Echocon, for inviting me and giving this opportunity to speak on this academic platform. Without wasting time, I am moving towards my presentation. So this is a 10-year-old girl of average weight, but according to parents was apparently well till 1 year ago. And when she started more of the GI symptoms like poor appetite, vomiting, abdominal distension, pedal edema, and periorbital puffiness in the course of the time. With these complaints, she was taken to gastroenterologist, and after blood investigation, first test was done was endoscopy. So endoscopy showed some gastritis and thing, and then ultrasound abdomen. So radiologists made a comment about hepatosplenomegaly ascites plus dilated IVC hepatic veins and cardiomegaly with some pericardial effusion. So because this was a comment made by radiologist, and she was referred to us for cardiac evaluation. She was carrying, after the ultrasound, the X-ray was done. So this is the sequence of event with something history more of mixed, and then primarily endoscopy, then ultrasound, then X-ray, and then the cardiac. So this was the flow chart in her history. On presentation, the heart rate was, she was of average build with heart rate 110, means there was tachycardia, it was regular, she was acyanotype, she was tachypneic with JVP was raised, and upper, even in sitting position, upper end of JVP was not visible. Pulses all were palpable, but of low volume with narrow pulse pressure of 20 mmHg only. There was pedal edema, significant cardiomegaly, precordium was quiet. It was not hyperdynamic. Very, though heart sounds were normal, there was no significant appreciable murmur. On abdominal examination, hepatomegaly and ascites, it was there, as this were her main presenting complaint. Liver was formed to palpate. And this was her ECG. She was in sinus rhythm. LR, right atrium, is significantly enlarged. We can see the tall P waves. And on the chest lead, this was normal for her age. On chest lead, RV complex were hardly visible on the ECG. And this was echo. We start from subcostal view, as all of us should. So the IVC is dilated, hepatic vein is dilated, RA is significantly dilated, and there is pericardial effusion seen there. Very sluggish flow pattern you can see even in right atrium. And this is IVC without any significant respiratory variation. This is the 4-chamber view. So classically, right heart is significantly dilated, and RA and RV, if you look at the thickness of the wall, it is almost same throughout. Means it looks like a common chamber, right atrium, right ventricle, and wherever the blood is going. And see at the flow pattern, the sluggish to and fro pattern in both chamber. It's a common chamber, just floating fluid was there. And there was, when on the live echo, there was echo contrast in right atrium, significant dense echo contrast. It is not visible here, but it was there. And this is parasternal long axis view. This is parasternal long axis with the posterior tilt. Again, you can see the right ventricle. Just a thin membrane type thing is there. No muscle is seen. Parasternal short axis view. Again, right atrium, right ventricle, a common chamber. But if I go to the 4-chamber view, the tricuspid valve is seen here. Attachment is normal, very thin leaflet, but it is there. But when I look from parasternal short axis view, it's a common cavity because the valves were so thin, hardly visible, and the antegrade flow into the pulmonary valve. This is subcostal view in very posterior plane. In usual planes, the effusion was hardly any, very thin effusion was seen, but this, the collection was posterior to right ventricle, and whatever the collection was there, it was, even that was compressing right ventricle because the wall was so thin. This was causing a sort of significant hemodynamic effect on right ventricle. And parasternal M mode, from the parasternal long axis view, you see dilated RARV, and look at the tricuspid valve, very thin tricuspid valve, hardly any movement of the tricuspid because annulus was so grossly dilated, there was no coaptation. And if you compare this with the Epstein anomaly, so Epstein anomaly, anterior tricuspid leaflet say like, you see the movement of the tricuspid leaflet and the closing point, which is a classical part for the Epstein point of view, late closer, delayed closer of the tricuspid valve in comparison to mitral valve. Here you hardly see any leaflet, any closing of the tricuspid leaflet in this particular pathology. And the Doppler, which is very interesting, actually, I found it very interesting in this patient. So this is the pulmonary flow pulse Doppler across the pulmonary valve. So normally during systole, we find antegrade flow, and then if there is some regurgitation, you see that. So here, antegrade flow with the P wave. So right atrium contract, it pushes the blood into the pulmonary pulmonary valve. So opening of the pulmonary valve, flow into the pulmonary during the atrial systole. Then again with ventricular systole, because with ventricular systole we don't have RE myocardium, but electrical things were going on, septum is contracting, so it is sucking the blood into your pulmonary flow. So two peaks plus with the if you compare it with the JVP, this is very interesting. So if you compare with the JVP with the A wave, when you expect A wave, there is antegrade flow into the pulmonary valve. When you expect C wave, there is antegrade flow into the pulmonary valve, and with the X descent, there is regurgitation of flow. So this is a typical venous pattern. Means you can just in a reverse way, you can see, imagine the JVP across the pulmonary venous Doppler in this patient. The thing described in an article about the pulmonary Doppler in Ewell's anomaly is the antegrade flow through the pulmonary valve, not the biphasic. But in this patient, that is the only way I can describe this particular PW across the pulmonary valve by your common chamber with atrial contraction, with systole, and in both phases there is antegrade flow with regurgitation PR during the diastole. And this is the aortic Doppler, which shows ventricular interdependence. Means there is significant variation, like your measure of the depiction of the pulsus paradoxus in this particular setting. So everything means, because that's whatever the effusion was there, plus grossly dilated right ventricle, both things were leading to ventricular interdependence, and you are getting same thing in your aortic pulse wave Doppler, while the pulmonary pulse wave Doppler is very typical of for the your as your right atrial pressures were elevated. So by these findings, my echo diagnosis was very thin right ventricle, which is a Ewell's anomaly of right ventricle. RA-RV was severely dilated. Both were acting as a common chamber. Tricuspid leaflet were at appropriate position attached there, grossly dilated annulus, and because the leaflet was so thin, annulus was so dilated, there was significant low pressure tricuspid regurgitation. IVC, SVC, hepatic vein, everything was dilated with no significant respiratory variation. Spontaneous echo contrast was there in RA. There was no organized clot, and antegrade flow across the pulmonary valve of the venous pattern, aortic Doppler showing pulsus paradoxus, LV contractions were normal, severe right ventricular dysfunction, and pericardial effusion, though small, it was causing right RV collapse because it was so thin. With these diagnoses, the MRI was done and it showed hardly any myocardium with the right ventricle. So in short about the Yule's anomaly, this is one of the most common and is not cataloged into any study of the prevalence. So this is so uncommon. This is a near or complete absence of the myocardium of right ventricle, first described in 1905 by Osler. And then 50 years later, the proper name, that Yule's anomaly, was given by Hughes. He described a parchment heart absent of the myocardium of the right ventricle, and this appellation of Yule's anomaly was now it is in use. Male-female presentation almost equal. The presentation is from the fetal neonatal infancy. So basically it is a childhood early infancy disease, but for us it is not uncommon to see the grown-ups, even it is reported from India in adult age. And etiology, though fully unknown, but there is lack of myocardium. More accepted theory is the apoptosis. Either it is apoptosis or the process which prevent the apoptosis is lacking. Genetic is known, is the explanation given, because there is some overlap with the ARVD also, and it is seen in twins, familial pattern is seen. That's why it's more towards the genetic theory about this apoptosis. Diagnosis by echo, ECG, echo, CT, MRI, and biopsy. Management point of view, this is like right heart is non-functioning. So we have to, the option we have, one is palliative care. We just continue whatever the arrhythmia will happen, thrombus formation chances are there. So palliative care with the medical stabilization point of view. There are few reports we have to go toward the single ventricle. So the options we have, you close the right atrium, you close the tricuspid valve, you enlarge interatrial communication or create interatrial communication, and then this is the, you are creating sort of tricuspid atresia with atrial communication right to left shunt, and then you go for the Glenn shunt followed by a Fontan completion. So these are the surgical things described for the Yule's anomaly, whatever very small number of cases being described. And final is the heart transplant for these patients. Differential diagnosis, you have ARVD, Epstein anomaly, unguarded.
Manish, you can conclude. You
so
have taken more time.
So these are the differential diagnosis which should be thought when we are thinking about this anomaly. So to summarize, it is a rare cardiac anomaly with usual presentation in early infancy, but grown up with severe intractable heart failures there. We need to think about that. Diagnosis by echocardiography is being made. You need to confirm by CT or MRI to reach the final diagnosis. Prognosis, it is is guarded. Most of the time it is a palliative care which is being done, surgical options being described, and finally this is a heart transplantation for this rare anomaly. Thank you.
Thank you. Thank you, Dr. Manish Tamar, for presenting a very rare case of Wolff's anomaly. We know that it can present from prenatal to even 58 years of age, as per the publication. As a comment that usually we see the RV apex is spurred and upper portion of the RV is really dilated. But in your four-chamber view, I cannot appreciate the RV apex area. And the second comment is nowadays the RV strain is doing. Maybe we can give a trial of RV strain on this case also to know the RV systolic function. Thank you.
Thank you.
I think
we have a quick question from Dr. UP Singh in the chat.
I wanted to comment because I have seen a similar two cases, because I personally feel that if you have an old abnormality, you would not have a tricuspid valve abnormality along with. You know, this typically fits in unguarded tricuspid orifice with an absent pulmonary valve. The reason why I say that the tricuspid valve in unguarded tricuspid orifice doesn't have to be absolutely absent. A tiny non-functional tricuspid valve also qualifies for unguarded tricuspid orifice. So the absent pulmonary valve and unguarded tricuspid orifice, I have seen two patients. Dr. Vivek Tandon has one. So I personally feel it is a case of unguarded tricuspid orifice, and RV dysfunctions are secondary to severe pulmonary, absent pulmonary valve and tricuspid regurgitation?
Like, sir, these things are, it's difficult to differentiate that way because Ewell's anomaly is absence of myocardium. When the myocardium is absent, annulus is so dilated,
Yes.
this dilatation dysfunction, these are the secondary effect, and eventually your tricuspid valve will fail. Leaflet is there, clearly it is there. Like there is if I can share my presentation, there is another image of an absent tricuspid valve. So obviously it's myocardium is the difference between these two things. Eventually the tricuspid valve thin, gone, will appear like that in advanced stages of disease.
Thank you very much, Monish. We have already exceeded time. Dr. Iyer, please.
Yeah, thank you for being able to participate, and congratulations, Monish. You are very well demonstrated Ewell's anomaly. I just wanted to highlight that we have a local publication also. In 2017, we published our experience with surgical outcomes for Ewell's anomaly for patients who had different manifestations and different surgical procedures in them. It is published in the World Journal of Pediatric and Congenital Heart Surgery. So I just thought I'd like to mention that. Yes, it is uncommon, but we also have data from our own country.
So please call the next speaker and introduce her, sir.
Next speaker is Smitha Mishra.
So,
Dr. Krishna Iyer, you can unmute.
yeah. Hello. Hello.
We can hear you, Smita. Go ahead.
Good morning. Good morning, ma'am, and everyone. Thank you, chairpersons, to giving me this opportunity and the Echocon organizing team. My today's case is a small this thing. It's a huge case, but only a small part I'm going to highlight. So it's a case of acyanotic post-op TOF with the severe MR LSVC to left atrium, and there was some interesting physiology over here. It was 20 years old resident of Iraq, female patient, was diagnosed to have normal segmental analysis, large perimembranous VSD, severe valvular supravalvular infundibular stenosis, and underwent corrective surgery in 2004. In 2010, she developed dyspnea on exertion. She remained acyanotic. Echo was done, which revealed moderate mitral regurgitation, and mild tricuspid regurgitation, as well as RVOT obstruction. Gradient was 65. She was suggested to go for a redo surgery and was referred out of Iraq. She turned up to Delhi 12 years late. Poor growth, height, weight, all below third percentile, heart rate 130 per minute, intermittent fibrillation, respiratory rate 25 per minute, liver 3 centimeter pulsatile, raised JVP, multiple murmurs were heard, NYHA 3, and the pedal edema was present. This was the X-ray which showed cardiomegaly, LA enlargement as well as RA enlargement. Otherwise, the situs was absolutely fine, no suggestion of increased pulmonary blood flow. Echo revealed normal segmental analysis and PFO was there. Besides, there was no residual VSD, but severe mitral regurgitation because of retracted A2, moderate tricuspid regurgitation, severe RVOT obstruction, and particularly severe distal MPA narrowing, severe pulmonary regurgitation, RVOT gradient. Despite of severe RV dysfunction, RVOT gradient was around 65-70. The branch pH were normal in size, rather dilated, and distal MPA narrowing was there. Reduced RV function, reduced LV function. So this was the picture. You can say this is a T picture. You can say the severity of TR and MR, and there was an in presence of TR MR, RV dysfunction and LV dysfunction is always both function is always overestimated. So this is again another view, Plaque's view, and can see the severe MR happening over there, and this is the RVOT. And you can see the gradient velocity and proximal narrowing of the MPA, but the distal branch pulmonary arteries were fine. So this is a basic anatomy for this patient. Now coming to venoatrial segment, for which I am presenting this case, the IVC was dilated and non-collapsing, well understood, because RV dysfunction was there, TR was there. Here you can make out the aorta ratio with the IVC, and you know that IVC is very much dilated. The another very interesting finding, there was right SVC. I am not showing that, but there was also a left venous channel which was connecting to LA. You can see. I'm sorry that it's not. So you can see that this venous channel is very interesting. You can see to and fro movement. You can see to and fro movement through this venous channel. This is a to and fro movement from this venous channel, and this is connecting over LA, because most of the time when there is a coronary sinus, you get a very disciplined flow of blood over here, but it's all splaying, so it's not very disciplined. It's actually this channel is connecting to LA, it seems like so. So a large venous channel connecting LA to systemic vein with to and fro blood flow in a cyanotic post-op patient. This is very important because a large left SVC connecting directly to LA will cause cyanosis. So these are the differential diagnosis: levoatriocardinal vein, persistent left superior vena cava, vertical vein, anomalous, showing anomalous pulmonary venous drain, and left superior intercostal vein. Left superior vena cava, you always get blood flowing in one direction, and levoatriocardinal vein, which is mostly associated, first described was in association with obstructive lesions, but in normal heart also it may be there, it may be bidirectional flow. So what it was, so in this particular case, I just put this slide because Dr. Munish did a device closure for left SVC to LA this thing, and there was, because there was a connecting vein, and in this case what she described, that coronary sinus was absolutely intact. So left SVC has a tendency to persist, then to connect with the coronary sinus. And the status of coronary sinus is very important in all cases. In this case, because when we went back to see the 4C view, we could see that there was a dilated coronary sinus. So it showed that coronary sinus was intact. But if you look at the plaques, and now in this particular area, whenever there is a LSVC to coronary sinus, you have a dilated coronary sinus over here. It is not seen over here. And if you see coronary sinus AHD so many times, you can see AHD and flow over here in the plaques. So it is not there. So this is very interesting finding for this patient, where the 4C was showing in the posterior, with the posterior tilt, was showing the coronary sinus very much dilated, and then CT actually suggested same finding. Here you can see the LA and the coronary sinus are connected, and then subsequently the coronary sinus is getting formed. This is LA and connecting to coronary sinus, but in this particular case, see, in one view there is no difference between the LA, and that is showing the unroofing, partial unroofing of the coronary sinus, which is formed very well, formed later in the later part of this. Then you can see the 3D picture where right superior vena cava is draining behind the right atrial appendage to the right atrium, and then you see the left SVC, which is connecting directly to left atria. So these are the 3D finding. So what are the other views where we can actually look for the coronary sinus AHD or unroofing of coronary sinus? So these are the few views which we mostly don't use, but in this particular case I thought that I should present it. So you can see this is a trans esophageal echo, and you can see this particular channel, and you see the direction of this channel. Direction of channel is like this, not actually you see SVC like this and IVC like this, but here the direction of channel is different. And this channel is quite small compared to SVC, and IVC you always expect a little bigger lumen than SVC are equal to SVC. So in 3D also you can see, sorry. So this is coronary sinus coronary sinus anatomy. You can see the coronary sinus ASD over here. It is because of failure of invagination of left sinus horn and left atria lead to failure of incorporation of left common cardinal vein and left sinus horn into right atrium. These are the other views where in transesophageal 75-degree, if you tilt, you can get a dilated coronary sinus, and little anterior posterior you get the defect if it is there. In this is the transthoracic echo, in fact modified 2D view. You can see this defect which we didn't actually see in the first go. Now this we actually find like yes, I suspected there is unroofing left SVC, but it was confirmed only on CT. So this is the supraesternal view for the adult side of people, because they don't do this. So supraclavicular fossa, you have to keep your probe with the marker 3 to 4 o'clock position. It should be rotated, and also you can see directly this left SVC coming over here. And if coronary sinus is, this is the disciplined way of the stream coming from here. And
Smita, can you please conclude?
Okay,
You have exceeded that time.
So left SVC is common association of TOF. In this case, a small connecting nominate vein was there. And that is why the LSVC was missed. The patient didn't have cyanosis despite of left SVC to LA. That is the interesting physiology. I think because there was very high pressure of LA due to severe MR, there was to and fro movement in the left SVC, as well as there was a compulsive left to right shunting through the unroofed coronary sinus, and the part of intact coronary sinus was giving way to right atrium. So this is how it was. And the patient was high risk case, underwent mitral valve, pulmonary valve replacement, tricuspid valve repair with annuloplasty ring, MPA-plasty, LSVC routed to RA. She did very well and was extubated in 48 hours, and now doing good. Thank you so much. To set the case.
Any comments
Dr.
from Dr. Iyer, or shall we move to the next speaker, Sajid?
Yeah.
Smita, that was a brilliant presentation.
Yes,
Sajid.
very, very rare presentation. And so we have a time restriction now, so we move on to next topic on pseudo co-triatriatum dexter by UP Singh. He doesn't need any much introduction. And over to you, Dr. UP Singh.
Unmute. Okay.
Where was this?
Yeah, your screen is visible now.
Yeah, is that okay?
Yeah, audible.
So I'm presenting a case which I believe that could be a discussion like Ukraine and Russia, that who is right, who is not. So I'm presenting a case, and I'm presenting against a very august panelist, and I need your opinions on this. 64 years, that's, remember, 64 years female. I mean, long, I'm presenting congenital heart disease in a 64 years female, and elevated JVP, pituitary edema, and she was even now NYHA class 2 dyspneic. That's her ECG, which shows multiple lateral ectopics and some LV forces with the strain pattern and a kind of a biphasic pattern here. Unusual marked cardiomegaly. Male on the right atrial side. That's our echo, right? So I'm not going to discuss, Dr. Manish has already done that. This is almost a similar case. You see some valve tags around, you see a rudimentary papillary muscles which are not kind of forming an adequate and functional tricuspid apparatus, absent pulmonary valve. That sounds same as what she had shown, and you see a kind of a rudimentary pulmonary valve. So rudimentary pulmonary valve, rudimentary tricuspid valve qualifies for unguarded tricuspid orifice and a pulmonary valve absent, and that's what is the pulmonary artery flow, like JVP or like IVC, what she had already shown. I'm not going to show that. My intention is to show you Ukraine versus Russia. This same patient had this structure in the right atrium. Okay. Now the confusion comes: is it a cord triatrium dexter, or it's something else? Right. So that's the structure what we see, and there's a significant opening. I mean, this is not a kind of thing which is obstructing. And we see this is kind of attached to the anterior lip of the inferior vena cava, and that's what it is. So, what is attached here is, the Eustachian valve. Right. So now the issue is that what we saw, is it a Eustachian valve? And otherwise the interatrial septum is intact, but there is a slight bulge on the other side because of the tricuspid abnormality she had. So I am in my support that this is a Eustachian valve. I'm showing you a couple of more cases. Literature is very divided here, saying that it's either cord triatrium dexter. Many reports and images I've seen on the internet, and this thing is showing that this as a case of cord triatrium dexter. Okay, so I have a couple of more cases where, in the same case, now you can see this is just a band. It's not through and through, it's just a single band. You don't expect cord triatrium dexter to be like a band. It has to be like a membrane, which has to be obstructing, like you have it on the left side. So this is just like a band, a thick band in the or a valvular kind of structure in the right atrium. So again, this is some other patient showing a same kind of structure arising from the inferior vena cava insertion, and that's a Eustachian valve. Okay, the same thing again. Let me move forward, and that's a fetal echo. We do see it in fetal echo as well. Where we know that Eustachian valve is very, very prominent. It has to, because it has to divert the blood of the umbilical vein to the left side. So same, this is the same patient where you again see that this is the normal fossa and this is the Eustachian valve. So what does literature say? There is one case only where a transesophageal echo, which was done, and it did a three-dimensional echo to show that this is a kind of a Eustachian valve. So now I believe this patient had a prominent Eustachian valve rather than cord triatrium dexter. So cherry formation are kind of small structures which you've seen in plenty, but he also described a prominent Eustachian valve along the margin of inferior vena cava, and that's a genesis. Right venous sinus gets incorporated into the right atrium. The right part becomes crista terminalis, and the other side becomes the Eustachian valve and Thebesian valve, and that's how the embryology shows the Eustachian valve involvement. But if I say that, then what is cord triatrium dexter? To me, cord triatrium dexter, like cord triatrium on the left side, is a membrane which is kind of dividing the connecting chamber from. Now this is the membrane which is between all pulmonary veins and then the left atrium, and it may or may not have obstruction. On the similar front, you have a valve which is present on the right side, it has to be right through and through, maybe including the crista terminalis and forming a membrane, total occluding membrane with a hole and obstructing. So that I think should be quadratum dexter. So I have saved your 2 minutes because I'm finishing 2 minutes early for discussion. Thank you very much.
Thank you very much, Dr. UP Singh. That was a very nice presentation. In fact, I have a series of 22 cases and I have done the balloon dilatation to split it, especially in older patients where there was a thrombosis. And I lost one patient also. To put the thing straight, Bob Anderson, the cardiac pathologist, the great pathologist, he doesn't want to call it as quadratum dexter. He prefers to call it as a divided right atrium. So I had a case of divided right atrium as well as divided left atrium in a single patient. But the point is, if it is starting from the Thebesian valve going up to the eustachian valve across the right atrium, we call it as divided right atrium. It may be fenestrated, it may not be fenestrated. It may be intact or it may not be intact. And for that, we can do the contrast echo or the 4D echo, whatever it is. But in your case, it was not a giant eustachian valve. If it was a giant eustachian valve, it will not extend to the Thebesian valve. So in your case, it was coming right from the Thebesian valve right up to the IVC. So it could be a divided right atrium itself. So any comments from Dr. Iyer or Saji, or we can move to the next speaker.
Yeah, I think we can move on to the next speaker because time is a bit short. And Dr. Karthik Gopinath is here. Yeah, he will be presenting serial obstructions. Over to Dr. Karthik.
Good morning to respected delegates. The topic of my presentation is serial obstructions. So here I present a case, an 18-year-old female diagnosed to have heart disease at 7 years of age, but she was not evaluated and treated for the same. And she presented to us with dyspnea on insertion around NYHA class 3 since the past 3 months. Chest X-ray showed the features of cardiomegaly with prominent bronchovascular markings. Otherwise, it didn't point to any specific cause. ECG showed sinus tachycardia with abnormal looking P waves in lead 2 and 3, especially in lead 2 and lead 3 and AVF also, and suggestive of an ectopic atrial rhythm, and T wave inversions in lead 2, 3 AVF and V4 to V6. And also it showed presence of left ventricular hypertrophy. So we proceeded with the echo. The echo showed in the parasternal long axis view, we can see a subaortic membrane just behind the aortic valve here. Oh, look at this. And also in the mitral valve, the posterior mitral leaflet looks abnormal. It is thickened and there is restricted mobility of the posterior mitral valve leaflet. You can see it in this view also. There is a distinct membrane just behind the aortic valve in the left ventricular outflow tract, and the mitral valve leaflet also looks abnormal. There were other abnormalities also. That is the supramitral ring. We can see in the parasternal long axis view here, a distinct membrane is present just attached to the annulus of the anterior mitral leaflet, producing a significant turbulence just before the valve, and the posterior mitral valve leaflet also looks abnormal, as it is a distinct membrane attached to the annulus, and the posterior mitral leaflet also looks abnormal. That is, valve leaflet abnormalities are there. It is an intramitral variant. The other variant is a supramitral variant, where it is distinctly away from the mitral valve leaflet, and the valve leaflet abnormalities are not there. So this patient had an intramitral variant of a supravalvular mitral ring, producing a significant gradient. The gradient is around 6 mm Hg here. Patient also had a severe left ventricular outflow obstruction. We can see in the A5 view here, there is significant turbulence at the left ventricular outflow tract, and it is subvalvular obstruction. The gradient here was around 38 mm. So the presence of a subaortic membrane and supravalvular mitral ring was confirmed in the cardiac CT. Here we can see in the axial section the subaortic membrane here. Patient also had a coarctation of aorta. We can see opposite the left subclavian, a distinct shelf-like indentation is present, producing significant turbulence in the descending thoracic aorta. The gradient here is around 38 mm. So cardiac catheterization study was done. In the DTA angiogram, the presence of a coarctation was confirmed. You can see here there is distinct coarctation of aorta, and the same is seen in the cardiac CT angio with the three-dimensional reconstruction. Patient also had a patent ductus arteriosus. That is, it was quite large actually, around 7 mm in size, with the left to right shunt. You can again see in the DTA angiogram here. And the same was confirmed before the catheterization study in the echo, showing a continuous flow as seen in the short axis view. Patient also had a persistent left superior venic clot. We can see the catheter all the way up till the left SVC, and the flow is seen there from the left SVC. Coming to Schoen's complex. Schoen's complex is a rare congenital heart disease made of multiple levels of left side obstructive lesions. Main components of the Schoen's complex include supravalvular mitral ring, parachute mitral valve, subaortic stenosis, and coarctation of aorta. Our patient did not have parachute mitral valve, but other features of Schoen's complex were present. Complete Schoen's complex includes the presence of all these, all these four lesions. The presence of an incomplete Schoen's complex is defined as the presence of any one obstruction at the level of the mitral valve and at the level of the left ventricular outflow tract, which need not be limited to supravalvular mitral ring or subaortic stenosis. Schoen's syndrome was initially described in 1963 with 8 components. That is the presence of these 4 components, along with the presence of a bicuspid aortic valve or triatriatum, hypoplastic left ventricle, and small aortic arch.
Thank you very much, Dr. Karthik. That was a nice presentation of Schoen's complex.
Patient had a supravalvular mitral ring.
No, we have got 3 more speakers, and let us thank you very much for your nice presentation. Now we move on to the next speaker, my good friend Vikas Kohli. He is going to speak about medically reversing the hypertrophic cardiomyopathy. Let us see what he is going to present. Thank you.
I'm glad to be here, but I need to be enabled for screen sharing, please, admin.
Can you please try again? You should be able to share your screen.
I will host disabled participant screen sharing. That's what it still says.
Right now, sir.
Again, I'm trying. Yes, thank you. So here we go, and very brief presentation today on this particular topic of, obviously there is no magic here, but reaching the right diagnosis. So we'll be talking about reversing hypertrophic cardiomyopathy. This 2-month-old baby was admitted in a pediatric ICU for a viral illness, had a murmur. Echocardiogram was done, which showed hypertrophy of left ventricle. A workup for hypertension was started, but not completed due to financial reasons, and was discharged due to cost issues, and comes to our OPD for follow-up. And this is what we see on the echocardiogram. Lo and behold, I'm shocked to see that the 2-month-old baby has such severe hypertrophic cardiomyopathy, and I'm sure practically everybody who's seeing this image right now is thinking of the right diagnosis, which we shall reach. You can see that it's already starting to affect the systolic function. The cavity size is small. It's a global hypertrophy, symmetrical hypertrophy. There is hypertrophy of the right ventricle also. And you can see in cross-section the massive thickness of the interventricular septum, almost reaching to 12, 14 millimeters in this small baby who was less than 4 kg in size. And during systole, the cavity is almost completely obliterated, and that's a color image, and you see no cavity at all. There's a thin pericardial effusion, which does get exaggerated in systole. So this is not the level of pericardial effusion, and this is not the way to look at it, but there was a thin pericardial effusion, and you can see that now in diastole. So we're dealing with a massive hypertrophic cardiomyopathy, and unless we reach a diagnosis, we won't know what it is, and the child is almost about to reach a point where it might end up into dilated hypertrophic cardiomyopathy, which is the end stage of hypertrophic cardiomyopathy when the LV starts dilating. So the measurements were taken and workup was started. And what were we thinking of? As you can notice here, that there is some enhancement of the endocardium, early endocardial fibroelastosis due to the massive thickening of the myocardium is noted, and diastolic dysfunction is noted. And we started going through, is there a dysmorphism? The child did not have a dysmorphism. Went through several algorithms, what other conditions can cause, and the ones which are highlighted in yellow are the ones which cause hypertrophic cardiomyopathy, definitely Noonan syndrome. We would have recognized the faces. There was no suggestion of neurofibromatosis. Beckwith-Widman is the ear would have been different. We were looking at various parameters. We also were aware that we did not have too much time on our hands, and we started a metabolic workup, and obviously glycogen storage disease and mucopolysaccharidosis all were available. Our focus was on glycogen storage disease, specifically Pompe's, which is a treatable cause of hypertrophic cardiomyopathy. Enzyme assay specifically for Pompe's was done with the idea of if that turns out to be positive, it's a treatable cause. We have several patients on follow-up who are receiving enzyme replacement therapy, and we confirmed the diagnosis by genetics and by metabolic specialists, and they initiated enzyme replacement therapy for the patient. It is remarkable that in 3 months, how well the patient did. On the left side panels are the pre, and on the right side panels, the left. The left ventricular mass, which was 140 to 150 grams, decreased to 59 grams. This is not indexed to body surface area. You can see the pre in the parasternal long axis and the post therapy. Obviously, the therapy is a continuing therapy and does not end here. And you can see the cross section and the mass calculation. And it is visibly very clear that this child was doing remarkably well in a 12-week period where the child received 12 doses of enzyme replacement therapy. You can see in the M mode also a remarkable improvement in the child's condition. And I would conclude the presentation here, suggesting that a thorough workup focusing on reversible therapies and causes looking at metabolic and genetic would truly help. Thank you very much.
Thank you, Dr. Vikas. It's very interesting presentation. And we had 3-4 cases of the overt and gestational diabetes presented with the severe hypertrophy. But very interestingly, within 40 days of postnatal life, totally resolved. But your presentation is very interesting. And what kind of enzyme therapy done, Dr. Vikas?
So specific enzyme alpha glucosidase, which is deficient, is given as a replacement therapy. It is produced by recombinant genetic engineering, and it is available in the market. Obviously, the issue is cost. One has to be aware that Government of India funds the cost for several months for several patients per government institution, which are tertiary care recognized genetic and metabolic centers, which is why we have almost 15 to 20 patients on long-term follow-up. And I must say that these patients do really well. Included also are specific types of mucopolysaccharidosis. They also get diagnosed and get treated with enzyme replacement therapy. So under the Government of India's rare disease program, which the geneticists have really pushed forward, and we need to thank them, we become a small part of continuing evaluation while they manage the treatment and weekly therapies.
Thank you very much, Vikas.
Thank you, Dr. Vikas.
Okay.
Pleasure.
Yeah, please, Sajid, call the next speaker.
Yeah, we move on to next topic on Marfan syndrome with the quadricuspid aortic valve, a rare case report and review by Dr. Rajesh Roy. Over to Dr. Rajesh Roy.
Thank you, sir. Good morning, everyone, and thank you for giving me this opportunity. Here I present a patient who presented to our institute. He was a rare case of Marfan syndrome along with the quadricuspid aortic valve. Now, Marfan syndrome is usually associated with abnormalities of aortic and mitral valve and sometimes pulmonary valves, usually aortic dilatation, aortic aneurysm, dissection, mitral valve prolapse. There is hardly any report worldwide, maybe one or two, which has shown an association of Marfan syndrome with quadricuspid aortic valve. Now, quadricuspid aortic valve in itself is a very rare congenital anomaly, and the incidence ranges from 0.005 to 0.006 only. And the most common functional abnormalities associated with QAV is regurgitation, which is seen in nearly 75% of the patients. Sometimes there may be an association of AR with AS in approximately 8.5% of the patients. There has been only around 200 cases worldwide of QAV reported till yet, but there are very handful of cases reported along with Marfan syndrome. This patient was a 39-year-old male patient hailing from Madhya Pradesh who had a history of fever since 1 month with generalized weakness. There was no significant family history given by the patient, but on examining the patient, we noticed that the patient has a very tall height and an abnormal stature as well. So we tried clinically only, it was apparent that the patient probably has a Marfanoid status. So we applied this Ghent criteria, which is used to diagnose Marfan syndrome. And the patient had an arm span of 190 centimeters, height of 179 centimeters. The upper segment, lower segment ratio was less than 1.05, which was around 0.75. He had a high arch palate with crowded teeth. The wrist sign, umbilical sign were positive. There was dental overcrowding. There was scoliosis and malar hypoplasia. This is the picture of the patient. On the extreme upper left side, we see that the patient has a tall stature, tall height, abnormal stature. The wrist sign, umbilical signs were positive. The patient had high arched palate with overcrowded teeth, which can be very well seen in this figure. The investigation, however, revealed urinary tract infection as the cause of the fever, which settled with antibiotic treatment within 2 days of admission. The anemia was proven to be because of proctitis, which was done through biopsy during colonoscopy. And the liver and renal profiles were also normal. But during this workup for finding the cause of the fever, we did the transthoracic echocardiography of this patient, which revealed a type A quadricuspid aortic valve as per the Hurwitz-Roberts classification. It was then confirmed with cardiac CT aortography also, which confirmed that the QAV was A type and there were no associated coronary abnormalities. This picture shows a 2D echo finding which was done by me on the left side, showing a equal 4 cusp of quadricuspid aortic valve, which was later confirmed with cardiac CT to have a type A QAV. This is the video of the patient having quadricuspid aortic valve, and there was a small aortic regurgitation, trivial to very mild, which was not causing any clinical problem then. Marfan syndrome in itself is a connective tissue disorder, which is autosomal dominant, and it is diagnosed on the basis of Ghent's criteria, where we should have 2 major criteria or 1 major and 2 minor criteria. Just a small hint of what all criteria are included in Ghent criteria. So our patient was clearly fitting into the positive status of Ghent's criteria, and he was having Marfan syndrome. The usual cardiac involvement is in Marfan syndrome is in the form of aortic or mitral valvular defects like aortic dilatation, aneurysm, dissection, etc. Quadricuspid aortic valve in Marfan syndrome is very rare. Quadricuspid aortic valve is common in males and is thought to arise because of inflammatory insult that causes abnormal septations of the conotrungus and endocardial cushions. It is classified on 2 schemes, either the Hurwitz-Roberts classification that considers the size of the supranumeral cusp, or the Nakamura classification that takes into consideration the position of the supranumeral cusp. This is in short regarding the Hurwitz-Roberts classification, ranging from type A to type G. Our patient had type A, where all the 4 cusps were nearly of equal size. Similarly, they have differentiated it into other 6 types depending upon the size of the cusps. The Nakamura classification, as stated previously, takes into consideration the position of the supranumerary cusp. So the type 1 is where the supranumerary cusp is between the right and left cusp, where type 2 is where the supranumerary cusp is between the right and non-coronary cusp. Type 3 is where it is between non-coronary and the left cusp. And when all the four cusps, supranumerary cusps are not identifiable, they put it in type 4 of Nakamura classification. QAV, as I have stated, is commonly associated with AR, whereas a combination of AR and AS can be seen in about 8.5% of the cases. Other abnormalities, the most common in QAV has been found to be coronary artery abnormalities, either the abnormal origin of RCA or single coronary artery, etc. Our patient didn't have, luckily. Other that has been found in association are PDA, VSD, ASD, TGA, non-obstructive HCM, etc. Infective endocarditis can be seen in up to 1.5% patients, but prophylaxis is usually not advisable until and unless patient has history or focus of severe infection or previous history of infective endocarditis. Usually the patient is symptom-free till 40 years of age. Our patient also fell into the same group, but they may start showing signs of cardiac failure, especially when they start approaching the age of 60. Diagnosis is most commonly by echocardiography. We can do a transesophageal echocardiography that can help us determine the aortic valve anatomy and coronary artery accurately, but we subjected this patient directly to CT cardiac angiography and radiography. Thus, surgery is indicated when the patient has very severe AS or very severe AR or other associated congenital anomalies. The surgery of choice is aortic valve replacement, but other options can be tricuspidalization, where we suture the right coronary artery, right coronary cusp with the supranumerary cusp, or we can subject the patient to bicuspidization surgeries. The 10-year survival post-surgery, as per various reports, is around 85%. So this was a patient of Marfanoid feature who presented to us with the QAV type A according to Hurwitz-Roberts classification, which is extremely rare, and only one case up till now I have managed to find out in Istanbul, which has reported a patient of Marfanoid feature with QAV. Thank you everyone for your patient listening.
Very much, Dr. Rajesh. That was a very nice and interesting case. And now we move on to the last speaker, Manisha Chakravarti. She's going to present about the rare coronary anomaly in a neonate. Sorry, because of short of time, we are moving to the next speaker. Manisha.
Good morning, everyone. I thank the organizers for this lovely CME being in a hybrid platform. I got a chance to visit my alma mater of pediatric cardiology here in Scots and yet listen to the international speakers. Now my case is with a newborn. Just to highlight that the coronary abnormalities are not only a popular topic for the adults, but we also do see a lot of interesting coronary abnormalities. So this baby was 36 weeks gestation, born of a gestational diabetic mother who was also hypertensive and was on labetalol. The baby is second in birth order. First baby was absolutely fine. The delivery was absolutely uneventful. And here there was emergency coronary cesarean section due to the absent diastolic flow. The finding was a meconium stent like a Apgar was otherwise okay, 7/10 and 9/10. The birth weight was 2.5 kg, but after birth, the baby had persistent tachypnea and was kept on oxygen to maintain the saturation. The investigation, otherwise there was no other problem. The baby was active, good cry, and the tone and everything was normal according to the neonatologist. However, due to this distress and the history of meconium aspiration, the CBC was done, which showed a high TLC with neutrophils. The platelet count was, however, very low of 59,000, and the CRP was borderline positive. So the antibiotics was started, baby was kept in NICU on oxygen, and I got a call for an echocardiography. So echo, we found as usual, there was a small ASD and a PDA, which had dominant left to right by bidirectional flow, because there was hypertrophy of the septum and also of the RV, though there was no obstruction. There was mild RV dysfunction, which commonly we see, as Dr. Saji also pointed out, in patients of mothers or babies of mother having diabetes mellitus. And to my utter surprise, what I found were the coronaries. See, we see what coronary that I have found here. The left coronary artery had no sign of tapering, no loss of tapering was there. The wall was little prominent and it was quite dilated. So this, when we measured, it was 2.1, which came to the as dilated Z score 4.7. The left coronary artery and the right coronary artery, both the coronary system was found to be dilated. The left LAD was 2.1 with a Z score of 4.7, and the right RCA was also Z score of 3.63. So in a newborn without any other abnormality, these coronaries were not being explained. So we tried to investigate this baby in terms of intrauterine infection and other things, but the torch was negative. Parvovirus and Epstein-Barr virus, which were also after the report came after some time, ultimately found to be negative. The autoimmune causes were a possibility. The mother's HANA and dsDNA also came to negative. The mother was otherwise antenatally followed up in this hospital only. So she was otherwise thoroughly walked up, and she had no antenatal history of any fever or rash or any other problem during her pregnancy. The mother's hepatitis B, C, HIV was also negative, no fever either in the mother or the baby. The COVID status of the mother and baby antigen was also negative, and we had also sent the baby's COVID antibody, which also came negative. So during the course, what we found was the oxygen requirement, which decreased after 2 days. The hypoglycemia, which was initially there, also controlled, was being controlled by the neonatologist. The platelet count, which was initially 59, came to 32,000. It decreased further, though the baby's activity was otherwise okay. The repeat echo was advised, where we found the hypertrophy, however, decreased and the function improved after 2 days. And the ASD and the PDA become almost negligible, which was shunting left to right. Now the function also improved. However, the dilatation of the coronary persisted. So opinion was taken from the hematologist, and due to the low platelet count associated with it without other findings, and the coronaries, autoimmune vasculitis possibility was kept, and IVIG was given just to be on the safe side to prevent the coronaries from further dilatation, because we were in a fix that we could not find out a definite cause. The follow-up of platelet after we gave IVIG improved gradually after 5 days, and Clexane was also added in between. The serial echo, again, we see here the coronaries are still dilated, the left and the right, and the loss of tapering also persisted. So size-wise, it came little down than before, with a Z score still of 4.4, and the RCA again 2.2. So baby was clinically improving, but the repeat platelet counts were rising. So we had discharged the baby with a platelet count and was kept on aspirin. After 1 month, however, we are following up this baby. After 1 month, baby is otherwise growing well, but we can see the coronaries here, the left and the right, both are still dilated. The Z score are very gradually increasing. This is after 6 months. Again, we can see here the coronary arteries Z score wise is decreasing, because the weight of the baby is increasing, while the size of the coronaries are decreasing in a very slow pace. Now the LAD is around 2 and the RCA is around 1.7. So the right coronary artery has come to the normal size, but the left LAD is still dilated. So we tried to review the literature, and we found that the coronary ectasia, which is defined as a distension of the artery, which is more than 150% of the diameter of the unaffected. But here, since both the coronaries were dilated, we depended on the Z score, which again less than 3 kg is to be taken with caution, but clearly with our experience, we don't find such big coronaries, and it was dilated. The cause, the most important association with Kawasaki disease, but we any of the other feature of Kawasaki in this patient. Coronary fistula is another cause which is also excluded here. We did not from the echo. It has been also seen associated with atherosclerosis and future in adult population with hyperlipidemia, the sepsis and asphyxia. The only thing was sepsis, but no blood culture and other things were also negative in our baby. There are only very few case reports. We reviewed the literature. A newborn with dysplastic aortic valve and air with dilated coronaries, where they found only the dilatation of the right coronary artery, and it was unilateral baby in a neonate by Dr. Joseph et al. A 20 days female was also diagnosed with VSD-PD at 3 months with isolated dilatation of the left anterior descending artery. Then there was another report of newborn with bilateral coronary dilatation, which was attributed to as a atypical Kawasaki disease and also responded to IVIG therapy. Only one mortality was reported so far in our review. Neonate with massive infarct, myocardial infarct on autopsy showed subacute necrotizing coronary vasculitis, which is a similar finding as of polyarteritis nodosa. Kawasaki, as we told, we also got a baby of 2 months old like this, where both the coronaries were dilated with thickening of the walls and loss of tapering. But then a newborn presenting with Kawasaki is almost not known. Boyles et al. Described a neonate with isolated dilated artery, also with congestive heart failure. These are the few cases that I found. But then congenital dilatation actually is very rare, and still I think the exact etiology needs to be investigated, and the follow-up of these babies till adulthood is very much required, which will reflect on the future prognosis of this child. The learning curve has just begun, so we still learn from our cases. Thank you.
Thank you very much, Dr. Manisha Chakravarti. That was a very rare case of congenital ectasia. We are already short of the time, and I thank all the speakers. They did wonderfully well, and I thank my co-chairman person, Dr. Krishna Iyer and Saji. Any comments from you? Otherwise, we'll conclude. Thank you.
Yeah, the last presentation is very interesting, and I really say that this is some kind of an immune complex vasculitis. Okay, it can be circulating immune complex can be triggered by even COVID RNA virus. So any virus or bacteria or destomite or whatever it is, it can trigger the circulating immune complexes. This may happen even in the gestational period itself. So something happened. I really believe that it's an immune complex vasculitis and dilator. Once coronary artery is dilated, our treatment is same. IVIG and aspirin can be given, and it's wonderfully it is resolved back to normal. Thank you.
Thank you, sir. Yes, we also suspected the same, though we could not find out exactly what it is.
Thank you. They were all very interesting cases, and congratulations to all the presenters.
Wonderful.
Thank you, sir.
Fantastic presentations by all our speakers and very well moderated by Dr. Vijayalakshmi. Before moving on to the next session, let's quickly take a group E photograph. I would request everyone to please turn on your cameras.
Dr. Simi.
Smita is not there?
Smita
and Munesh?
Munesh is there.
I see Dr. Munish is there. Dr. Munish, if you could turn on your camera.
Keep an eye on the road also.
Okay, perfect.
Okay.
Right.
If she's driving.
Say cheese. Perfect. All
Thank
right.
you.
Thank you so much,
Thank
ladies
you.
and gentlemen,
Thank
for the
you.
wonderful session. Moving on to the next session on eco advances, I would take the honor to invite our chairpersons, Dr. Nagendra Chauhan, Dr. Vishal Rastogi, Dr. Vivek Kumar, and Dr. Rakesh Jalota. Definitely, sir. As the very first speaker for this session, I would now invite Dr. Rishi Gupta, and his talk is subjected on approaching heart failure with preserved ejection fraction. Over to you, Dr. Rishi.
Thank you everyone, and good noon to chairpersons and all delegates. First and foremost, I would like to express my gratitude to Indian Academy of Echocardiography Delhi chapter for inviting me for this talk, and it's a wonderful meeting, and I congratulate the people associated with the meeting for this wonderful meeting. I am going to talk about the diastolic heart failure and approach to diastolic the heart failure with preserved ejection fraction. As you all know, could you see my slides?
Yeah, your slides are visible. Yeah, go ahead.
Yeah. So yeah, this is my topic, approaching heart failure with preserved ejection fraction. Let me talk something about the echocardiogram in this entity. We know that this abnormality is very confusing, and the diagnosis and the treatment has always been very dicey, and there had been a lot of progress, and now we understand this entity much better. So let us start with the universal definition of heart failure. Now, if you see from the 2021 position paper of European Journal of Heart Failure, the universal definition of heart failure has been defined as symptoms and or signs of heart failure caused by a structural and or functional cardiac abnormality, and should be corroborated by at least one of the following: either a elevated natriuretic peptide or objective evidence of cardiogenic pulmonary or systemic congestion. And because this definition is very important, because many times you have the fluid overload because of CKD, because of so many other conditions which may mimic like heart failure with preserved ejection fraction, and then you have to make a clear-cut diagnosis of HFpEF. And this is the European Society of Cardiology 2021 diagnostic algorithm for heart failure diagnosis. If you have any patient who have a suspected heart failure with then you should evaluate for risk factors, symptoms, and or signs of heart failure, and should always see that there is an ECG abnormality is there or not. And then you should proceed for, if the patient is suspected for heart failure, then you should proceed for an evaluation either with NT-proBNP or BNP, which is defined as criteria of heart failure as more than 35 of BNP or more than 125 of proBNP. So if heart failure is strongly suspected, and if the NT-proBNP is not available, then one should proceed for the echocardiography. So this becomes an important part of evaluation. And here also, if there is no evidence of increased NT-proBNP, that means the possibility of heart failure is unlikely. The diagnosis is normally excluded. And similarly, if the echocardiogram do not show any structural abnormality, then also the diagnosis of heart failure becomes unlikely. And if we find that both the things are positive for diagnosis of heart failure, then the heart failure is confirmed. And then we define the heart failure phenotype based on LV ejection fraction. This is divided into a heart failure with reduced ejection fraction less than 40%. Then you have the mid-range heart failure, what we call when we have the ejection fraction between 41 to 49%. And HFpEF is defined as ejection fraction more than 50%. So I am going to talk about the heart failure with preserved ejection fraction as HFpEF. And then one should determine the etiology and the treatment should be started. So this is, I think I already talked about the universal definition consensus statement of different phenotype. There is another fourth variety of heart failure, which we normally see in our practice, that is heart failure with improved ejection fraction, where the ejection fraction, we start with the patient had heart failure with the LVEF less than 40%, and on follow-up, the patient had improvement in ejection fraction with more than 10-point increase or second measurement more than 40%, then this patient is classified as heart failure with improved ejection fraction. So this is again very important to differentiate from the treatment point of view, because this patient will require a treatment similar to HFrEF in spite of having a ejection fraction more than 40%. So it is, let us come to the important part of echocardiographic evaluation of HFpEF patients. So now, normally what we see that the greater number of abnormalities indicate higher likelihood of HFpEF. So this is very important because there is no single abnormality which can define that this patient is having HFpEF. So this is why the all these criteria have been defined. Normally, conventionally, we had been measuring the EA ratio to define the diastolic dysfunction, but now we have the more with the understanding of heart failure with preserved ejection fraction, we have a lot of other parameters which are now being assessed. So the first parameter is the left ventricular mass index, which is considered more than 95 gram per meter square in female and more than 115 gram per meter square in male. And the another second criteria is the relative wall thickness, more than 0.42. The relative wall thickness normally indicates the concentric LV geometry. So this is what it is. It is basically a twice of posterior wall diameter divided by the end diastolic diameter of the left ventricle. So this is again one of the very important criteria which tells you that this patient is having a eccentric hypertrophy or concentric hypertrophy. Even before concentric hypertrophy, you can define that the patient may be having a concentric LV geometry. So this is again one of the very important parameter, echocardiographic parameter, which can be used for diagnosis of HFpEF. Then the left atrium volume index more than 34 millimeter per meter square in sinus rhythm and more than 40 millimeter per meter square in atrial fibrillation in absence of valve disease. And then E and E prime ratio, which should be more than 9. So if one should understand that if you have E and E dash prime ratio more than 9, it had the sensitivity of 78%, but specificity of only 59%. Whereas if you have an E and E prime ratio more than 13, it has high specificity, but of course sensitivity becomes low. Then the fifth criteria is the tricuspid regurgitation, with the velocity should be more than 2.8 meter per second. And then pulmonary artery systolic pressure, which should be more than 35. So let us define the facts about the LV mass index and the relative wall thickness. The left ventricle geometry is often classified using LV mass index and relative wall thickness. LV, as I told you, that the LV mass index in male and female and the relative wall thickness more than 0.42 is indicative of concentric LV remodeling or hypertrophy. So you can have the 4 type of patterns which have been defined. You can have a normal pattern where the LV mass index and the relative wall thickness is less than 0.42. Then concentric remodeling, where you have the normal LV mass index but relative wall thickness more than 0.42, which is considered as concentric remodeling. Then you have concentric hypertrophy, where both the things are increased. Then you have eccentric hypertrophy, where there is an increased LV mass index but relative wall thickness is less than 0.42. So the patient with HFpEF will have either a concentric LV remodeling or hypertrophy. And it is also, one should understand that what I have told you about the basic part, and if you have the LV mass index more than 149 or in male and 122 gram per meter square in women, and with RWT more than 0.42 is a very major criteria for diagnosis of HFpEF and supports the diagnosis of HFpEF according to the Heart Failure Association algorithms from European Society. And one should also understand that the absence of LV hypertrophy does not exclude the diagnosis of HFpEF. So let us, another important criteria of echocardiography of diagnosis of HFpEF is the left atrium volume index. So this is again one of the very important criteria, and in absence of atrial fibrillation and valve disease, normally LA volume index more than 34 ml per meter square suggests elevated LV filling pressures, and it is again one of the very important supportive signal for diastolic heart failure. In patient of AF, then this criteria should be used as more than 40 ml per meter square. So, so this is the criteria. Is you see from the Heart Failure Association criteria, the LA volume index more than 34 ml per meter square is considered as major, and between 29 to 34 is considered as minor criteria. And the other important thing which has been noted from the TopCat trial, which is about the mineraloreceptor antagonist trial in HFpEF, where it was shown that the minimal left atrium volume index was associated with worse clinical outcomes as compared to maximal left atrial volume index. And they also found that the left atrial emptying fraction as well as left atrial strain were more prognostic, had more prognostic implications for clinical outcomes in HFpEF patients independently of LA volume. So this is again one of the very important thing which one should note. And let us talk about the E and E prime ratio. The E and E prime ratio again is very important criteria for diagnosis of HFpEF, and it indicates the elevated mean capillary wedge pressure and correlates with LV stiffness and fibrosis. It is less dependent on age as compared to E-dash velocity and minimally influenced by change in volume. So it becomes very important. So what is the criteria? Criteria is more than 9, and if it is more than 13, it is very specific. As I told you that the higher values has less sensitivity. Coming to the tricuspid regurgitation velocity, so I think it is very important. 2.8 is if you have TR velocity more than 2.8 is indicative of increased pulmonary artery pressures, and it is again in absence of LV dysfunction and absence of lung disease becomes one of the important criteria for diagnosis of HFpEF. And if it is more than 3.5, then it suggests strongly suggests possibility of HFpEF in absence of lung disease and LV dysfunction and valve disease. And similarly for the pulmonary artery pressures, the evidence of pulmonary artery pressures again a very strong indicator of HFpEF in absence of lung disease and the left ventricular systolic dysfunction. So this is again one of the very important criteria, and elevated pressures become one of the important criteria for diagnosis of HFpEF. Let us come to the PEF algorithms for diagnosis of HFpEF by the Heart Failure Association. So you have the initial workup where you measure the symptom signs, risk factors, ECG, standard echocardiogram, natriuretic peptide, and 6-minute walk test. Then you have the E stands for echocardiographic and natriuretic peptide score. Then you have the comprehensive echocardiogram where you when you measure the advanced parameters of diastolic dysfunction as well as the natriuretic peptide if it is not measured in step 1. Then you have the advanced workup, functional testing, and etiological workup, and that is required once you have made a diagnosis of heart failure. So this is the step 1, where all these things are measured: age, overweight, metabolic syndrome, physical inactivity, arterial hypertension, atrial fibrillation, ECG abnormalities, and elevated natriuretic peptide. And this is the step 2, where you measure the it is again, here you can see that the major and minor criteria, and these major and minor criteria of the E and E prime ratio, LA volume index, pro BNP, and then these factors are taken, and once you have for a major criteria are given 2 points and minor criteria are given 1 point. If you have 5 points, then the diagnosis of HFpEF is established. If you have 2 to 4 points, then patient should go for diastolic stress test or invasive test. So what is the step 3, the advanced functional testing, that is stress echo is done, and then the stress echo, if you find that on stress the E and E dash prime ratio is more than 15 or TR velocity more than 3.4, then it establishes, then you have the more added points, 2 or 3 points to make the diagnosis of HFpEF. And if it is still negative and you strongly suspect that this patient is having HFpEF, then patient should go for the invasive testing. So just
Dr. Gupta, please summarize.
Yeah. Just let me go into the part. I'm not going into the stress part. So this is the another criteria of H2 PEF score, where the clinical parameters like heavy obesity, hypertension, and atrial fibrillation and elderly age group is also included. And then you have this criteria where the points are given, and then the more number of abnormalities will indicate the diagnosis of HFpEF. So let us come to the last part of the treatment point of view. You have a lot of treatments available for the HFpEF which have been tried. So you had starting from 2003 to where the candesartan was used. Then you have the PEP CHF trial where prendopril was used, irbesartan trial in 2008, then TopCat trial with the spironolactone, and then Paragon heart failure trial with sacubitril valsartan. All trials showed some minor decrease in event rate, but it was not statistically significant. Whereas you had the latest trial in 2021, Emperor Preserve trial, which showed significant reduction in heart failure admission and death with SGLT2 inhibitor empagliflozin. And this is what it showed, is whether you talk about the mid-range ejection fraction, you talk about the LV ejection fraction more than 50%, it showed significant reduction in hospitalization for heart failure and death. So this became one of the first treatment which is available for patients with HFpEF. And so this is again now the new paradigm in management of heart failure with preserved ejection fraction. You have now the newer drug available. Thank you very much for your patient listening.
Thank you, Dr. Gupta. This was a very comprehensive review of a very complex topic, and I understand that 15 minutes were not enough. But however, due to constraint of time, we move on to the next topic, which is again a heart failure topic. This will be delivered by Dr. Anshul Jain. The topic is reverse cardiac remodeling and clinical outcome after initiation of ARNI.
Yeah, hi, good morning. I think Dr. Rishi, thank you so much. You need to stop sharing your screen. Sorry.
Yeah, you can go ahead. He stopped it.
Yeah, 1 second. Sincere thanks to the Echocon and Novartis for giving me a chance to speak. And very happy to see you, Vishal, Nagendra, and Vivek after a long time. So my topic is very simple, actually. After a detailed discussion by Dr. Gupta about heart failure and definitions and volume, so I am supposed to speak on why reverse modeling, can reverse cardiac remodeling and clinical outcomes be achieved with the use of ARNI, that is sacubitril valsartan combination. So we know that cardiac remodeling, basically it means that there is a reduction of heart failure, of ejection fraction, which is caused by changes in dimensions of the heart as well as the volumes of the heart. And we have not many dimensions and echocardiac dimensions and volumes which we measure so often, and come to a conclusion whether the heart is maintaining the normal geometry with which it pumps or not. Whether it loses sphericity, if it loses its sphericity, the volumes obviously increase, and so it implicates basically indirectly into loss of ejection of the blood. So what we see on top is our minimal symptoms, whereas under the, in the heart, many things are going with in terms of adverse remodeling. So what happens? We often report concentric LVH on echo so casually. Oh, it's concentric LVH. But if you see this cardiovascular composite, you see that patients who have endpoints of cardiovascular, that is sudden cardiac death, stroke, heart failure, infarction, they have, so many of them have a high incidence of concentric LVH. The gray one is a normal heart. The bluish one is concentric remodeling, and the light yellow is eccentric hypertrophy, and the chrome yellow, as you call it, is concentric LVH. So you see, all of these cardiovascular endpoints have a higher incidence of concentric LVH. So it's not a benign echocardic report of concentric LVH. It has its implication on the cardiac mortality and morbidity. For every 10% drop of ejection fraction, you will have a 45% increased risk of cardiovascular death or chronic heart failure hospitalization, and a 57% increase in cardiovascular death. Similarly, when you have a 10 ml increase in left ventricular and diastolic volume, the death or heart failure hospitalization increases by 9%, which is very significant. Increase in end systolic volume results in 15% increased risk of death or heart failure hospitalization. So what is exactly happening in a normal heart which is afflicted by ischemia, diabetes, hypertension, obesity, or aging? Many phenomena are going in, be it extracellular matrix remodeling, necrosis, apoptosis, autophagy, oxidative stress, or energetic abnormalities. What it does, it causes, as I said earlier, it changes the geometry of the heart, and this is what we call as remodeling. So are there drugs or mechanisms by which you can reverse this remodeling so as to achieve a near normal heart geometry, which should translate into a better outcome in terms of reduction of cardiovascular endpoints? So what are the options? The options are ACE inhibitors, ARBs, aldosterone antagonists, beta blockers, and ivabitrin. Other than, then you have cardiac resynchronized therapy or LVSS devices. Now, these these therapeutic modalities, they tend to reverse the cardiac remodeling. Beta blocker, which are commonest used, they cut down the sympathetic nervous system, thereby reducing the vasoconstriction, reduces RAS activity, vasopressin, heart rate, and contractility. The inhibition of renin-angiotensin system results again in reduced vasoconstriction, reduction of blood pressure, sympathetic tone, aldosterone, hypertrophy, and fibrosis. So we are aiming somehow with these therapeutic interventions to reduce the cardiac remodeling. Despite conventional therapy with ACs or ARBs, patients still have depressed cardiac function and increased risk of hospitalization because of heart failure and cardiovascular death. So no wonder we have the new kid on the block, which is the ARNI, which is now recommended as the first line of therapy for heart failure therapy. Now, does it result in cardiac reversal of the cardiac remodeling process of these heart failure patients? Well, yes, there are 4 trials which have looked. These are small trials, but very well designed trials, which have looked at about 660 patients followed up for about a year. And what is interesting is that almost half of these had either ICDs or CRT. Now, in this class of patients also, a significant number of patients who were treated assiduously with ARNI for 6 months or more showed significant improvement in cardiac remodeling. Now, the ejection fraction increased about by 5%, which I will tell you later. The left ventricular and diastolic volume reduced, and so did the left ventricular and systolic volume. The shape and function of the heart, the geometry optimized, with the result there was reduction in mitral regurgitation. And the left ventricular diastolic function also improved, which was discussed in details by Dr. Gupta. So we see that there was a roughly 5% increment in heart failure in the ejection fraction across these 4 studies, in contrast to ACs or ARBs, which increased by 4%, and beta blockers, which again increased by 4 to 7%. This is the absolute increase in ejection fraction in patients who are treated with RD for about 6 months. So in this particular trial, the blue line shows that the patients were on ACs or ARBs. And at this point in time, when these patients, they are shifted over to ARNI, the shaded part in this slide. You see that LVF significantly improves within 6 months of therapy, which is about 5%. And no wonder this would translate into improved survival and reduction in heart failure hospitalization. The left ventricular end diastolic dimensions reduced over a period of next 18 months, again, which means that the cardio remodeling is getting reversed. What happens to the end diastolic volume and end systolic volume? Again, in contrast to patients who are treated with ACE inhibitors, ARNI reduces it significantly. There is about a 30% versus 9% reduction in the regurgitant orifice area in patients who are treated with ARNI as compared to those who are treated with ACE inhibitors or ARBs. Similarly, in parallel, there is a 33% reduction of the regurgitant volume in patients who are treated with ARNI as compared to those who are treated with ACE inhibitors. Now, this is an important slide which shows that higher the dose of ARNI the patient is able to tolerate and you are able to administer, higher is the improvement in ejection fraction, which is a dose-dependent ejection fraction, which plateaus at 400 milligrams of ARNI. So within 6 months of therapy, within 3 months of therapy, you have significant improvement in ejection fraction in these patients who are treated with GDMT, especially including ARNI, in contrast to patients who are treated with the ACE inhibitors or ARBs. Yes, this I've already told you that there is an improvement in end diastolic volume index, and end diastolic volume dimensions compared with ACE inhibitors or ARBs. When you compare even with valsartan, which is ARB, these similar parameters are noted, that is the ventricular geometry, it improves significantly with patients who are treated with ARNI, even in contrast to those who are treated with valsartan. To summarize, cardiac remodeling is a major risk factor for progression of heart failure, and its prognosis has been evaluated through various parameters in heart failure patients. Aggravation of cardiac remodeling is related to risk of cardiovascular events and leads to significant increase in risk of hospitalization and death due to heart failure. Sacubitril valsartan can improve cardiac remodeling in patients with HFrEF, even in those who are on traditional optimal GDMT. Now, can there be a surrogate marker which will help us to guide that yes, the ARNI are working, and this surrogate marker will help us to say that yes, the cardiac remodeling is occurring and will result in lesser mortality and morbidity. Of course, anti-proBNP, we are all using it. It is released from myocardium in response to my hemodynamic stress, provides prognostic information in HFrEF, and the decrease in concentration is followed by improvement in the clinical parameters. So we see that the increment in ejection fraction and diastolic volume index and systolic volume index, it occurs in parallel in log way related to the amount of reduction in anti-proBNP. So more is the reduction of anti-proBNP, the more is the improvement in these parameters. What happens when you treat the patients of heart failure with the sacubitril valsartan? You see that the patients, in contrast to those who are treated with the ACE inhibitor, there is a much more reduction of anti-proBNP, which is a surrogate marker for cardiac remodeling being corrected. So the proof heart failure trial, it showed that within 14 days of treatment with the sacubitril valsartan, there is a 30% reduction of anti-proBNP levels, and which is about 37% at about 12 months, which basically means that whatever reduction occurs predominantly occurs within first 14 days to 1 month. And these are the parameters which improve with treatment with the ARNI, which is ejection fraction improves by about 5%. The end diastolic volume index and systolic volume index, left atrial volume index, and the E to E prime ratio, they all improve in parallel within 6 months of treatment with ARNI, and which we all know would result in improvement of the mortality status, the morbidity parameters. So just to finish my talk, to summarize, time is now to initiate sacubitril valsartan first-line therapy for heart failure patients. PROVE-HF shows significant correlation between anti-proBNP and cardiac remodeling parameters in HFrEF patients. More rapid and robust reductions of anti-proBNP might identify patients who are more likely to have reverse remodeling and benefit from therapy from ARNI. Patients with largest reduction in anti-proBNP and end systolic volume index with sacubitril valsartan by 6 months had lowest rates of subsequent death or heart failure hospitalization. Thank you.
Thank you, Dr. Jain, for sticking to time. Please stay with us. If at the end of session, if we have some time, we'll have some discussion. Now, I invite Dr. Debika Chatterjee to talk about quantification of mitral and aortic regurgitation. Over to you, Dr. Debika.
Yeah. Thank you, chairpersons. Can you see my slide? Not yet. Yeah. Can you see it now?
Yeah, please go ahead.
Okay. Thanks to the organizers for inviting me, and good afternoon, everybody. I'm going to talk on quantification of mitral regurgitation and aortic regurgitation. When we do echocardiography in mitral regurgitation or aortic regurgitation, other than identification of the regurgitation jet and knowing the etiology and its question, that is, how severe is the regurgitation? Or in other words, how much blood is regurgitating, or the quantification of the regurgitation. Because the answer of this question will decide the future line of treatment. It will decide whether we are going to medically follow up the patient, or we are going to send the patient to the surgeon for valve replacement. So echocardiography has become a standard of care for quantification of regurgitation, valvular regurgitation. Now, when we do the quantification of regurgitation, we don't stick to a single value or a single parameter. We take an integrated approach with 2D imaging, different indirect signs because of the hemodynamic consequences, and the color Doppler, and then we quantify the severity of the regurgitation qualitatively, semi-quantitatively, and quantitatively. So as we see that quantification of regurgitation is multifaceted. We take the information from various final diagnoses about the severity and the quantification of severity. And so when we take the help of two-dimensional imaging in MR, we look for the morphological changes, like here, the flail leaflets, or a papillary muscle rupture, or a wide coaptation defect, all are suggestive of severe mitral regurgitation. And then we do look at the indirect signs for chronic severe MR, like dilated LV, hyperdynamic LV, L enlargement, and the bulging of the IS towards the RA because of the raised LA pressure. And we do look at the sign at the color flow qualitatively in the apical 4 chamber, and then we measure the MR jet area, and then after measuring the jet area, we measure the LA area by tracing. If the jet area is more than 10 square centimeter, it's said to be severe. If the ratio of jet area to LA area is more than 40%, we say it's severe. However, we must remember that this measurement of the jet area or ratio is not applicable in case of eccentric wall-hugging jet, because you see this jet, though it looks much smaller than actually it is, because it's coming along the wall of the left atrium. So there is a risk of underestimation of the severity of the MR in eccentric jet if we measure the jet area. And by looking at the CW Doppler qualitatively from the 4 chamber view, a faint signal, incomplete signal, indicates mild MR, whereas a dense signal with early peaking giving a triangular shape indicates severe MR, because more blood cells are coming from the LV to LA. And we also look at the vena contracta width, which is a semi-quantitative measurement by color flow mapping. It's easy to do, quick to do, and it corresponds to the regurgitant orifice area. But we have to remember that ultrasound beam should be perpendicular to the MR jet, and the three components of the regurgitant jet must be visible. As you can see here, this is the flow convergence, and then the narrow neck, that is called the VC, and the jet area. So as in this case, it's all three are visible. So it's best obtained in the parasternal long axis view. As you have seen here, the flow convergence, vena contracta, and the jet area, and we measure the narrowest neck. If it is more than 7 millimeter, we say it's severe. We must remember that this VC measurement is not recommended in two-chamber view, because two-chamber view is parallel to the mitral valve leaflet coaptation line. So it's not valid in that case. And also VC measurement is not valid when there is multiple MR jet. And also we just cannot add all the VCs and give a value. That also is not recommended. And the validity of the vena contracta is limited in case of functional mitral regurgitation, because the regurgitant orifice becomes elongated and non-circular, whereas the accuracy of vena contracta is based on the assumption that the regurgitant orifice is circular, which happens in organic MR. So all these factors can be avoided if we measure the vena contracta area by 3D echo, which is relatively fast, more reproducible, can be applied in functional and eccentric MR, where we see the on-first view, and then with the help of multiplanar reconstruction, we measure the vena contracta area. Pulmonary venous flow is altered in mitral regurgitation. Normally, systolic is more than diastolic. In moderate MR, systolic is less than the diastolic, whereas in severe MR, there is a systolic flow reversal. However, as in this case, this method is a bit unreliable, difficult to do in adult patient, and has got many pitfalls. So we go ultimately to the quantitative method, where we are going to measure how much blood is actually regurgitating from the LV to LA. For that, we have two methods in mitral regurgitation. One is PISA and another is volumetric method. So the PISA method PISA means proximal isovelocity surface area. This follows the rule of fluid dynamics. It says that regurgitant flow converges in multiple hemispherical shells as it goes from the LV to LA through the regurgitant orifice. If we compare this LV with a water tank filled with water and we open the valve, the water comes out forming different multiple hemispherical shells, and the flow in that most proximal hemisphere is equivalent to the flow at the regurgitant orifice. So we need to find out the proximal isovelocity surface area. But if we look here, we cannot differentiate the multiple hemispheres. Mind it that we are working with full scale of 58. So what I am going to do, I'm going to reduce the Nyquist limit in the direction of MR jet. So reducing the baseline between 30 to 40, here it is 38, will reveal the proximal isovelocity surface area, because I can see the yellow first proximal surface area, then the blue, and then dark, light blue, then dark blue. So the interface between the yellow and the blue is the margin of proximal isovelocity surface area. So I measure that, and then with full scale, I measure the velocity of the MR and the VTI. Then after that, I apply the values in the famous formula for PISA. You see where ERO can be obtained, putting the value of pi, and radius is the PISA radius. Aliasing velocity, we know the velocity of the MR jet. Thankfully, our machine does all the calculations. We need to measure the radius only. So once we get the ERO, not very difficult to get the regurgitant volume by multiplying ERO with VTI of MR. And in severe MR, ERO is more than 0.4 square centimeter, and regurgitant volume is more than 60 ml. But we do face some problems while measuring the PISA. There might be multiple jets and it's unreliable in eccentric MR. And sometimes we find it difficult to delineate the PISA margin. Another method is volumetric quantification of MR, where we use the pulse wave Doppler. The advantage is in this case is that we can use in presence of multiple jet and eccentric jet. So what we do, we just find out the stroke volume across the mitral valve. We take the interannular radius of the mitral valve, and then putting the sample volume at the level of the annulus, we get the pulse wave Doppler, and then we trace the mitral forward flow to get the VTI. And the moment we do that, we get the stroke volume across mitral valve. Same way we do the stroke volume across the aortic valve, provided there is no regurgitation, and taking the LVOT diameter, and then putting the the sample volume of the pulse Doppler at LVOT, we get the LVOT VTI, and we get the stroke volume across the aortic valve. And then once we deduct the stroke volume of mitral valve, stroke volume across aortic valve, from stroke volume across mitral valve, we get the regurgitant volume. In severe MR, it's more than 60 ml. And once we get the regurgitant volume, we can get the regurgitant fraction by dividing the volume with mitral valve stroke volume into 100. And in severe MR, it's 55%. And in my case, more than 55. In my case, it was 81, which is quite severe. We can also get the effective regurgitant orifice by dividing regurgitant volume with MR jet VTI. In severe MR, it's more than 0.40 square centimeter, whereas in my case, it was 1.1 square centimeter. So these are the things we do for mitral regurgitation. Now let us move to the aortic regurgitation. Quantification of aortic regurgitation, where again we follow that integrated approach by looking at the two-dimensional imaging of the aortic valve. Flail, white coaptation defect in the aortic valve suggests severe aortic regurgitation. We do look at the indirect signs like dilatation of the LVH at some stage. And also we look at the diastolic flutter of the ML by doing the M mode at the mitral valve, because it's hitting the anterior mitral leaflet. And then we start looking at the color flow mapping qualitatively, where we never look at the length of the AR jet in the LV. We rather look at so after looking there, we try to assess qualitatively how severe it is. A small central jet indicates mild, whereas a large central or a large eccentric jet indicate a severe mitral aortic regurgitation. We also look at the density of the CW signal of the AR jet by doing CW Doppler in the apical 5-chamber view. Its faint signal indicates mild, but the dense signal indicates severe aortic regurgitation. We can measure the deceleration slope, where it's very slow with the pressure half time more than 500 in mild and less than 200 in severe aortic regurgitation. And then we move to the diastolic flow reversal in descending thoracic aorta from the suprasternal view. As you can see, this is the descending thoracic aorta, and there should be only blue flow, but you can see the red flow. It indicates mild AR because there is brief early diastolic flow reversal. Whereas look at this patient, there is a hollow diastolic flow reversal, and we can get this this finding confirmed by doing the M mode across the descending thoracic aorta. Look at the diastolic period, only early diastolic flow reversal in the M mode, as well as pulse wave Doppler, keeping the sample volume at the level of the second branch. There is only early diastolic flow reversal. On the contrary, in this case of severe AR, there is a hollow diastolic flow reversal in the M mode as semi-quantitative measurement, where we measure the vena contracta of aortic regurgitation. That we do in the pasternal long axis, and that should be on the LVOT side. just below the aortic valve, where the flow still continues to narrow, as you see, not here, but it's in the narrowest portion of the jet. So this is the measurement. If it is more than 0.6 centimeter, we say it's severe. And we can also measure the height of the air jet and then height of the LVOT and take the ratio. And then that we do in the plaques within 1 centimeter of the vena contracta on the LVOT side. This time we are going to measure not the narrow because we are taking the ratio, how much of the air is covering the LVOT. Both the measurements should be taken at the same cross-sectional level in this way. If the ratio is more than 65%, we say it's severe. Because there is a pitfall in measuring the vena contracta and the jet height, LVOT height, in eccentric air. As you see, this eccentric air is originating actually much more anteriorly here, and then it's coursing along the aortic valve. So you cannot measure here the vena contracta, because if you want to measure, you have to measure laterally, which is not recommended. So lateral measurement of the vena contracta is not recommended. We cannot measure vena contracta here. And then we can also measure semi-quantitatively the cross-sectional area of the aortic jet and cross-sectional area of the LVOT in the parasternal short axis at the level of the great vessels. Only we have to remain slightly towards the LVOT so that we can see the regurgitant jet properly. And if the ratio is more than 60%, we say it's severe. And then we come ultimately to the actual quantification of the amount of the blood regurgitating into the ventricle from aorta, where we use volumetric method using the PW Doppler to get the values of regurgitant volume, fraction, and regurgitant orifice area. This is my patient. If I want to measure the regurgitant volume, we again follow the same rule. We find out stroke volume across aortic valve, and then stroke volume across a competent valve, which might be mitral or pulmonary, provided there is no regurgitation, no significant mitral regurgitation. So first we measure the stroke volume across aortic valve, which I already described, and in my case it was 139 ml. And then we measure the stroke volume across the mitral valve by measuring the annular diameter and pulse wave Doppler, and I get 106 ml stroke volume across the mitral valve. So the regurgitant volume is 33 ml in my case. Once we have the regurgitant volume, it's not very difficult to measure the regurgitant fraction by dividing volume by aortic stroke volume into 100, which was 29% in my case. And effective regurgitant orifice area was 0.18 square centimeter, which I obtained by dividing regurgitant volume with air jet VTI, which I have measured here. And after getting the tracing with CW Doppler, I traced the VTI of air, and I got the ERO. So, ladies and gentlemen, to summarize, I would say that quantification of valvular regurgitation has severity is really now a standard of care in echocardiography, and we never rely on a single value or single 2D or Doppler method to grade the severity here. Rather, we follow an subject to variability. Thank you.
Thank you, Dr. Devika. This was a very comprehensive assessment talk. I now invite Dr. Atul Karande for his talk on myocardial work, current significance in clinical practice. Over to you, Dr. Karande.
Estimation of LV systolic function is essential in all cardiac diseases, and ejection fraction still is the most commonly used parameter because it has been proved to be a prognostic parameter in numerous studies. However, there are many limitations of ejection fraction, like it depends on loading conditions, and there is a wide inter-observer as well as intra-observer variability. Global longitudinal strain by speckle tracking echocardiography provides more detailed information about global and segmental systolic function and also gives us opportunity to detect subclinical dysfunction. This is a patient of severe aortic stenosis. The ejection fraction looks normal and the strain is impaired significantly. But at this point of time, it is very difficult to establish that whether this impaired GLS is due to increased afterload or due to impaired contractility. And the myocardial work gives the answer. If the GLS is decreased and the myocardial work is increased, this indicates increased afterload. And if the GLS is decreased and the myocardial work is also decreased, then it indicates impaired contractility. Myocardial work is a novel echocardiographic method which can reduce the afterload dependent limitation of GLS by incorporating LV afterload into the analysis of longitudinal strain. Myocardial work is more sensitive index of segmental and global LV performance compared to ejection fraction and global longitudinal strain. Myocardial work is not a new concept. The original experimental study was published in 1979. They evaluated the myocardial work by pressure-volume relationship, which reflects the myocardial oxygen consumption and eventually the LV performance. The pressure-volume loop, however, is an invasive method, so it can't be used in routine clinical practice. Razel in 2012 introduced a non-invasive method to measure myocardial work. Work is a product of LV pressure and stroke volume. Blood pressure can be used as a non-invasive surrogate for LV pressure in absence of aortic stenosis. And global longitudinal strain is closely related to stroke volume, so it can be used in place of stroke volume. Non-invasive myocardial work is derived from estimated LV pressure via brachial cuff BP and measurement of strain. The pressure strain loop, or in short the PSL, works in counterclockwise direction from mitral valve closure to aortic valve opening to aortic valve closure to the mitral valve opening. These are various components of myocardial work which are measured. The global work index is the total work performed by the left ventricle during isovolumic contraction, ventricular systole, and isovolumic relaxation. This is reflected by the area within this PSL. Global constructive work is the work performed by the left ventricle during systole that is productive, which includes the shortening of the muscle during the systole and lengthening during the isovolumic relaxation period. The global vested work is the work performed by the left ventricle during systole that is not productive, including both lengthening of the muscle during systole and shortening during isovolumic relaxation. Global work efficacy is the ratio of constructive work to the sum of constructive and vested work. The myocardial work components, except the global work efficacy, have the same units, that is millimeter of mercury percentage, as they reflect the power of the cardiac cycle longitudinal strain. Global work efficacy is expressed in percentage as it is a fraction. How to measure the myocardial work? Very simple. Mark the aortic and mitral valve opening and closing time. Measure the strain as usual and enter the blood pressure. And the machine automatically provides bullseye of the global work index and global work efficiency for the LV with all 17 segments. On the same screen, values of all myocardial work components and bars indicating the relationship between constructive and vested work are displayed. By choosing a specific segment, we can compare the global and segmental work index along with their PSL at the same time. The global work index bullseye can also be assessed visually with a color scale. The red indicates area of high work and the green indicates area of normal work and blue shows areas of negative work. Now this is bullseye of myocardial work efficiency. Now here the color code is different. Here the red indicates low level of efficiency and green indicates high level of efficiency and the yellow is in between. Now these are the normal reference values recommended by various studies. The most commonly used values are from EACVI in our study. Now here we can see that the value of all the myocardial work component except the myocardial vested work are higher in females compared to the males. So male hearts have more vested work rather than constructive work. Now coming to clinical applications. Myocardial work was first described and validated in patients undergoing CRT for cardiac dyssynchrony. In a normal heart, all 17 segments contract at the same time and produce a very little vested work, and the myocardial work efficiency is 98%. In presence of LV dyssynchrony due to LVB, the septal segment lengthen during systole and contract during isovolumic relaxation period, producing a lot of vested work. One of the major issues in dyssynchrony is to predict that which patient will benefit from CRT. A lower global work efficiency before CRT is independently associated with better long-term outcome in heart failure patients with a class 1 indication for CRT. For example, in this patient, the global work efficiency was 62% before CRT and it improved to 84% after CRT. Patients with global work efficiency less than 75% showed lower event rate than patients with efficiency of more than 75%. This is another study where septal vested work along with wall motion score index was used to identify patients which will respond to CRT. This is a CRT responder patient. The vested work was in 3 digits before CRT and it significantly dropped down to single digit after the CRT. This is a CRT non-responder where the vested work was only in moderate range in 2 digits, so there was not a significant drop after CRT. Myocardial work is also helpful in assessment of response to CRT. In this study, the work difference between the septal and lateral wall combined with the viability detected by cardiac MRI were the parameters to predict CRT responders with an AUC of 0.88. Prior to the CRT, there was a significant difference between the work produced by the lateral wall and septum. And after CRT, actually the septum surpassed the lateral wall. Another study showing that patients with constructive work more than 1057 millimeter Hg% display better response to CRT. On multivariate logistic regression analysis, only the septal flash and global constructive work remained significant predictor of CRT positive response. In non-ST elevation MI, presence of reduced segment aided in the identification of acute coronary artery occlusion. This was an important factor in the selection of patient for prompt intervention. This is bull's eye plot showing segmental work. Myocardial work index of 1700 mmHg was taken as segmental work cutoff, and 8 of the segments had impaired systolic function, and the coronary angiogram revealed an occlusion in the right coronary artery. In ST elevation MI, patients treated with primary PCI and optimal medical therapy, the regional value of myocardial work index in the culprit vessel indicated by these blue areas before discharge is independently associated with early LV remodeling. In the same study, along with regional wall motion index in the culprit vessel territory, the pre-troponin T levels and LV and diastolic volume were independently associated with early LV remodeling. Myocardial work has been assessed in valvular heart disease with encouraging results. In aortic stenosis, afterload is increased, but systolic blood pressure cannot be used as a surrogate for LV systolic pressure. Renuka Jain in her study added the mean aortic gradient to the blood pressure in the aortic stenosis patients as a better approach to estimate the LV afterload. Before AVR, GLS was decreased, but the myocardial work was increased, indicating that low GLS is due to increased afterload rather than due to myocardial damage. After the TAVR, the myocardial work index was reduced immediately after the intervention and the GLS improved. Myocardial work can also be beneficial in evaluation of cardiomyopathies. This study shows that the non-ischemic as well as ischemic cardiomyopathy Both the global work index and global work efficiency were significantly impaired. The global wasted work was increased in SCM population, while all the components of other components of myocardial work were significantly reduced. The red curve represents normal global LV-PSL, while the green curve is the deviating PSL of the septal segment in a patient with septal non-obstructive SCM. The bullseye plot shows significantly decreased myocardial work efficiency in the septal segment. In this study, they demonstrated the additive value of global constructive work in different phenotypes of SCM and correlated it with the survival. Here we can see that in septal SCM, the constructive work is impaired in septal region. Here it is impaired in all mid and basal segments. And in apical SCM, the constructive work is decreased in apical segments only. Several studies have been performed on myocardial work and stress echocardiography. During normal exercise, global work index increases. GLS also increases, but the myocardial work efficiency remained unchanged. With exercise-induced ischemia, segmental myocardial work decreases in affected segments indicated by these blue areas. The GLS decreases and the global work efficiency also decreases. In patients with ischemia, constructive work did not change significantly after exercise, while the wasted work increased. In normal subjects, constructive work increases after exercise with a little change in the wasted work. In cardiac amyloidosis patients, they have significantly reduced baseline global work index compared with the healthy controls. With exercise, the differences are even more pronounced. Global work efficiency decreased in the cardiac amyloidosis patients after exercise, but it remained stable in the control group. If we compare the segments after exercise, there is an increase in the myocardial work index in the apical segments with no remarkable increase in the basal or mid segments in the subjects with cardiac amyloidosis. In controls, the myocardial work index increases in all the segments. Every measurement has got limitations, and myocardial work is not an exception to it. Myocardial work is derived from strain analysis, so bears the same limitations like 2D image quality should be good, frame rate should be adequate, strain tracking should be accurate. Myocardial work is dependent on vendor platform and requires proprietary software that is currently available only with a single vendor at this point of time. Now, the force or afterload exerted on the left ventricle is more accurately reflected by wall stress rather than LV pressure alone. And wall stress is governed by this formula. Therefore, the LV afterload is directly proportional to LV pressure and radius of the ventricle, and it is inversely proportional to the wall thickness. So, as the wall thickness increases, the afterload decreases. And as the ventricle dilates, its radius increases and the wall stress also increases. So, in dilated ventricle, wall stress will be higher at any given pressure compared with a smaller ventricle. To incorporate wall stress into the measurement of myocardial work, the recently proposed LV stress strain group areas integrate the information on wall thickness, radius of curvature, and LV pressure to estimate the wall stress rather than LV pressure alone. And this may be feasible in future by incorporating the method into 3D echocardiographic software. So the take-home message is myocardial work is an advanced analysis of LV function by including blood pressure and afterload. It is more sensitive than GLS and ejection fraction as it overcomes load-dependent limitations. Clinical application can be applied across a variety of diseases. Although the prognostic implications and use in clinical decision making require more research, there is much promise in the utility of myocardial work for advanced assessment of cardiac function. Thank you very much.
Thank you, Dr. Atul. This is a great presentation. Do we have other chairpersons? Any comments or any questions from our I think it's lunchtime then. So that we can end the session.
And it's also like we are, this was the last session for the day today. So we would be also closing the hall B at the same time.
Okay.
So this was the last session. I will just check with the organizers once again.
Yeah.
That
Sure.
if in case we need to keep it open for other sessions.
No, there's no other session. We have talked about it. So it's okay.
Nitish, this is the last session that we have in Hall B. The next thing that we have will be the sessions at Hall A, and then 6 p.m. we have the closing.
Okay. Thank you, everyone. Bye.
Yeah. So with this, we come to the end of this session. But before closing off, I would request everyone to please turn on their cameras, unmute their lines, and let's hear it for all our speakers who have presented during the session and our moderators. So I've said this on the gallery view. Let's hear it for all our speakers and our moderators for the session. Amazing. Fantastic. So with this, we come to the end of Echocon Delhi and NCR 2022 Digital and Hybrid Meeting organized by Echocardiography, NCR chapter on echocardiography and clinical cardiology at Hall B. This is your host Diksha Raina signing off, and we'll see you again at Hall A for the closure ceremony at 6 p.m. And in case you want to join the Hall A. There are a lot of interesting sessions happening in Hall A. I would request you to please join Hall A for further sessions. Thank you. This is Diksha Raina signing off. Until we meet next time. Till then, stay safe and keep smiling. Thank you.
Yeah, so here you can see the arch of the aorta, and I don't see a clear, there seems to be a very narrow neck and a pseudoaneurysm coming from the neck of the distal arch.
Okay, next slide. Any more
That's,
information?
no,
Not
nothing.
then nothing. This one.
Yeah, these are just reconstructions of the same thing. It seems to be coming from the aorta. There seems to be a breach from the aorta only.
Okay, this one.
Again, the same.
Same. This is also the same. This is contrast.
Yeah.
Nothing else could be extra when we pullated. So there is a report from the KM Hospital, Mumbai. They say there is a left-sided mediastinal query aortic aneurysm. That time they are also not sure even with the CT this is aortic aneurysm. So did the MRI chest. So again is the MRI. This is the MRI.
Yeah, again
Any
a
more?
very similar lesion, and again
Similar
we can
lesion,
see that-
similar information. Nothing more.
Yeah.
What I read it, and this is the another view. And again they reported left-sided superior mediastinum, a large vascular mass, query aortic aneurysm. Again there is a put in the query. So what I do is that, so CT aortogram, and that gives the diagnosis, I think, is anything this one, and otherwise they have the 3D reconstruction here is in, and you can see these arising from the aortic arch, and this is self-explanatory, and they reported is a large mass is arising from the aortic aneurysm involving the distal aortic arch and the left subclavian. The purpose of presenting this case is that even when you saw this type of in the chest X-ray, even if you do not take all the modalities in TIC, you may not reach the pinpoint diagnosis. Am I correct, ma'am?
Yes, absolutely. I agree.
So
We live in a world of multimodality imaging.
Now is in the most interesting session, and ma'am is of great will explain everything about the echo MRI. We have a three very interesting case. I'll show you. First is a 50-year-old man, the recurrent chest discomfort, dysmenorrhagmus, and palpitation for the last 2 years. There is an intermittent episode of guidelines, date of examination, dyspnea exertion, frequent misbeats, admitted with the retrosternal discomfort, arrhythmia, ECG, multiple recordings showed sometimes normal, sometimes frequent supraventricular, sometimes ventricular premature bleed, sometimes some interventricular conductivity. I'll show all the ECGs. This is a normal ECG, and you can see the tachycardia with some supraventricular ectopics, and you can see the ventricular ectopics, and you can see the both supraventricular and ventricular ectopics in the different form, different ECG I collected. One echo was done first. They have described as a dilated left ventricle valve, a kinetic infraposterior valve with a moderate systolic dysfunction with the moderate pulmonary arterial hypertension. They did in an outside hospital, they did the angio, coronary angio, and because of the acute chest pains, and the right coronary artery is normal. You can see the other coronaries are also normal, and these are the different views and normal. So it's a normal coronary angiogram. And this patient was put on the medical management. Holter monitoring showed few VPCs. Chest X-ray, there is a only widening of the paratracheal soft tissue. CT thorax, there is a right paratracheal lymphadenopathy and right pleural thickening. ACE level is only 34, and another was 47. And when you did the first echo, see, this itself is a very, very important information is given. Here is a basal thinning of the interventricular septum. And this picture is so important to look at in any case of such of a history, is that it has to be looked at the basal thinning. And you can see this basal thinning is, you can see very beautifully the basal thinning. And this is the net picture, and this is our picture. And this characteristic is very characteristic of something else, I'll tell you. And there is a moderate MR, and there is some hypokinesia in the infraposterior wall. But what is more important is to look at the interventricular septum very, very carefully. There is a thinning of the basal thinning. Of course, there is a mid and apical part. There is some thickening is there. But what is the whole of the interventricular septum is that some beaded appearance and some fibrotic appearance is there. And you can look at this very carefully. There's some beaded appearance. I'll zoom it. You can see the beads and fibrotic appearance. This is our picture, and this is the net pictures. And then other way, find out the grade 1 diastolic dysfunction is there in this case. Inferior vena cava is nothing to comment about. And when you do the GLS, we get the variegated appearance. It's not conforming to any of the territory of the coronary artery. So what we did is the abnormal thinning of the basal interventricular septum is the patchy areas of bright echoes. These are called speckled or snowstorm pattern due to areas of granulomatous infiltration. This is a very highly suggestive of cardiac sarcoidosis. In fact, this patient was a cardiac sarcoidosis. Then you did the CT thorax, multiple enlarged distinct lymph node in the pretracheal, paratracheal, and the epi window. Cardiac MRI is suggestive of infiltrative cardiomyopathy. I'll show the cardiac MRI of this patient. EBAS guided aspiration, there's a scanty reactive lymphoid cell, but EBAS guided TBNA biopsies was somehow is an inadequate sample. ACE level was 47, urea creatine criticism, a mild elevation. We started with the immunosuppressive therapy, prednisone initial dose of 1 milligram per kg per day for 8 weeks, followed by the tapering of the dose with careful assessment of the cardiac function. And this patient is doing well. He's the father of a doctor. And after 6 to 7 months of steroid therapy, patient improved symptomatically. Echocardiography, improvement of contractility of the inferior posterior and the lateral walls, improved ejection fraction, reduction of the mitral degradation, and patient is on maintenance dose of the steroid. Ma'am, this is the rubidium and the FDG PET we did it in this patient. Can you describe it so for the audience and the others?
I don't normally read PETs actually.
Okay. So
but it is evident that the anterior superior, the septum and the anterior wall, they are showing less uptake, whereas the posterior walls. But I think I'd leave this to the PET expert.
And I think in the any of the panelists can describe in the PET. I'm not, but what they reported is I can show there's a delayed gadolinium enhancement is found predominantly in the mid myocardium and the epicardial areas, but rarely in the endocardium, mainly at the basal and the lateral segment of the left ventricle. There is a perfusion defect with intense FDG uptake in this region, suggestive of myocardial inflammation. And the normal myocardium has no FDG uptake because it is using free fatty acid. And now is the MRI. I'll show the MRI. and there is a cine also there. So I'll go on the slides. If anything strikes you, we can describe. And this is one. This is
So
two.
you can see that all these areas which are white, the myocardium should be black. And here you can see lots of areas of the white is all scar within the myocardium. So you can see that there's involvement on the RV side, there's involvement of the basal septum and of the lateral wall. And all these regions which are now showing white within the black myocardium, these are areas of scar, and these are very typical locations for sarcoid.
Okay, thank you, ma'am. There's another one. I think it's a blood pool one.
Yeah.
Yeah, with lead gadolinium enhancement.
No, this is not late gadolinium enhancement.
Oh,
No, this is a black blood image.
Black blood image. And this is the
And this is just a moving BTFE, and it shows that the anterior wall and the seb is moving in this akinesia, some bulging of the LV cavity.
Another, I think, another one. This one. Same thing, I think.
These are all BTFE images, but these will be very similar to the echo images. What is really important is to use the late gadolinium enhancement and the T2 weighted imaging to look for edema and scars.
I don't think. Oh, no, another one is there. Let's see this one.
Yeah, this is also moving image. This will only show you the extent of wall motion abnormality, which is very similar to what you would see even on echo.
In the echocardiogram.
Yeah, but I feel that the lateral wall of this patient is also looking like a little bit of a non-compaction. As we go towards the apex, I feel that there is some element of hypertrabeculation, but that sometimes also happens when there is a long-standing DCM.
Okay, that's happened, sir. That's happened. So these are, I don't think these are the features actually we get in the cardiac MRI. You have already described, so I'm not wasting in the time. There is what you saw is the acute macular impairment is the focal areas of thick and increased signal intensity on T2 weighting images and early gadolinium enhanced image. And now another one.
What was your echo diagnosis? When you
yes, sir. Echo diagnosis. So there is a variety. There are 3 experts has been seen. First, we saw that they thought is a case of ACS. They did the angiography, one hospital. The second hospital, they thought it could be some myocarditis. And when it came to our case, when we saw the basal thinning with this snowstorm and apical cadence, then we subjected this patient for the CT and we did the biopsy and all these things, and the diagnosis is confirmed with it. So basal thinning with this that is the speckled appearance in the interventricular septum. These are the 2 beautiful hallmark signs of the cardiac sarcoidosis that you won't get in any other disease. This is very important. So another interesting MRI is also, it is a story of a 9-year-old boy presented with the cyanosis and clubbing. There is a shortness of breath, mild hepatomegaly. There is you can see the cyanosis and clubbing in this case. And there is a flushing of the eyes of the conjunctiva, and you can see in this patient. This is the chest X-ray. Madam, I don't think anything to describe in the chest X-ray is a normal. And ECG is also of child ECG, it's normal and for a child. And now see the echocardiography, the first. Look at this echocardiography, very careful. See, this is the LV, and what you see, there is an aneurysmal dilatation of the LV apex. And the RV is looking a little hypoplastic. This is the first impression we got. But look at this, all the pictures very carefully. There is a lot of images in there. And there is a RV, and this is looking like the apical aneurysm. And this is the RV outflow tract, and RV outflow tract look is absolutely normal. And these pictures I'll show you is a very important thing. See, look at the LV very carefully. See, look at the margins of the LV up to this area is absolutely smooth wall margin. But look at this margin is highly trabeculated. This cannot be a LV margin. So what happens? This is a part of actually the RV. This is the trabecular band. So there's a large apical VSD that is contained by the trabecular band. And this is actually the part of RV incorporated into the LV. And now you can see the subcostal view. There is an PFO with absolutely right to left side. And now this is another picture, another picture, another picture, all of the same type of picture. And also the outflow tract. Outflow is very well developed outflow tract, well developed pulmonary artery, no flow acceleration, anything was there. And even the tricuspid flow is normal. And I have measured the tricuspid annulus, and the Z value is absolutely normal, more than 2. And so tricuspid annulus is absolutely normal. There is a little tear, and tricuspid flow is absolutely normal. So that is flow is normal. So what we saw in the echocardiogram is a large apical ventricular septal defect with the separation of the right ventricular apex from the remaining RV. By excessive trabeculation, they are eliminating any of the left to right sun across the ventricular septal defect. It's actually the rare and distinct type of morphology. Very few description in the world. Physiology. Physiologically, there is no apparent hemodynamic disturbance. But why there is a cyanosis and clubbing? Because the right ventricle, the basal cavity size RV inflow are normal. Tricuspid annular diameter is 16 millimeter with a Z score of -1.86. Right ventricular outflow tuck normal. Normal out on the main pulmonary artery, confluent and the good size branch PA. Apical segment distal to the moderator band is integrated to the left ventricle, resultant apical dilatation of the left ventricle. There is a large apical muscular defect of ventricular septum closed by the moderator band. And the resultant functional hypoplastic right ventricular cavity with increased RV and diastolic pressure, there is increased RAP. That's why the right left side across the large BSD. So this is actually the picture. That time that somewhere in the BSD was there, and that is being closed. Here we do it, actually the MRI, what will show? If you do the MRI, there's a separation of the right ventricle from the remaining RV by excessive trabeculation. They are eliminating any of the right to left side across the defect. And the MRI short axis views through the defect at an apical level of 10 millimeter above were taken. And what they describe is, here is the, ma'am, you can describe it, or what they have told me and they have taught me is that the red one is the LV, green one was the RV, and there's the white one is the actually the RV part incorporated into the LV. I don't know exactly that this is how to MRI the read, but this is the description given by the MRI people. So this is the distinct type of MRI we can saw in this color coded thing. The blood pool between the red and white is and the uncolored brigade is the blood pool between the red and the blue, resembling the physics, which was actually the time where is the PSD was there. But what is that? This type of apical VD constitute a rare and distinct type of morphology, and the physiology has to be considered in patient with the suspected LV aneurysm in a child, or in an adult even, absence of coronary artery disease and the lack of any heart mouth. Our patient is symptomatic with class 3 DOE. Cyanos failed to gain weight. We do not know what can do further for the child because there is no apparent hemodynamic disturbance. So what happens in this case? This is the coral bridge. You can see in Andaman, lot of coral ridge. When it completes, it's called coral bridge. Here it forms the coral bridge. And last case of the echo MRI, I'll say it, 50-year-old lady presented with the evidence of right heart failure, facial puffiness, dependent edema, ascites, systolic murmur at picodium, DOE. You can see in this case there's a thickened myocardial, LV myocardium, is a small pericardial effusion. Systolic function is fairly maintained. There is a moderate tricuspid regurgitation, moderate mitral regurgitation, and E by E prime is a restrictive pattern. And you can see a mild elevation or mild to moderate elevation of the pulmonary artery pressure, the dilated inferior vena cava with the reversal of shunt into the hepatic vein. And here you can see the definite thickening of the interictal septum. So we diagnose clinically or echocardiographically is the case of probably the amyloidosis. I'll say another case, second case. Similar pattern you can see. Maybe a mild systolic dysfunction is there, but the thickened myocardium with the central corridor signs, what you call it, is a central corridor sign. Everything is there. And almost similar picture is like that. You can see almost similar picture and the color flow and the same restrictive type of diastolic pattern. And now in the first case, when we did the GLS, we saw there is the apical sparing, the cherry on the top, whatever that is. But second case, again in the cherry of the top. So can tell the clinically, echocardiographically is both the case of amyloidosis. But now, look at the ECG of the first case. Of course, this confronts the low voltage complexes, and this is very consistent with the amyloidosis. But C diagnosis, the first case is amyloidosis, almost confirmed. Now, look at the second case. Almost similar case, echocardiographically, even up to the GLS is same. But with this ECG, is very, very difficult to describe. This is a case of, probably this is a, most likely this is a case of hypertrophic cardiomyopathy. So what we did there, we did the MRI. So what will be the MRI of the cardiac MRI? So these are the actually features the ma'am will describe. What will this? Also the MRI. The first serious slide. Ma'am, you go on telling the MRI because
yeah. So basically, a BTFE image showing the myocardial thickening.
Thickening. Second one.
Again, the same thing. We are seeing a concentric myocardial thickening, and it's also
including the RV also.
RV and the septum. Also, the interatrial septum is thickened. Here you can see a very diffuse gadolinium enhancement, and this enhancement is usually circumferential. It does not follow coronary artery territory, and it is in the subendocardium. It starts from the subendocardium and then becomes transmural.
And this is the dark. This is the normal vision for comparison, and here you can see the dark blood pool. I think so. This is the dark.
And here you can see, and over there you can see again the enhancement along the subendocardium.
And there is a, you can see the pericardial, ma'am. This is a pericardial effusion. You can see the pericardial effusion. So this is a classic case of amyloidosis in a case of. Now let us second case in the significant hypertrophy of the basal interventricular septum with late enhancement and good contraction of the both ventricle and no focal wall abnormality. So this is the MRI of the.
Here you have a asymmetric septal hypertrophy.
And another slide.
Yeah.
Same thing. And this is actually the slide, ma'am. This is the mid-ventricular obstruction. In another slide, the mid-ventricular obstruction, they are showing in the MRI. The senior slide, I think is not running.
Here again is a mid-ventricular.
And you can see the MR also. You can see the MR also in the window. So only the now is the importance of the multimodality imaging. See, even with the GLS, the cherry on the top or the apical sparing, everything can happen in the echocardiography, and the MRI will give the diagnosis. Of course, ultimate diagnosis is by the biopsy, but we do not do the biopsy in all the cases. So multimodality imaging is the most important. So another is MRI, you can see in these cases. So this is there. Oh, sorry. And now is the echo, another case. This is not an MRI. This is the echo operative footprint. This is the last case, and this will take a little time. And I'll show the very important slides in this case. And if time permits 5 minutes, I'll show how this case has been managed. 50-year-old lady presented with the dysphagia of solids only, known diabetic and hypertensive, fairly controlled, past history of pericardial effusion, treated conservatively, no other significant history, and unremarkable clinical examination. So this is the first slide. So the parasternal long axis view. What we can see in this, there is a mass within the left atrium, is a variegated appearance, and it is almost filling the left atrium. We do not know what is happening here and there, but other views will be there. So this is the contractility of the LV and the RV. This is okay. And when you see this op-axis view, we can see the mass, well circumscribed mass, you can see within the left atrium. This is the left atrial wall, and you can see this is not attached to the septal wall, but in the other walls is the wall. If you see the RV outflow tract and the pulmonary artery is absolutely normal. And this is a 4-chamber view. You can see here it seems to be attached to the interventricular septum with some, I don't know, this is a part of the there is some cystic appearance, cystic degeneration of the appearance or like that. This is thought this is attached to the interatrial septum with some cystic degeneration. Frankly speaking, while I'm doing the echo, this particular patient, I thought, this is coming in my mind with whether I'm dealing with the case of left atrial myxoma with a cystic degeneration or not. And that is kept in my mind, first coming into the mind. And this is, we can saw that there is some mild to moderate air is there, but there is no obstruction in the outflow tract. And this here you can see, and this is a zoom view. You can see this very clearly, and now you can see the extent of the mass. You can see there is some cystic degeneration, or what we call cystic formation, cyst formation within the mass, and this is a variegated appearance is there. And now come to the, we have time of 13 minutes time, so we can describe any of the panelists. What is the first echo diagnosis?
Looks like a myxoma, but it's kind of fixed. Very little mobility of the mass.
Okay, that's one possibility. That same thing came to my mind. And any other possibility?
Think of angiosarcoma as well.
Yeah, sarcoma could be another possibility. There is a cystic degeneration possible. And any other possibility? Well, if not, I'll go to the area. This is subcostal view. And this you can see the intertidal septum. You can see it looks like it is attached to the intertidal septum. Looks like, but I'm not sure. There is maybe even it is not pedunculated, but it's a broad attachment is there. Could be. So that is there, and you can see the superior vena cava flow is okay, fine. There is no obstruction to the superior vena cava flow. And sorry, before going to the MRI, so this is our diagnosis. Now I'll go to the MRI. So let's see the first of the MRI. MRI, this is the picture given by the MRI man. Is from, I got it from the Manoj Jain from Ambi Salt Lake. And this is the MRI, the first slide. And this is the second slide. Madam, you see first all the slides and then you will describe and I'll tell you whatever it is there. Second slide. And this is the third slide, and last one is this is the fourth slide. These 4 images, I got it. Ma'am, whatever I got may not be a very good picture. I'm not satisfied, but whatever I got it from my colleague. So can you describe anything?
Dr. Mana, is it looking conclusive? I think difficult to make out.
This is not, but what I got it from this slide, this is within the LA, and another slide, sorry, this one, and the slide, sorry. Another slide, you can see some communication maybe from aorta. So that is there. There's some communication from the aorta, maybe the what cystic appearance, what we see is that this is the area of the cystic appearance, and this is it, but not conclusively. Now we do the CT angio.
It looks like a thrombosed area, thrombus of the aneurysm of the base of the aorta.
Yeah. Now CT angio is very, very classical. You can see this is arising from the arch of the aorta, and you can see, but still not sure. Probably this is the iris from the arch of the aorta, and this is the aortic aneurysm.
Then it's pushing down into the LA.
LA pushing down into the then they thought they will operate it. So in operation, they will do the intraoperative. And in intraoperative, now it is pretty clear this is the aorta, and there is a communication from the aorta into the aneurysm and to the aneurysm. So this is basically, so keeping all the modalities.
Back to the echo, did you get a chance to see the aortic valve in this patient?
Yeah, aortic valve. We saw the absolutely normal aortic root. What I saw from the personal long accident and from the ascending aorta is absolutely normal. But I'll show you, ma'am, I reviewed the echo again. What I saw, I'll show you.
That's what you have.
I'll show you. This is the, now this is the slide. I'll go to the slide, this one. So I reviewed the subcostal file. The first. So what I got it, from the go to the subcostal view, I find other than superior vena cava flow, there is some flow is coming. So I zoom this area, and now we can see there is a communication into these aneurysm also done. Now you can see the flow within that flow, what you could show in the intraoperative transesophageal echocardiography, and that flow is infected. In fact, I have already taken this preoperatively. But when I got this, when I got to see the intraoperative transesophageal echo, I reviewed this, like, why I missed it. Then I saw that I have taken this view, and I thought there is a definite communication into this, and this is the communicating area. So this is very, very important. So what I want to show is that this patient was treated by a frozen elephant trunk procedure, was done by Dr. Otunusa in the Aruntagar Medical College. And you can see the video and how it is being done. Sorry. Just a minute. How it has been done. This celiac trunk is done. And this procedure is a very one. I'll forward it a little bit.
Actually, if you go back a little, the CT might tell us. Yeah,
CT.
so now,
Now
let's see the CT.
Achha, okay. Just a minute.
Because the MR was just.
This is the COPD CT aortogram.
Just go back and let's just see the contrast images of CT.
Achha, let's see. Oh, what is it?
Just keep it on the pause so that the moment it comes, you can pause it. Yeah, now play it.
Preoperative CT aortogram. This is the preoperative CT aortogram. This is the CT.
Yeah. So we can see both around the ascending and the descending aorta, and peripherally, you've got this thrombosis, you've got the lumen, which is white, and then you've also got a dissection and some flow within the dissected flap. So, yeah, see, there's a dissection of the type A dissection.
Now, sir, ma'am, this is actually the cartoon picture.
But even the
how this procedure is being done.
Yeah.
So I'll forward it. Is a 11 minutes video, but I'll forward it. This is the E-Vita Open Plus delivery system. By that, we can they do the frozen tongue operation, and this is the area they put it where, and not much of operation has been done in this. Yeah. So this is their inflating balloon tip to the smooth transition from tip to the textile cover, and what they did, go to the this area positioning and the guarantee of the optimal stent, and then this way they'll go to this area. Then evating, then again evating, there is a reimplantation of the head vessels by using the island technique, and this is there, and this is the real operative procedure. Actually, they did it, and this operative procedure, and this is the operation actually going. This is the real video. This is going on. The same thing. The principle is ongoing. Because of lack of time, I'm just forwarding it. So delivery of the frozen elephant trunk, and so this is the operation. They are doing it in patient, and there's a pumping it, then everting it into it, and there's now they are everting it into it, and putting the same thing. Is that full video is 11 minutes. That's why I could not cut it the video. And this is the pulling up the ascending graft from the stained graft, and this is the way they did it, and then pulling the, and now suturing the
10 minutes and followed by an international faculty. So can we close it now?
Yeah, sir, this is the post-operative aortogram. This is the finishing. So this patient has a most post-operative days on the day period.
So thank you very much for your...
Thank you. Sir, I finished in time.
I think next time we'll not get Mona Bhatia, otherwise she removes all the suspense by giving the diagnosis.
Yeah.
Thank you, sir.
Thank you, sir. Thank you, ma'am.
Sunday में बैठ के diagnosis दे रही हूँ, and then you are saying कि The whole Sunday I've spent doing this, and
सारा suspense आप खत्म
I'm
कर
only
देते हो.
here for
Okay,
Aniruddha
can we
Ji.
have the
Thank you
Philips
so
people,
much.
please, our friends, to if they want to give any presentation?
We have Mr. Sandeep Dabas, who's the regional manager of Philips India, who's going to be giving his presentation. In the meanwhile, I would like to thank the entire team and Dr. Aniruddha for giving us his insights. Over to Mr. Sandeep Dabas from Philips India.
Hi, sir. Good afternoon. Am I audible, sir?
Yes, and the total time is approximately 10 minutes. So we can have the timer on. Thank you.
Sure, sir. Sure. So today I'm going to present the EPIC CVXI top-end system which is available in the industry. This is a top-end system of echocardiography system. EPIC CVXI basically we have introduced in 2021. So this is the system, sir, which is right now T procedure which are compared to 2015. Now in 2020 we are around 500K T procedure increase for interventional cardiology procedures. So we introduced this system for making simpler life of interventional cardiology, because echo is the first love for cardiologists and they want to use this echo in intervention, making their life easy. So with the help of this system, you can able system with the cath lab, sir. So your same 3D echo images you can able to see in both echo as well as in a cath lab screen. So both echo images, 3D echo images as well as cath lab images, fused images you can able to see on a cath lab screen. So these are very easy to do the fusion in the with the help of this system. You no need to put any registration point, nothing required for this. You need to purchase the Echo Navigator with our Philips Cath Lab, and you can fuse that, purchase that EPIC CVXI system. So you can very easily fuse both the images together, and that will be very helpful in your complicated procedure like device closure, ballooning of mitral valve, or many other complicated procedures. So this is very, very helpful. So this is the images you can see here. We are fusing these images in the cath lab image. This is the panel which we are trying to show you. So this is the same T. We are putting a 3D T in the patients, and you can see both the images together. So this is our one more new probe we introduced with the system X51C. So earlier we have introduced X51 only. Now we have to X51C. So what is the benefit of this? So we have slightly changed the shape of the tip of the probe. So this slightly on curved side, because right now window. So we have changed the tip of the shape of the tip. So it's curved. It's very easy to penetrate and very easy to see the difficult echocardiography views with the help of this X51C. And the 3D echo images also you can able to see this outstanding trans-thoracic 3D echo images we can able to generate with the help of X51C. So these are all trans-thoracic images. You can see that TrueView technology with the help of TrueView and your depth precision view. So you can see the clot in the echocardiography image, and so this is very nicely, very beautifully seen. So complicated procedures also with the help of this Echo Navigator we can able to do. So these are the few examples of different CM angle. So whenever this angle rotate with the cath lab, so see, parallelly echo images angle also will rotate parallelly. So no need to do the rotation manually in this. So when a panel rotates, so similarly T probe angle also rotate. So this is a MaxView technology also we introduced with the MaxView. Means normally we are getting bigger sizes monitor, 22-inch monitor, but now we are not able to utilize the complete size of the monitor. So with the help of MaxView, you are utilizing complete size of the monitor. So you can able to see full screen images without any resolution dropouts. Same resolution you will get which are earlier images, because we have increased the pixel levels. So that's why you're getting the same resolution, and without zooming out of the image, without any artifact, you can able to see the same type of resolution in the image. These are also auto angle correct. Auto angles we can able to set on the T images. Suppose you are normally rotating 45 degree, 90 degree, but in our system you can just set up this angle automatically. You can just press 45, 75, 90 degree. So automatically that level, change that angle. No need to do manual in this. So that also saves you a lot of time, because in T normally when it's inside the patient, so it's difficult to keep that for a long time. So with this help of angle adjustment, auto angle adjustment, normally we need 45, 90 degree, 120 degree. Press this angle, it automatically changes that view. These are also new technology we have launched. So earlier you can see both the images comparison of photorealistic as well as your live 3D images, T images. So in that it's difficult to see the leaflets clearly, but now with the help of this new True, you can see all the leaflets very nicely because we can put a virtual light source inside the cavity. So that light source can travel in the depth also. So you can able to see very nice and clear images with the help of True. You can put this light source anywhere around the 3D eco images. This is TouchView technology also we have launched with the system. With the help of TouchView, you can do all post-processing with the help of touch panel, and you can rotate the screen toward the surgeon, or surgeon want to see in OT, so you can just do all manipulation from the touch panel. So the work as an image, dual monitors, because a whole image come on the touch panel also. So you can do all manipulation from the touch panel. These are the gallery of probe. All high-end eco probes are compatible with the system. Neonatal T probe, pediatric eco probe, 3D T probe, neonatal eco probe, X-matrix for fetal eco, X-matrix for linear probe, EL18 for linear probe. So these are all high-end probes are compatible with the system. There is no compromise in the quality in all these probes. These are all our pure crystal probe. Plus you can see the transfer T images. You can see the frame rate in the color. 3D with color, and you can see the frame rate in 3D eco images. Just like a normal 2D eco, you can do nowadays a 3D eco also with color also, as well as your 2D also. So now we acquired a TomTech also in this. So with the help of this, you can see the subcoronary mode is also. So for pediatric, because it's difficult to see the coronary artery flow, with the help of subcoronary mode, just click on a button, you can able to see the coronary flow also very nicely. You can able to take the Doppler trace also, sir. The new XL14 is a new linear matrix, so we have launched with the system. So with that, all you are getting X matrix with all the parameters for transverse eco, for fetal eco, for linear probe. All three sections we have X matrix probes available for you. With the help of this X matrix, you can able to see both the live plane together, your transverse carotid plane as well as your longitudinal transverse plane. Both plane you can able to see live. So without rotating the transducers. So during OT procedure or during cath lab, you want to put a line so you can see both the plane live. And that same thing you can able to see with color also, as well as Doppler also. And you can able to see want to see 3D in the carotid artery, you can put the 3D also, and it give you a 3D image also. So you can see the plaques and all very nicely. Plus, we have acquired, as everybody know, we have acquired a TomTech also, and we have launched dynamic heart model also with that system. So dynamic heart model means earlier you are putting so many points to get the 3D ejection fraction, but with the help of dynamic heart model, just click of a button, you will get the 3D ejection fraction as well as your LA volume as well as your LV mass. Everything you will get with the click of a button. No need to do any manipulation, nothing. It's a very authentic software. So, and it's a dynamic movement also you will get with the software. So it's very, very easy to use. Plus, we acquired a TomTech also now. With the help of TomTech, we launched new TomTech strain for RV as well as LV, plus 3D RV quantification also we have launched. So 3D RV, this also quantification you can do with the help of one click only. So whole 3D volume of RV plus 3D ejection fraction of RV, everything will get to the one click. And its results are very accurate because we have migrated this from the TomTech technology. So TomTech also we acquired by Philips nowadays. So this is RV strain, LA strain, all dedicated separate strain we have launched with the system. So you'll get a LV as well as RV as well as LA strain. All are TomTech based strains. So there's no authentication is required. All our white papers are available with all this strain quantification. So these are all are validated strain basically. Plus we have mitral quantification also. That is also now TomTech based. So with the help of it is very, very easy to use. Just in a 2 click, you will get the complete anatomy of the mitral with the values. So this is very, very easy to use. But this system is very cost effective, very easy to repair. So in this system, you need to open one this press one key, so it automatically open the panel. So no screws, nothing is like in the available in the system. It's very easy to repair. Plus our service team diagnose that is from their head office, and they comes with the whatever required with the replacement of the system. They come with that part. So it's very easy to operate, saves you a lot of time because echo is requirement in day-to-day practice. So this is very, very easy to do the servicing part also. Thank you, sir. Thank you very much for giving us this chance. Thank you. Thanks a lot, sir.
Thank you for this great new developments from Philips. I hope you get more kudos from all over the country about it or so.
Yes, sir.
Thank you.
Thank you, sir.
With the permission, can we get started with the next session, sir? We have Dr. Lisa also joined us from Australia. Can I request our chairpersons to please join us? We have got Dr. Satish Parashar, Dr. H.K. Chopra, Dr. R.R. Kasliwal, Dr. Satish C. Govind, and Dr. Rakesh Gupta. I request the chairpersons to please invite our first speaker.
I hope all the chairpersons are there. Now, I can see Lisa, I can see Jarek, both of them I can see. I hope Tom Binder, Krasimira and Fejol are all there also. But still, for the time being, we'll start staining the left atrium, because the way I strained Lisa when she was on holidays, so I think she took the same topic, because I went on sending emails and she was not, and she was in chutti or so. So she will start with the straining the left atrium and the clinical implications from Professor Lisa Thomas, please.
Thank you, Dr. Parashar, for your kind invitation. I'd like to thank the organizers for giving me this opportunity. And in the next 20 minutes, I'd like to talk about left atrial strain and what we think are its most useful clinical implications. I have no disclosures related to this presentation. Now, when we think of the physiological function of the left atrium, so its main function is to modulate left ventricular filling. It contributes almost a third of cardiac output. Additionally, it secretes natriuretic peptides. It communicates with the RAS pathway. It acts as a very important volume sensor and is thought to be a barometer of left ventricular diastolic function. And additionally, it has prognostic value as a biomarker in a host of cardiovascular diseases. Now, we all are familiar with left atrial volume and that an increased left atrial volume is associated with diastolic dysfunction, but there has recently been an increased interest in left atrial function, whether it be by volumetric measurements such as left atrial emptying fraction or LAFI, or using Doppler or tissue Doppler and measuring peak A velocity or the A prime velocity. But the focus of my talk will be on strain. So very briefly, what comprises or constitutes left atrial function. So what I have here is an invasively derived pressure volume loop of the left atrium. So when the mitral valve closes, blood fills the atrium from the pulmonary veins. In early diastole, the mitral valve opens and empties blood into the left ventricle. This is the conduit function of the left atrium. When blood first filled from the pulmonary veins, it was its reservoir volume. And finally, in late diastole, the atrium contracts, and then we get its contractile function or stroke volume. Now, traditional parameters like peak A velocity, atrial fraction, the ejection force or A prime velocity were all very useful parameters, but they're surrogates either of blood flow, of mitral annular motion during atrial contraction, and therefore they're only applicable in sinus rhythm. So what exactly is strain? And I know in the program this has been covered. So very briefly, it's a measure of myocardial deformation defined as change in length divided by original length. So if we start off with myocardium, which is 10 centimeters long, and it shortens to 8 centimeters, we get negative 20% strain. If it elongates, we get positive 20% strain. And there's a variety of ways in which we've derived strain. The earliest derivation of left atrial strain was using tissue Doppler, and we used a very thin and long sample volume, unlike the left ventricle, where it was a 9 by 9 millimeter volume. For the atrium, it was 10 by 2. However, despite its very high temporal frame rate, you have to track this sample volume throughout the cardiac cycle. Also, being Doppler dependent, it has to line up with your actual ultrasound beam. What was then derived was two-dimensional strain. And what this does is tracks the speckle pattern, which we get on our standard two-dimensional echo image. So we recognize that pattern and we look at the change during the cardiac cycle. Now, what I've shown here is a typical pattern of left atrial strain. What we see initially when we gate based on the R to R interval is that we get positive strain or reservoir strain, and then a flattening, which is conduit strain. And finally, we get what we call its contractile strain. If, however, we change the gating of the ECG and we make it P2P, initially we get negative strain, which corresponds to left atrial contractile strain. Now, what do we know about normal left atrial strain? So this was a meta-analysis of 40 studies, and they came up with mean values in healthy normals, reservoir volume normal being 39%, contractile strain being about 17%. Bear in mind that this conduit function is really a measure of left ventricular relaxation. We also derived, using two standard deviations of the mean, a lower limit of normal of left atrial reservoir strain of about 24%. But similar to other echocardiographic parameters, there is a slight change in strain with age, with both reservoir as well as conduit strain decreasing, and we see a compensatory increase in contractile strain. Now, our group also compared volumetric change to change in left atrial strain in healthy controls. And what we saw was that strain and strain rate start to significantly decrease about the 5th decade. However, when we look at volume changes, this was really occurring about 10 years later. So this suggested that strain may be more sensitive than measuring volume change. Now, what are some of the determinants of left atrial strain? This is work done by Dr. Gary Gann from our group. He demonstrated that left atrial strain was altered by left ventricular global longitudinal strain. So depending on how much the LV contracts, that determines reservoir volume. And as the left atrium dilated, this caused a reduction in left atrial strain. More recently, there was a study from a multi-center group led by Dr. Otto Smytset, where they also looked at invasive measurements. And in addition to LVGLS and LAVI, left ventricular filling pressure also is a determinant of strain. Now, what does a reduced strain correlate with? So in work done on MRI and looking at late gadolinium enhancement, they demonstrated that in patients who have more strain, more scar in the left atrium, left atrial strain is lower as compared to patients seen in this panel with less amount of late gadolinium enhancement. Dr. Camelli and colleagues actually compared histopathology. So these were patients going for mitral valve repair, and they got a sample of the atrium, And you see that as left atrial strain decreases, histopathology showed increase in fibrosis, and hence strain may be a surrogate measure of left atrial fibrosis. There's a lot of new research in terms of left atrial strain, but I think its predominant utility is in 3 domains. One is with diastolic function assessment. The second is in atrial fibrillation and HFpEF. And finally, it's demonstrated prognostic utility. And I hope to show you some examples of this. So here are the 2016 guidelines, and we see that left atrial volume is one of the main components. And we see here that left atrial volume is increased as we progress to worsening diastolic grade. However, there could be a problem here with grade 1, where larvae may still be normal. This is work from Roberto Lang's group, where they classified patients using traditional diastolic metrics. And you see here an overlap when you used left atrial volume alone. However, when they stratified patients based on left atrial strain, there was a much clearer demarcation of diastolic grade, and where originally 8% were indeterminate, when they substituted left atrial strain for larvae, they were able to reclassify these patients. This was further demonstrated in a much larger group of 500 patients. Morris and colleagues looked at patients with varying cardiovascular risk factors. What they showed was only 1/3 of people had an enlarged larvae, but 2/3 of this group had abnormal left atrial strain, and those with left atrial strain less than 23% had a higher incidence of heart failure hospitalization. So in a review that we wrote looking at the utility of left atrial strain, we feel its benefit is in early diastolic dysfunction, where your larvae has not changed, but left atrial strain is already reduced. Now, how does it act with left ventricular filling pressure? I previously showed you a slide saying that LV filling pressure is a determinant of left atrial strain. And in this elegant paper, they showed that both reservoir and pump strain had a high AUC for left ventricular filling pressure, which was elevated. So a reservoir strain less than 18 or pump strain less than 8% supported elevated filling pressures. And in a subsequent expert guideline, they suggested that if you had difficulty using traditional parameters like E over E prime or larvae, that they could be substituted using left atrial reservoir function. Here's a study from the Mayo Clinic where they were using stress echo to differentiate patients who might have diastolic dysfunction. So the group who had normal E over E prime at rest and post-exercise had the highest strain, the lowest strain in those with resting elevation in E over E prime, and intermediate value in the group who showed an elevated E over E prime only with exercise. So our group 2 looked at a group of patients with chronic kidney disease, about 218 patients, and left atrial strain was the most powerful resting echo parameter, which corresponded to the number of METs achieved with exercise. And it actually had a similar AUC, 0.83, as compared to exercise E over E prime of 0.79, suggesting that we could use a resting parameter instead of an exercise-derived parameter. Now, another area where left atrial strain will have a lot of utility is atrial fibrillation. Here's a multi-center study from Korea, and they demonstrated that patients with reduced global longitudinal strain were more likely to progress from paroxysmal to persistent atrial fibrillation. And this was demonstrated even in a group of patients with normal left atrial volume. It's also demonstrated utility in terms of determining patients who will be restored to sinus rhythm post pulmonary vein isolation. In addition to just measuring the peak strain, we can measure the equivalent of mechanical dispersion in the left ventricle. So you measure the standard deviation of the time to peak from various segments of the left atrium. And in this case control study, individuals who had prolonged mechanical dispersion were more likely to develop atrial fibrillation. How about HFpEF? So we now recognize this as a very important entity in heart failure, with more than half of our heart failure patients having preserved ejection fraction, but having the same poor outcomes as patients with HFrEF. So on the panel on the left is the ECHO sub-study from the Paramount study, and you see that patients with HFpEF had lower left atrial strain compared to controls, but it was even further reduced in those who developed atrial fibrillation or were hospitalized. Similar findings from the TopCat study, where peak left atrial strain were superior to other functional parameters and was a predictor of the composite of death and heart failure hospitalization. A study from the Mayo Clinic again in HFpEF patients. And what they saw was patients who developed paroxysmal atrial fibrillation had lower strain, and those with permanent AF had even lower strain, and that this left atrial strain reduction was associated with reduced survival. Our own group had an interest in looking at chronic kidney disease patients because CKD is a condition where diastolic dysfunction is common. And in our follow-up of these patients, left atrial reservoir strain was the only independent echocardiographic parameter of adverse events, which was a composite of MACE as well as death. And here you can see the tertiles of left atrial strain, the lowest left atrial strain having the worst prognosis. The third area of clinical importance is patients who suffer stroke. So this was a study looking at cardioembolic stroke, and you can see here that patients with worse left atrial strain tended to develop ischemic stroke. And most importantly, left atrial strain provided incremental value over CHA2DS2-VASc score in terms of these patients having a repeat ischemic stroke. How about encryptogenic stroke or ESAS? Again, left atrial booster pump strain rate, not strain, but strain rate, was the strongest predictor of these patients developing atrial fibrillation when followed prospectively, suggesting that there's a group of ESAS patients who actually have undetected atrial fibrillation or atrial cardiomyopathy, which is the cause of their stroke. Hitherto, I've spoken about two-dimensional strain, but over the horizon is 3D strain, and the advantage of this is there will be no through plane artifact, and that the speckles will remain within the imaging plane throughout. The current limitation, however, is the relatively low frame rate using 3D echo. So to summarize now, in terms of left atrial strain, we can use it to measure phasic left atrial function, whether it's reservoir strain or whether it's contractile function. As I demonstrated, it has particular utility in diastolic function assessment and also in elevation of elevated left ventricular filling pressure, particular clinical utility in HFpEF, atrial fibrillation, and stroke. Changes in left atrial strain seem to occur prior to left atrial volume changing, and therefore it's perhaps a more sensitive parameter. It has demonstrated prognostic value. I only showed you a few examples because of the limitation of time. What is interesting for the future, can we use left atrial strain to actually measure response to therapy and to determine success of treatment? There are already small studies in patients with hypertension or in patients with heart failure to see whether maximum therapeutic management will result in reduction in left atrial remodeling. And will there be improved value if we were to combine left atrial strain together with left atrial volume? So what are some of the pitfalls? It does require training and expertise. There is some vendor variability. However, many of these has been addressed. There's still a lack of standardized normative data, and most of the studies that I've presented today have used a left ventricular algorithm for calculation of left atrial strain. However, I was very pleased to see the Philips presentation prior to my talk talking about dedicated left atrial strain packages. So with that, I'd like to acknowledge my team at Westmead Hospital, as well as students who've all worked to develop so much of this work. And I thank you for your attention.
Thank you. Thank you, Lisa, for the very brilliant presentation of straining the left atrium. And I think a lot of us have got a more incentive to do more of a studies on this, on doing a left atrium. I hope you will be with us for some time so that we can.
Can I ask some questions?
No, we are having questions in the end or so. So Dr. Chopra can introduce the next colleague who is beside you and giving a very beautiful smile. Jarek, my old friend.
So I think.
Thank you very much. Can you hear me?
Yeah, yes, we can hear you.
Good. So I'm sharing my presentation with you. And well, first of all, a warm greet and welcome to all Indian friends. Thanks for inviting me to this fantastic symposium. And technically, the connection works so well. So I feel just like being in Delhi. So I would like to take you on a personal journey over my experience with 3D Echo, which I really find a method having a long and winding road behind. And actually, the evolution of entire echocardiography includes this track of developments in 3D Echo, which is indeed a 48-year-old method. Quite old indeed, even though the early methods to do it were incomparable to what we are doing today. So the first ever report showed a mechanical arm holding an M-mode transducer to produce a 3D image of a heart, which I believe, although I cannot really explain or interpret it. However, there is always a first paper to be published, and even though the next developments over the coming decades, starting from 74, showed clearer pictures, there were still far something like a researcher's toy, and the road really looked windy. So 74 and 82, I have shown it already to you, but there was something going on in the field, and the 90s have become a very meaningful period because the principles of 3D Echo, as we know it today, were developed right during that time. So the principles of reconstructions, the concept of dynamic reconstructions, and even the prediction of a volumetric scan, which is actually an obvious connotation for us dealing with 4D Echo 2022. But the road was windy and bumpy, so you can recognize Professor Mom from Munich, who was the founder of one of the most influential companies developing 3D technology. And the early Tomtec devices, interestingly, in 1992, it seemed that the best way will be to insert in the esophagus a very special TOE probe, with a special straightening device called the crab tail to straighten it in the esophagus of a patient and produce parallel scans, just reproducing the concept of CT anno 1992, the parallel scanning and then to reconstruct it. Well, this did not hit the market and didn't seem very patient-friendly. So the next developments were driven by the concept of a separate console, which was connected to the video output of an echo device and able to reconstruct a tedious acquisition of 60 or 90 consecutive beats to produce this sort of images. And there were initial clinical successes. So you can see an attempt to reconstruct a carcinoid valve. It is static, but we were able to measure areas and interpret it. So it seemed it can be working, but still this principle of 3D reconstruction hampered the clinical proliferation. And actually this has never made a widespread technique because of this duration and time. So a lot of interesting engineering developments came on the way. This is a motorized transthoracic probe because the rotational, controlled rotation of the probe seemed to be a very attractive way to collect dimensional data. You could also put a standard probe into this big aluminium device, and we had a name of bazooka about it. It was a caliber of bazooka indeed. And a lot of external detection of the probe was being developed during that time. All these methods shared one common feature. They were complex and probably too complex. This is our clinical setup in our lab of 3D Echo 2000 with an external magnetic device sensing the position of the probe. And we did, in fact, made some clinical input out of it. But it never seemed to be really promising enough to hit the market. And there was a quiet revolution in the meantime. The first ever commercial volumetric scanner came on the market. The company was called Volumetrics and produced a probe which was resembling something we use today. But due to engineering issues, it was hard to wire a necessary number of elements. So there were 256 elements in a sparse square array, producing simultaneous multiplanar images, including one feature which was mind-blowing at the time and still constitutes the backbone of what we are using 3D Echo today, which is C-scan. So real-time scan produced from anatomically unavailable planes unavailable for live 2D scanning. So why have things changed? Why did they change? Why in the year 2022, we have in most of the labs a machine with a 3D scanner and we have a lot of clinical applications. So, well, we are not too busy now. Actually, we are busy with difficult things in cardiology. So we need precise devices, and the development of a rapid electronic technology really changed the landscape. Okay, the transducers were initially large, they were heavy, they were not so convincing in terms of resolution, but still the ability to connect around 3,000 elements, both in transthoracic and in transesophageal probe, which were indeed a game changer because it was easier to produce convincing, clinically readable images from easy transesophageal window as compared to a bit more challenging transthoracic window. So even though the 3D TE probes came a few years later, around 2007, let's say 4 years later than transthoracic, they actually helped the methodology to win the ground and to convince that it can be clinically useful, just like as we understand it now. So you can see the evolution of transthoracic probe more or less in the real proportion of size and imaginably the weight of the probes. And in fact, the major thing we need to change while switching to 4D is thinking about working in 4D space. So anything within a data set is within reach. We can measure things we would never think of. We are no more tied to specific imaging window for specific applications. So I will try to illustrate you with some clinical examples. But the principal things to change in our minds while switching to everyday 4D is that we need to extract what we need from the data. Because with good quality 4D acquisition, we have abundant data and we are not going to use all of them. but we can extract what is most needed in the specific patient scenarios. By the way, good windows, referring to transthoracic acquisitions, are welcome, but moderate windows are not disqualifying for clinical purposes. Maybe not for producing echo atlas pictures, but for answering clinical questions, yes. Another connected aspect is that we need to learn how to extract the data, and the critically important part is extracting usual 2D cross sections out of a data set. The typical full volume looks uninterpretable, but inside there are hidden pearls, and in a technique called MPR or FlexiSlice, depending on the vendor, we can actually extract the plane we need for our most critical and precise measurements. So the resolution as of now, this is a mixture of the transesophageal and transthoracic images, is really very convincing. You can see details of segmental disease, just like this degenerative mitral valve disease, and the fine details of abnormal aortic valve anatomy with huge potential of quantification. And the usual way is to combine volume rendered views and reconstructed planes, usually 3 of them, with easy control from one to another. So why getting the best arbitrary view? Well, to produce the best view for measuring things, just like this optimized mitral valve planimetry. And believe me, this is different than just measuring a transthoracic arbitrary 2D plane, and this is more precise, reproducible. You can produce the view which is not available. Just imagine a patient without apical window in whom you're interested in a ventricular quantification. So a good subcostal will make it. They are no more tied to a specific window for a dedicated application. So what clinical scenarios are the most common? So first, the most accurate quantification available in cardiac ultrasound before major steps in therapy, usually interventional, just like CRT implantation, a cardioverter defibrillator implantation as well, or surgical quantification to the procedures based on subtle LV dysfunction or remodeling. Better assessment of unusual anatomy, including the need for non-standard viewing planes, just like looking for attachments or stalls of cardiac masses, just to give one of the clinical examples. And obviously, one of the most expanding applications is preparing, planning, and monitoring of cardiac interventions, especially percutaneous, in which scenario pre-procedural planning plays the major role and actually determines the success of the treatment. We have a number of parameters which have become measurable only with 3D, and this is the most striking example of quantifying right ventricle, including volumes, stroke volume, ejection fraction, and strain in one step. Also, another field where 3D performs fantastic is measuring areas, including both holes in cardiac tissues like defects and obstructions to optimize the measurement of in-plane lesion area. So quantifying a cardiac chamber function has been developed in most of the vendors with very advanced applications like real-time evaluation of volumes, strain, a huge input of artificial intelligence to produce rapid quantification within a fraction of a minute to calculate ventricular strain. And this is more reproducible than 2D echo, allows us to detect a smaller clinically relevant difference, and therefore it's as close to the reference imaging method of cardiac magnetic resonance as can be. New developments on the field. This is actually in link with the previous talk. Quantification of a left atrium appears to be very easy from 3D. We are still missing reference values to use them for every day, but this is a 30-second workflow giving you not only the phasic change in volumes, ejection fraction of the atrium, but also values of a strain. And mind you, not only longitudinal strain, but also a radial strain, which can be, circumferential strain, which can be of interest in this structure as well. But the right ventricle is really a major development. Again, a nice and easy workflow, actually workflows developed by several independent vendors, producing a full volume curve over a cardiac cycle and most of the necessary measurements as illustrated here. So this is volumetric, this is the strength of volumetric acquisition, but also for defining morphology, this era has really changed. And many of the clips I'm showing you now have been recorded precordially. So a completely different view at pacing wires and the implications of pacing wires. So we can have a whole picture, and any person trying to image the course of the leads in right heart knows it's challenging in 2D, and in many patients it's really a piece of cake. Switching over to volumetric mode, and this is not just pretty pictures. Professor Christopher will develop the topic in a few minutes, but just look at this stuck ingrown ventricular lead, which may and often does have an interaction with tricuspid function. And I envy Krasimira of having this fascinating topic in her presentation, but just a couple of diagnoses and details of anatomy of tricuspid valve as a appetizer before the next talk. So this has been a revolution, and we understand not only tricuspid disease, but also many other types of structural valve disease in a completely different way now. So segmental extent of valve disease does not really require a dedicated measurement packages in all cases. You just see it in front of your eyes. Just take a look at this nice definition of extent of P2 prolapse with a ruptured chordae. And this is an easy thing, but we often have difficult things. Just take a quick glimpse at this odd mitral regurgitation with subabnormal structures. So the options are a couple, including prolapse, including vegetation. But if you turn on 3D, actually the solution comes in front of your eyes. Let's reformat it. And this is a mitral valve, and you can clearly see something which looks like 3 commissures. So in this case, the diagnosis of mitral valve cleft as a rare and significant etiology for mitral regurgitation just shines in front of your eyes. Another interesting example of less intuitive, tricky mitral regurgitation with very oblique course of regurgitation jet, and a rather unusual presentation on standard transesophageal views leads to discovery of an isolated commissural prolapse, a special form which is treated by the surgeon very effectively, providing he knows about it because he has an extra stitch technique to make this valve sealed. So clefts are segmental disease, and sometimes even usually looking things. So our Indian colleagues are experts in mitral stenosis, and this was a mitral stenosis in a European patient in our country with a very odd-looking submitral apparatus, and actually this careful reformatting and the observation of a totally asymmetric and calcification-free led us to discovery of a congenital etiology of parachute-like asymmetric mitral valve stenosis. So this probably would not be the best candidate for a usual balloon because there are no stuck commissures to separate. And even the common valves like aortic valve is sometimes tough. Just look at this patient who had a congenital symmetric bicuspid aortic valve. And with reformatting, you can beautifully see both the opening area and also the extent of the perforation in the consequence of the infective process, which was based on these findings carefully managed by the patchplasty by an experienced surgeon. So difficult areas to measure, difficult orifices. Just think of a growing population of patients with mitral clip. So separate orifices which can be quantified separately, just as we do with the common mitral stenosis, where you can also strengthen our robustness of the findings when you optimize your viewing plane. So the factor of angle-dependent error in planimetry is cancelled. So any difficult object can be better measured in good quality 3D data set. And an example of a measurement which is really meaningful is a left atrial appendage quantification. And this is our favorite prior to occluder implantation now. We are actually giving up on contrast a fluoroscopy of the appendage. We don't do it so much now because this is so precise and easy and reproducible. So this can help to reduce radiation or contrast exposure if needed. Same story with planning of atrial septal defect closure. En face view gives you the full understanding of a string-like multiple defects, or perhaps real multiple defects separated by the more extensive stripes of tissue, and this determines the strategy and helps avoid balloon sizing. Same story in most patients. We don't do balloon sizing nowadays prior to the occlusion with occluder, and measurements of this kind are sufficient to plan, including more complex multiple or fenestrated defects as illustrated here, and that precise roadmap, including the choice of devices and design of the procedure, leads to a single or multiple occluder procedure in accelerated and precise way. And this brings us into the field of interventions, and proudly 3D echo is necessary or really prerequisite for some types of interventions, including occluder closure of perivalvular leaks. And this beautiful definition of perivalvular or intravalvular leak is critical, just like guiding the intervention during the procedure itself to avoid false crossing and to ensure the proper engagement of the leak orifice, and then occlusion with one or multiple devices. And now with newer designs, one device is often frequent. And this is not as spectacular, but shows the potential to measure things which are necessary for planning. A patient with heart failure and significant, although not huge, perimembranous septal defect, quite close to the aortic valve. Is it close enough to preclude a percutaneous closure? With 4D dataset with color, you can reformat it so you can precisely measure the distance between the attachment of the aortic valve and the defect, which was 11 millimeters, far sufficient to close it percutaneously, which indeed happened. So, in fact, we have so many obvious clinical benefits where we need more precise quantification, including measuring different. This is actually the intra-atrial membrane at cortia striatum with multiple openings, which can be measured. This was a lesion with invisible attachment, which has become visible in 3D. So this is penetrating everyday guidelines, chronic heart failure, valve disease, reporting standards. So many examples that 3D is mentioned just as an everyday technique, which indeed is in 2022. And what will the future bring? Well, the images go better and better. We have photorealistic imaging. This is a LV thrombus, and this is a procedural view. So it really looks like in a rising sunshine with shadowing, with transparency information, which can be meaningful in some type of procedures and planning, with amazing new features showing the semi-transparent structures with or without color overlay. And this is not just pretty picture. Just take a look at this atrial appendage, which indeed looks like a CT image with a possibility to look at the specific anatomy type, which can be of importance. In this last minute, just a few examples of artificial intelligence supporting structure segmentation and presentation, allowing rapid quantification of chambers, and also accelerating the workflow to short seconds when you acquire a good quality data set. These images are a good friend to interventional cardiologists and can be mixed and overlaid with live fluoroscopic image. And 3D echo scanners have become also a complex Zycom viewers, which can present echo images with a grayscale overlay. Finally, we can also try to enter the new fields of mixed or virtual reality. And I'll just finish with the experience with Hedin Wood, producing the first ever real streaming of 3D information in the structural intervention setting to produce something like this. I'm pinching the air to rotate the cube with three-dimensional information streamed directly from the scanner. And importantly, this does not obscure the vision of the real structures and can be shared with the operator, which is performing an occluder procedure at the same time. So, ladies and gentlemen, 4D echo has become a new scanning paradigm for high-end echocardiography 2022. I'm proud to be a part of it over these 28 years. And I'm fully convinced that this is in scannable patients, it is the most effective way, allowing optimal understanding, analysis, communication, and also teaching of cardiac imaging with ultrasound. Ladies and gentlemen, thanks a lot for this invitation, and I will show this parallel picture of Fuji in winter and in spring.
Dr. Chopra, please carry on.
Thank you very much for your most stunning presentation on 3D echo. And with this, we go to the next presentation. I think Thomas Binder needs no introduction to this audience, and he's covering a very, very important subject: heart transplantation status, future directions. Thomas Binder, sir.
Well, thank you very much for the invitation. I hope you can all hear me. Well, thank you very much for this very kind invitation to speak here at this conference and symposium, and many greetings to all the friends in India. I see many of them already here on the screen. And my topic is going to be on heart transplantation. So let me just open up my presentation here, and I do hope you can all see it. Now, heart transplantation is obviously a technology which is always, of course, on the top of the list if you talk about the treatment options you have for heart failure. And it's always in the press and the media because it's a rather spectacular, I would say, technology, even though, of course, we should not forget that there are many other ways of treating patients with heart failure as well. What I would like to present you, much of what I'm going to present you now is, of course, stemmed from our transplant program. And here you see Andreas Zuckermann, who leads this transplantation program. And thanks to him, I got a lot of background information and details and statistics and data that I want to present with you as well. So where are we standing at the moment? 160,000 heart transplants have done since the early days, since Christian Bernard was the first one who transplanted hearts. Now, there's a lot of experience with this technology, and this technology has really, really evolved since the early days. But one thing that definitely has not changed much, is the indications. From this slide, you see that most of the patients that undergo heart transplantation are patients with ischemic coronary artery disease and patients with dilated cardiomyopathy. But be aware that these are not the only two indications, that we also have patients with valvular heart disease, congenital heart disease, and then we do have a small percentage of patients who already had a transplant and are going for a second transplant. I will talk a little bit later about some other indications, some new indications, which are coming across the corner here. But I think many of you who are seeing this ultrasound image will greatly appreciate that this patient must be in end-stage heart failure. And this is exactly what the main indication for heart transplantation is. It's end-stage heart failure, but it's also patients who have no other options. So we have to be sure that there's nothing else we can do for the patients, because after all, heart transplantation is logistically especially a very, very complex procedure, and there's a limited number of organs that are available. So what are these alternative therapies that can help us? And what are some of the things we can do to maybe bridge patients until they get a transplant heart? Well, one thing obviously is to intensify medical therapy, and there is a number of new drugs out on the market for heart failure which are helping us to increase or to improve the prognosis of patients and to prolong life. So intensification of medical therapy is always on the top of the list. Then we've got cardiac resynchronization therapy, and something that we've talked about, I think in previous lectures here already, is the edge-to-edge repair of the mitral valve. Here you see such a patient with severe mitral regurgitation. So this is definitely something that can also help patients significantly to improve and maybe even avoid heart transplant. And then we've got this whole area of left ventricular assist devices, VATS, which is a very, very interesting and fascinating new concept of treating patients with heart failure. And I will definitely talk about this technique, at least in a later slide. Now, what about the new indications? Where can heart transplantation also be utilized? It's patients with heart failure and preserved ejection fraction. This is one indication, such as maybe patients with restrictive cardiomyopathy, amyloid heart disease, Fabry, and sarcoid heart disease. We are using it increasingly also in patients with adult congenital heart disease, in patients with heart failure after chemotherapy. Don't forget that this is a growing number of patients that we see, patients who had chemotherapy many, many years ago and are now developing heart failure. And then we've got this group of patients with high urgent indications for transplantation with fulminant myocarditis, sometimes very dramatic scenarios where a heart transplantation is indicated, for example, in the situation of giant cell myocarditis. Now, because heart transplantation is a logistically very complex procedure and that there's limited number of donors, we have to really make sure that those patients who get a heart are the right ones, that they have a good prognosis. So what we have in place is a checklist of diseases which we need to exclude, diseases and conditions such as infection, cerebrovascular disease, renal disease, irreversible pulmonary hypertension. I'll talk a little bit later about the role of pulmonary hypertension, malignancy, systemic disease. We also don't like patients who are grossly obese, so we have a limit of a body mass index of 35. Alcohol and drugs is an issue, and psychosocial factors are also an issue. And some patients also go through consultation of a psychiatrist to be sure that these patients are the ones who will benefit from the procedure. And what you see here is a checklist that we have in place at our institution. And only if the patients meet all these different specific factors will they be put on a waiting list for transplantation. I already mentioned the issue of pulmonary hypertension, which is a very important one because we do not want patients to have high pulmonary pressure because the transplanted heart might not be able to accommodate the high pressure, the high pulmonary vascular resistance. So this is an issue. But what we've learned in the past is that it does not necessarily mean if you have high pulmonary pressure that patients cannot get a heart transplant. What we do is we use pharmacological testing. And if the patients are able to lower, or if the pressure lowers in response to pharmacological testing, then it would still be candidates for transplantation. And we've shown that in several publications that patients have a good outcome, if only it is a reversible form of pulmonary hypertension. Now, if you look at the different options we have, and I would say the two methodologies which are somehow in opposition is the VAT and the transplant. It's sometimes very difficult to decide which of the two should be installed. And there will be clear situations where a transplant is the better option, and there's clear situations where the VAT is a good option. But then there are situations where we sometimes are, I would say, in a situation where both methodologies would be available. But in the end, we will have to settle for a situation or for a therapy that is easier to implement, either if we have a strong artificial heart program or if a center has a lot of donor hearts. So this is something that is sometimes very, I would say, individualized. What is the situation of transplantation in Austria and in Europe? Well, there is an organization called Eurotransplant, which includes a number of different countries that you see listed here. And these countries share donor hearts so that donors can be, I would say, sent from one country to the other. Now, what is really important with respect to the individual programs in the countries is also whether or not a legal situation is in place where informed consent is necessary or where we have presumed consent. In Austria, we have presumed consent opposed to some other countries. And this greatly influences the number of transplants in the country as well. This is some statistics of, I think this is the year 2019, where of 68 hearts were exported, of 68 hearts which were I would say, available as donor hearts, 25 were exported and 16 were imported into Austria. So we see there's an exchange of organs back and forth, and at the end, it probably always evens out some way or other so that each country gets pretty much the same number of organs that they're putting into the bank. And if you look at the percentage of the ratio of transplants per population, you will see that there are some countries which have a rather high number of transplantations, those in blue. And these are also the countries who have the presumed consent in place. Obviously, these countries have more organs. Luckily, Austria is among them. And then you've got countries which are somewhere in the intermediate range, in lower range, and then some countries don't transplant very much. This is, for example, the UK, but it's also the Eastern countries to some extent. Now, what about India? India has a very active transplant program. I've read up on this, of course, on the internet to figure out what the situation in your country is. As a matter of fact, India was one of the first countries that transplanted hearts. And of course, the logistics in India sometimes might be more difficult than in Europe, but the rate is approximately 0.2 per million population. And if you look at the numbers, we see that the numbers globally and also in India have risen, but especially in India, the numbers have again dropped in the 2017, 2018. I guess there were some legal situations that probably underlied this little drop in transplantation. Coming back to the heart transplantation system in Austria at the medical university, at the institution that I work, in blue you see the number of transplants, and in red what you see are the number of VATs. And clearly there is an increase in artificial hearts which are being implanted. And we also see that there was a drop here in the number of hearts that were transplanted. And this just shows that there are some other factors which play a role, which you might not even think of. And that is the better neurosurgical treatment of patients with cerebral hemorrhage, the protective trepanation, which definitely caused a decrease in the number of organs. And of course, at this point in time, there was also mandatory to wear helmets on motorcycles. That definitely also played a role. So you see the number of organs have dropped, but it's again expanding now, and probably at a relatively high level at this place. Of course, this drop here in the end is related to the COVID situation, where definitely less transplants, were implanted. Now, if you look at the situation with respect to high urgent transplantations, you see that that we still have a relatively high number of high urgently transplanted hearts, but again, we also have a number of VATs which are implanted in the situation. So basically, we have two treatment options now available, which improves the prognosis of patients with high urgent need of hearts, especially also in children. If you look at these statistics, which is the ratio between VAT and no VAT, just to look at the situation in different countries, you can see that there was, especially in 2017, an increase in the VATs. And the reason for this was definitely because there was an extreme lack of organs in Germany. There was a scandal in Germany that went on. There was some transplant centers who preferred certain patients. And so this was a huge issue in the media, which led to a lack of transplantations in Germany. Again, see that there's many factors which play a role. Now, the survival after heart transplantation depends very much on when the transplants were performed. You see that in the modern area of transplantation, the results are excellent with a 1 year survival of 90%. But what is very evident is that the patients that we are now transplanting are sicker, they're older, they have more additional disease, but we are able to get them out of the hospital quicker. So definitely, this just shows that there is an increase in the way we are able to treat patients now. Just a short notice on the waiting list and how long patients have to wait for a high urgent transplant. This is rather low. In some countries, as low as 10 days, which is quite quick. So this has definitely improved as well. And this is probably one of the reasons that the mortality on the waiting list has dropped from initially 28% to as little as 8%. So this and the factor that there is now better pharmacological bridging, that we have VATs available, ICDs and CRT, high urgency systems in place, microclip and shunts are one of the major issues that patients do not die as quickly on the waiting list. I don't want to expand too much on the technology of heart transplantation, but only mention that nowadays a transplantation methodology is used that is a little bit different than that in the early days, where basically one atria was connected to the other, the so-called bicaval methodology, which had more tricuspid regurgitation afterwards. And this is a trend that I think is pretty much in place in all countries. So the technique of transplantation is not the issue. It's much more the complications after transplantation. And in the early phases, it's graft dysfunction. But then after a few weeks, it changes to the situation where we might have acute rejection, both cellular and humoral. In the later phases, we then see complications of the immune suppressant drugs. And then finally, several years and decades later, it's the graft vasculopathy, which plays a major role. So this is something that we need to consider. So to have a successful transplant program, it's very, very important to also have good drugs available to prevent rejection. And the drugs we have available, of course, have changed over the time. And this has led to a very strong decrease in the mortality from 2010 to 2020, from 25% to less than 10%. So this is probably one of the major advances. And with numerous drugs now available, we can target the immune suppressant therapy to individual situations. We know that women and children might need a little different regimen and protocol than, for example, patients with diabetes. And definitely, this is one of the main reasons that the prognosis is much better. We also now know what the side effects of the individual immune suppressant drugs are and can then adapt to the individual patients. We have alternatives in place. Still, the gold standard is biopsy. We perform biopsy basically weekly, and then switch to a bi-weekly mode, and then to a monthly mode. But over a time period of half a year, we perform myocardial biopsy to detect rejection. Coming to echocardiography, yes, echocardiography plays a very important role as well. We can detect left ventricular dysfunction. We can detect the echogenicity of the myocardium, which might denote edema. We see pericardial effusion, changes in the deceleration time and isovolumetric relaxation time. Right ventricular function might decrease as a sign of rejection. We see an increased myocardial thickness. Again, this is edema. And we also see a reduction in strain. So this is a classic example of a patient with early rejection. We see right ventricular dysfunction, left ventricular dysfunction, and we see tricuspid regurgitation, which sometimes is an early sign of dysfunction. But be aware that tricuspid regurgitation might also be related to the biopsy itself as a iatrogenic complication. Just a few words to graft vasculopathy. Very important, of course. It's a long-term problem that the patients have. We think that it's related to the autoimmune problem and to maybe also recurrent virus and CMV infections. We can detect it with intravascular ultrasound, and we don't really have much treatment for this disease. But what we do know is that tacrolimus, which is a new drug, definitely is the way to go, and that this is something that really reduces the vasculopathy in these patients. This is just a statistical study that documents this. If we look at the prognosis of patients, we also see that the prognosis again has improved, also due to these new immunologic drugs, autoimmune drugs. Now, one thing that I cannot forget to mention is the risk of malignancy in patients with transplantation, and that patients who have transplants have a mortality of 21.2% as a consequence of malignancies, which is about 6 times higher than that for patients who do not have a transplant. So this is definitely something which is important to consider, but also here we believe that with new immunosuppressive regimens, the mortality and the risk of malignancy can be lowered. Let me now come to the final part of this presentation and just give you some of the new advances that are on the horizon with respect to heart transplantation. And I guess if you look at some of the VATs which are now implanted, you might think we're turning more and more into what you might call terminators. But in reality, these methodologies are really, really something that will change the face of heart failure. We can see them get smaller, more effective, with less complications, so that we don't only use them for bridging, but also for destination therapy. What else is on the horizon? Well, we have better machine perfusion and transport systems, which is very important, especially for countries, for situations where we need to transport the organs over longer distances. We need to make sure that the organ comes to the place where it is transplanted in a good condition. We also have a concept which is fascinating, which is called the DCD concept, where we also try to implant hearts after circulatory death. In other words, not only patients with brain death, but also with circulatory death. This is often the case in patients who have irreversible neurologic damage. Obviously, we try not to influence the procedure of death. And the way it works is that basically there is first a decision to withdraw life support. And then life support is actually withdrawn. And then basically one waits for the heart to stop beating for a systole. And that's the time when explantation of the heart is being performed. Then the heart is being perfused and then transplanted. So this concept will definitely increase the number of organs that are available. And we at the Medical University of Vienna implanted such a patient in 2019 for the very first time. Here you see the transplantation team, the head of cardiovascular surgery, Professor Laufer, and Dr. Kindermann, and also Dr. Asadian, who's also instrumental in the transplantation program. What else is new? There's new immune tolerance induction, where we try to avoid the problem of rejection. We're using xenotransplantation. I guess many of you have heard about these spectacular transplantations performed in the University of Maryland in the US, where a pig heart was transplanted to humans. This is a concept which has been around for some time, previously tested in baboons, where you use a genetically modified heart of a pig in a human now, where the idea is that there is no rejection. So the CRISPR technology is used here. There's a number of different genes were being modified. Of course, this is still in the early phase, but this would definitely change the availability of donor organs if it works. The size of the heart is still a problem, but in principle, this is definitely something that is on the horizon. Finally, we've got decellularization as a potential methodology. I guess many of you have seen these hearts where the matrix is in place, and then this is kind of seeded with cellular material, where the hearts are then again beating, so you can basically build your own heart. And then we've got 3D printing as also a technology, which I just briefly want to mention. So in summary, this is some of the advances. And from an echo point of view, just one last word. What I would be, of course, looking for would be a standardized evaluation of potential donor hearts, something that we need in daily clinical practice. I guess many of you are probably in a situation where you need to decide if an organ is a potential donor organ. This heart definitely is not. There's left ventricular hypertrophy here, but there would be a need for standardization. So this brings me to an end to my presentation. I do hope that you got something out of this lecture. And again, best greetings to all my friends in India.
Thank you. Thank you. Is Dr. Satish Govind there? Because I don't see Kastiwal.
I'm here.
So please, after the, now you can call the next. You can see Krasimira here.
Dr. Krasimira is a familiar face. We have seen her in past conferences. And welcome, Dr. Krasimira. And she'll be talking about tricuspid valve. Dr. Krasimira, we can start the talk.
Krasimira, come online, please.
We saw briefly, again, maybe some connection problems. So probably reconnecting. So let's wait for the connection again.
Please come back. I believe Dr. Krasimira was using two devices. That's the reason we were getting an echo.
There were some echoes.
Yes. So I think she just rejoined. We're just asking her to start her camera and start presenting.
Don't get confused. He is not Krasimira. Yeah.
Dr. Krasimira, welcome. Can you hear us?
We had seen her using a mobile device. I believe she might be using the mobile for the audio. Let's see.
So let us wait for a few minutes. Apologies for the delay. So Dr. Krasimira will be talking about the 3D echo and assessment of tricuspid valve and tricuspid regurgitation. She's from Sofia, Bulgaria, and she's been with us in past conferences. So we look forward to her talk.
Till she comes online, Dr. Chopra had a question from Lisa Thomas. Can he ask that question?
Lisa, I think I just only one question because you gave a very brilliant talk on LA strain. And I think she is here now. Krasimira is here.
Are you?
Dr. Krasimira, welcome. Yes. I know that you've been having some connections, but you're waiting eagerly for your talk. You can please start your presentation.
Okay, thank you. The first, I want to thank you all organized committee that you invited me to be here, and hope that we will be very soon face to face. So this is my first slide from the presentation. That actually I will starting with this one of the last slides of the Professor Kapchak that he spoke about that the 3D echocardiography, it's the revolution for the tricuspid valve. Yes, this is the revolution for the tricuspid valve, and because the imaging is going to be better and better, and the possibility for the measurements of the tricuspid valve and tricuspid regurgitation, it's now not the forgotten valve for anyone, and we must looking about the right heart and the tricuspid valve also. This is the anatomy of the tricuspid valve, which is very challenging to perform with the 2D-dimensional echocardiography because the valve is very complex with the non-planar geometry, and the annulus is very highly variable with the anatomy of the valves. Moreover, with the 3D-dimensional echocardiography, it's very difficult to visualize all the three leaflets simultaneously as in a single tomographic view. Therefore, the 3D-dimensional echocardiography is the new revolution for the imaging of the tricuspid valve and for the evolution. This is one of the very quick orientation of the tricuspid valve regarding the anatomy of the heart and the other valves like the mitral aortic valve with the pulmonary valve, and the position of the leaflets. It's very easy to orient it when they're using the left and the right heart from the position of the mitral valve. So the three-dimensional echocardiography, it's possible to give us more information about not only for the in experience center, but we can use in the everyday in our practice. Not to use the several maneuvers from the suggested for the better visualization of the free wall, but with very nice visualization of the 3D, we can have the on face, the 3 leaflets and the whole wall and the leaflets, and for the anatomical and for the surgical view also. That we need to have, this is the very good acquisition. Actually, the transesophageal echocardiography is one of the better possibilities to have this more visual 3 leaflets of the tricuspid valve with the anterior position, which is relative to the probe, oblique incidence of the ultrasound, and very thin leaflets. But the transthoracal echocardiography also is possible to visualize the 3 leaflets very well, the patient. But we must to know that this is the very important, that is the leaflets morphology. The tricuspid leaflets are very thinner, very translucent and very fragile, more challenging to image and repair. Consequently, the anterior leaflets is very more largest, and the posterior leaflets is the smallest. Radially, the anterior leaflets, it's not the longest, and the septal leaflets is the shortest, having this the caudal attachment with the interventricular septums. Commissures, there are 3, they are not a distance. This is the one of the very good paper from a group of the Professor Badano, that they proposed the stepwise acquisition of the tricuspid valve complex using the matrix probe by three-dimensional transthoracic echocardiography. The first, this is the left lateral position of the patient with very good data sets with the gain optimization on the depth to visualize the right ventricle with the leaflets of the tricuspid valve. And it's possible then to go to the after the good acquisition with the multi-beat and the single beat acquisition from the visualize the better of the leaflets of the valve. This is the one of the clinical case that is one 15 years old man who is coming with the functional class of the 3 of the heart failure. He was referred after the atrial fibrillation complication from the department of the surgery of the pulmonic thorax X-ray. We have the clear lungs, no legs edema. Of the ACG, this is the very significant atrial fibrillation with the heart rate around 150 and RBB. From the Holter ACG, there is no sustained ventricular tachycardia, and the echocardiography performed at RV enlargement with the severe tricuspid aortic regurgitation. This is our patient, and this is the tricuspid regurgitation, which is performed from our lab. What is the most only difficult for this patient, because he's very young and is coming with this severe tricuspid regurgitation. When we look at about more detailed from the anamnesis of the patient, he has some history of the trauma and the healed left rib fracture, and then he developed this the pulmonary embolism and very small incidences in the past 10 years with the pulmonary embolism. So the 3D echo allows very comprehensive assessment of the right heart with the better understanding the severity, not only the tricuspid regurgitation, but the better understanding the morphology of the leaflets of the valve. Sorry for this. This is the one of the very large variability of the tricuspid valve leaflets with the number of the morphology. We can find from 2, 3, 4, or even the 60 leaflets, and one to 3 scallops of the posterior leaflet, which is described in the couple of years. Assumption of the leaflet orientation is identification of the two-dimensional images may not work. Leaflet number and morphology assessment is very crucial for the children tricuspid intervention also. And 3D echo is by far superior than the two-dimensional echo for assessing actually the anatomy of the tricuspid leaflets. So we have these various of the changes of the morphology. It's very important, especially for the type of intervention that could proceed for every one of the patients. This is the one of the very famous paper from the group of Professor Rebecca Hunt, which was published early in the 2019 and then 2021, which is the large variability of the tricuspid leaflets number of the morphology. This proposed new tricuspid nomenclature is very important, especially when we are trying to incent our patient for the intervention. This is the echocardiograph example for the tricuspid valve morphology. But what is more interesting about this, because the incidence of the it's very huge in the type 1 of the tricuspid valve morphology like this, when it's proposed here like the catheter for the pacemaker between the posterior and anterior leaflets. The adjustment structures is very relevant for the tricuspid intervention, and we could have this also in mind when we look at about this non-coronary sinus in Valsalva. There is a high risk of the perforation with the devices that are required and showing on this level. Also, the Hess bundle is there is the risk of the heart block when we look at about when they applying the pressure of this region. The right coronary artery here is also the risk from the injury and the acute ischemia with annular showing devices. This is another clinical case with this woman with dilated tortuous aorta. She is, when we look at on the right side of the heart, we find this very moderate tricuspid significant regurgitation. What is the explanation of this moderate tricuspid regurgitation? There is any link between the aorta and the tricuspid regurgitation. This is one of the very interesting paper that looked at about the patient with the dilated aorta, published in 2016, again from the group of the Professor Banano. They look at about the tricuspid valve anatomy and the function in this part of the group, because actually dilated aorta going to deformate the tricuspid annulus of this dilatation, and changing of this tricuspid annulus is performed with the different type of tricuspid regurgitation also. When we look at about the tricuspid annulus, we can say that the annulus is very complex anatomy, and the interaction between the mitral valve, aortic valve, pulmonary valve, there is also some complication. But the single measure, this provides very level information. We can find here that this is the sidal shape form of the tricuspid valve, which is elliptical or D-shape in the cross section also, and becomes very circular in the systole. How to measure the annular size? This is also one of the challenges with it's possible to do on different type of the modality that we using for the two-dimensional apical four-chamber view, apical right ventricle focus at right ventricle view, also from the 3D slice measurement of the diameter of the tricuspid valve, or to using the diameters from the 3D models of the softwares that they performed from the reconstruction of the 3D. But when we saw this paper from the Mayo Clinic from 2019, they use it to analyze the sites of the tricuspid annulus on the geometry, which is the very underestimated by the two-dimensional echocardiography. And there is quite a big bias between the methods when we use it for the analyzing the diameters and the annulus diameters from the four-chamber short axis, from the long axis, from the focused RV view, and on cycles, and the bias is very high. So the two-dimensional echocardiography underestimate in the larger of the measurements, which is done with the standard four-chamber view. So the tricuspid valve and the annulus, it's possible to analyze with the 3D, not only for the geometry, but for the morphology. When we look at about this, the normal heart, this normal annulus array and tenting volume, when we look into about the patient with the functional tricuspid regurgitation, we could find this annulus array, which is very large, and the tenting volume is again is higher. Another possibility of the 3D echocardiography of the tricuspid valve, this is the possibility to give information about the 3D valve and phase, and to prepare us for the different type of the new technology and to perform the printing of the valve. This is the one of the first printed 3D printing models from Denica Muraru, and the 3D enhanced the perception of the complex of the 3D anatomy on the leaflets. And this is the non-planarity of the tricuspid annulus. When we look at about the pathophysiology of functional tricuspid regurgitation, we have two phenotypes, which is very interesting. This could explain the type of the functional tricuspid regurgitation regarding the dilatation of the right atrium dilatation, or for the papillary muscle displacement. And the 3D echocardiography gives us more information about differences about the atrial functional tricuspid regurgitation and ventricular functional tricuspid regurgitation. The annulus is quite higher in the ventricular functional, in the atrial functional tricuspid regurgitation, and the tenting volume is lower. When we look at about the annulus in the ventricular functional tricuspid regurgitation, we have the smallest annulus and the higher tenting volume. The right atrium is also the major determinant of the deformation of the tricuspid annulus, and that could be explained with this right atrial myocardial fibrous, which is going to involve the tricuspid annulus, and the later the annulus actually, which is more affected by the right atrial fibrosis. This is the model that was performed in different right heart disease with the patient with the normal tricuspid annulus with the tetralogy of the Fallot, pulmonary hypertension, and left ventricular hypertrophic disease and atrial fibrillation. The differences of the modeling of the remodeling of the right atrium, it's influenced by the remodeling of the annulus, also on the tenting area of this group of the patient. This is the one of the last papers that was published a couple of weeks ago regarding the tricuspid regurgitation. There is the novel tricuspid classification that we could analyze the functional or the secondary tricuspid regurgitation for the atrial and ventricular type, and see it related regurgitation or organic and primary tricuspid regurgitation. This is another clinical case that I could perform during my presentation. This is the 61-year-old woman. She has the grave disease of the thyroidea. She is coming with the May 2080 with the heart failure, dyspnea, peripheral edema, and atrial fibrillation. For the thyrotoxicosis, there is all signs that we could find here after this analysis of the blood. We performed after the thyroidectomy. 2 months later, the patient spontaneously was in the sinus rhythm, and the Neha class was the second. What is the most important here? The restoration of maintenance of the sinus rhythm is very important for the rate control to reduce the incidence of the functional tricuspid regurgitation in the patient with atrial fibrillation. Atriogenic functional tricuspid regurgitation due to atrial fibrillation may be the most suitable subtype of the functional tricuspid regurgitation for annuloplasty repair techniques because it exhibits of the prominent annular dilatation with less tendering and the leaflets. Challenges also to achieve the satisfactory refraction of the arrow with extremely large annulus size, which is the 3 to 4 more from the normal values. Another type of the tricuspid regurgitation, this is the cardiac implantable device and related with them tricuspid regurgitation. Mainly the position of the catheter is very important for the severity of the jet of the tricuspid regurgitation. This is the one of the papers from JACO 2017 from the group of the Mayo Clinic that they look at about this management of the pacemaker and how is going with the patient with the tricuspid regurgitation. When we have this catheter in the posterior commissure, there is the interfere with the pacemaker catheter, and the tricuspid regurgitation is very large and when it's posted in the centrally of the catheter. One of the classification of the tricuspid regurgitation was proposed very early in 2013 based of the two-dimensional echocardiography. There is several signs that we must look at about for the quantitative, semi-quantitative, and qualitative qualification of the severity of tricuspid regurgitation. More of them are useful for the daily practice, but they take the more of the time. But when we look at about the mitral and the tricuspid regurgitation, there is very similar, but when we're analyzing with the PISA method, this is the very differences when we look at from the, especially for the tricuspid regurgitation. There is another paper that's proposed grading of the severity of the tricuspid regurgitation, actually based of the PISA method and the 3D vena contracta, which is important. We could have this severe, massive, and torrential tricuspid regurgitation. There is some pitfalls when we're using the conventional echo to grade the severity of the tricuspid regurgitation, actually. And the most important of this is the the complex of the way you have is how to cut the area where is the jet. It's changed during the cutting of and cropping the images from this. But the group of the Professor Badano looking about the regurgitance orifice shape of the 3D, and they proposed the severity to be analyze it on the couple of the changes. So the vena contracta, the one of the earliest studies actually performed from the Professor Nanda group, based of the vena contracta area of the tricuspid regurgitation. It's one of the beginning of this analysis nowadays. This is the one of the
Can you come to your conclusion slide because you have over by about 2-3 minutes.
Yes, I am finishing now. Actually, the quantification of this functional tricuspid regurgitation regarding the vena contracta area, it's going to be not so very fair because when we look at the R0.62 and bias from the 2 and 3-dimensional arrow, it's not so big. I think that this is not a very corrective method for the analysis of the especially the severity of the tricuspid area. Basic of the methods for the analyzing of the PISA, when we have the leaflets on the physics of the
Apologies to interrupt, ma'am, but we are overshot the time. With respect to the next speaker, can I request you to please summarize the talk, please?
We have these leaflets, which is not in the one level leaflets, but the moderate on the prognostic of the validation. This is the when we look at about the severity of the tricuspid regurgitation with the outcomes actually with the right heart and the failure on the deeds. So this is my last slide from here, and the new classification proposed to analyze new classification, new measurements, new imaging proposal for the tricuspid valve. Thank you for your attention.
Thank you, Dr. Krasimira. That was a wonderful lecture. You brought out some very important points of how 3D echo can provide incremental information. Please stay back for the discussion. This will be after the next speaker.
Yes, so Rakesh is there or not? If he's not there, then I have the privilege of introducing my very old friend Fabiola from Milano, Italy, who is a regular visitor to India, and her talk will be on cardiac amyloidosis, current clinical role of echocardiography. Fabiola, please come on line here. I hope you finish in the given 20 minutes or even less than that.
Okay. Yes, great. Can you hear me?
Yeah.
Can you hear me and to see my presentation? Yes. Okay. Good afternoon. I'm very pleased and honored to be here today. Thank you, Professor Parashar, and thank you to the organizing committee for such an important invitation. I learned a lot from the previous speakers, and now in the coming 20 minutes, I'm going to talk about the current clinical role of echocardiography in cardiac amyloidosis. I'm starting with a quote from Linus Torvalds. Probably you know him. He is one of the world's most renowned software programmers. He has revolutionized the computer history. He has even won asteroids on his name. And you know, he is saying it depends is almost always the right answer in any big question. And I would like to talk about amyloidosis and thick heart pathology, starting with this quote. As you know, amyloidosis is an infiltrative multisystem disorder, and amyloid is an insoluble fibrillary proteins that aggregates. Those proteins become folded, stick together, and precipitates in the extracellular matrix, creating a condition of disruption of the architecture of the cardiomyocytes, which go towards a process of necrosis. Therefore, a functional and structural heart changing is developed. Amyloid has an historical misnomer. Literally, it means stalk-like. Comes from a Latin word, amylum. Amylum is cellulose, but cellulose is a polysaccharide. Misnomer why? Because the professor, the German pathology, Professor Virchow, in the 1800s was involved in a big academic dispute. He called amyloid, he introduced this term referring to deposit of material destined in a similar manner to cellulose when exposed to iodine with this typical blue coloration. But amyloid is a protein, it's not a glycide. We know that there are more than 30 subtypes of proteins, of amyloid proteins, but which cardiologists need to know? In practice, there are only 3, fortunately, for cardiologists. So we have the AL, the light chain, abnormal clonal proliferation from plasma cells. It's a type of primary systemic amyloidosis that is also the most common and one of the most severe with a rapid poor prognosis. And then we have the transthyretin associated amyloidosis with 2 subtypes, the mutated type, which is autosomic dominant, typical of Afro-Americans, and the type due to a wild type deposition, typical in the elderly, so senile form in males. And then very rare, about 5–10% of the total cases of amyloidosis, of cardiac amyloidosis, is the secondary amyloidosis associated to infective disorder, cancer. So amyloidosis, cardiac amyloidosis begins with subclinical stages. We have initially a mild and specific presentation of cardiac symptoms. We have mild LVH, mild diastolic dysfunction, and mild impairment of the LV longitudinal function. But then the disease rapidly progresses. So treatments are not the same in the all phases and types. And that's why it's very important to be the earlier, the better, you know, as always in medicine. But I want to present it with this: one size doesn't fit all. It's true, especially for amyloidosis. We have a cardiac infiltration, and look how it looks like at the electronic microscope. The misfolded assembled proteins are sticked. Look how tough are. And in the section of the autoptic heart, we see that the assembled material create granular formation with wax consistency. And we look for those things, for those thickening in the echo. This is the base of the increasing of myocardial stiffness. Therefore, a restrictive cardiomyopathy is the evolution. The presentation in most of the cases is related to cardiac heart failure symptoms, diastolic heart failure at the beginning, right side heart failure, and only in the advanced stage we have left ventricular dysfunction, visible reduced ejection fraction, only at the end of the disease presentation. And amyloids, as we said, those proteins misfolded, deposit everywhere in the heart. Of course, in the walls, in the myocardium, but also in the valves, in the interarterial septum, and in the conduction system. So one of the typical symptoms is atrial fibrillation, but in some cases, we face ventricular fibrillation, ventricular flutter, like in this case that evolves in ventricular fibrillation. And fortunately, the patient had an ICD that properly gave a shock. But you know, ICD is a cosmetic treatment. The disease is restrictive, the stiffness is the problem. So we have to arrive the earlier as possible. And in the echo lab, we have to perform a comprehensive echo to estimate what type of thick heart pathology we are facing. We have to differentiate between cardiac amyloidosis myopathy from hypertrophic cardiomyopathy or simply LVH in a hypertensive patient. Now I'm going to present 3 cases. Easy cases. So the first one is a 54 years old woman affected by hypertension with some signs of heart failure. We look at the echo. The echo is very easy. You remember this section of the pathology, of the anatomic pathology, and look how it looks in the, how it's presented at the echo. We have a concentric hypertrophy in this parasternal long axis view with granular sparkling that has wax consistency. We have this highly refractile agglomeration, valve thickening, and we have concentric left ventricular hypertrophy together with concentric right ventricular hypertrophy. The ejection fraction is barely normal, but the problem is related to the hypertrophy and volumes. So we have small volumes, and we have a thick right ventricular wall from this subcostal view. You know, the cutoff is more than 4 millimeters. And then we have again here very clear the concept of small volumes. The viscosity increases. So one of the presentation in this patient is thrombus, and one of the treatment is anticoagulation related to atrial fibrillation, atrial thrombus, but thrombus in general for amyloid patient. The patient has an interesting ECG, an easy ECG. We have, in fact, in the peripheral leads, a pseudonecrotic pattern in the inferior leads with a low QRS voltage. We have it also in the precordial leads, this poor wave progression. So the combination of left ventricular mass index, elevated left ventricular mass index with low voltage EKG pattern shows a very high specificity. But this condition is quite rare. I mean, it's about, in general, of amyloid patients, 25%, maybe 1/4. So it shouldn't be the ECG, the main criteria. But we have to know that the presentation can be also that one. Let's move to the important phase of Doppler study. First criteria for a restrictive pattern, as we said, in infiltrative disorder, with the thickening of the wall. We have the mitral inflow diastolic velocity showing an EA ratio more than 2, with a short deceleration time, less than 150, and no respiratory variation of the mitral inflow velocity, which means high increased filling pressure in the ventricle, but also in the left atrium. In fact, the pulmonary vein flow is showing an inversion between diastolic and systolic velocity. So the systolic velocity is much lower. The predominant part is the diastolic part. But why? Because the left atrial pressure is increased. The atrium has lost the contraction function. It's just a conduit with no reservoir function. That's why we have this increase in pressure and this morphology at the pulmonary vein flow. And then, you know, when you have a wall thickening, the suspect of infiltration, and you analyze the mitral annulus tissue velocity, and you find a reduced mitral tissue velocity, E prime, A prime, this is indicative of decreased longitudinal contraction, and it's a hallmark of amyloidosis. So echo is an excellent screening tool because of diastolic functional assessment, the conventional left ventricular remodeling, but especially nowadays, we are having different informations from the deformation-based parameters, which has gained a momentum recently. Strain, you know, is a myocardial deformation. Parameters is a percentage in length of the individual myocardial segments at systole and systole minus and diastole divided and the diastole. It's a percentage. and is representing an early marker of LV dysfunction in several cardiac diseases with normal ejection fraction. Is a predictor, and it should be incorporated into the cardiac exam. In our patient, we have a biventricular thickening with speckled myocardium, and we can show the 2D strain speckled tracking echo in the several segments. This is a 4-chamber view. We have to do 2, 3-chamber view, and then we create the curves in each of the corresponding myocardial segments. And we did use the map with in amyloidotic patient the characteristic basal to apical gradient of impaired longitudinal function. In fact, in patients with amyloidosis, like in our patient, the global longitudinal, the GLS, the global strain is diminished despite the apex is preserved. The apical longitudinal contraction is spared compared to the basal and middle segment. At the polar plot to the reconstruction in our patient, we see that the apical segments have a better strain from -23 to -10 in comparison to the mid and basal segments. So we have a lower deformation in these segments. This is a normal case. And this is an early parameter with the normal ejection fraction. It's known that when we are talking about LVH or storage disease, we are in a gray zone. All these type of diseases present with a similar diastolic dysfunction, but for cardiac amyloidosis, we have a longitudinal strain with relative preservation of the apical function. Definitely the gold standard, especially for the TTR type, is an endomyocardial biopsy. But as you know, it's invasive, it has a restrictive use. The abnormal wall-fat pad biopsy is almost mandatory. It has a high sensitivity in the AL type. You see, this is a congruent stain fat pad, which is positive for infiltration. And at the polarized light, we have the typical apple green birefringence of this is a characteristic the microscopy of amyloidosis, but this biopsy, the abdominal wall fat pad, has a very low sensitivity in the TTR type, so 20%. Let's move to case 2. Now we have a 60-year-old man with hypertension, some symptoms, chest pain, dyspnea, and the ECG is showing a low QRS voltage, again, like in the previous patient. And the echo, again, we have a concentric hypertrophy, LVH with left atrial dilatation, some pericardial effusion, barely normal ejection fraction, and concentric hypertrophy in the left ventricle, but also in the right ventricle, small chambers again, biatrial enlargement, sparkling myocardium. So we are in the condition of the thickening with reduced relaxation. The thickening has increased, the atrium has become bigger, the left atrial pressure has increased, and we have a condition of pushing from the atrium to the ventricle. It's not related to the LV restoring forces that are generated during systole. We are in the grade 3 diastolic dysfunction. In fact, in this case, again, we have the EA ratio with more than 2, restrictive pattern, and the EE prime, you see, E prime is very low, the velocity, EE prime is more than 2 anti, so restrictive, absolutely advanced diastolic dysfunction. The left atrial volume index is increased, And remember, the atrium is stiff because of deposit of amyloidosis. Therefore, we have a very small A wave. We have a loss of the left atrial function with almost exclusive diastolic flow at the pulmonary venous flow. And the global longitudinal peak systolic strain is decreased with a classical apical pattern with the strain that is relatively preserved in the apex with significant impairment in the base and middle segment. As Professor Lisa said at the beginning of this session, the atrial strain in patients with HFpEF is reduced, and in cardiac amyloidosis, like in this patient, we assist to a globally significant impairment of the atrial strain compared to that is a normal patient, left atrial systolic positive peak. Our patient has a small right ventricle, reduced TAPSE, indicative of reduced right ventricular function, increased TR jet velocity, which correlates very well with the systolic pulmonary artery pressure. And we have also to give a look to lungs. The patient has dyspnea, and we show at the echo some lung congestion. You see the comet tails with a B line with this hyperechoic reflection originating from the pleura and traveling perpendicular to the pleural line. This is quite typical of lung congestion. And then I move to the last easy case, but a bit more tricky compared to the previous one. It's a young woman, 42 years old, no cardiac symptoms and somatic polyneuropathy. Why should we think to cardiac amyloidosis? The ECG is showing a sinus rhythm with a first degree AV block, no low voltage complexes, and yeah.
only 2-3 questions.
Yeah. So the ECG is not showing low complexes, and the echo is normal volumes, normal thickening, normal contraction, normal atrium, normal septum. And the EA ratio is normal, but in this patient, TDI is a marker of early diagnosis. E prime and A prime are showing a reversion with a pseudonormalization, and E prime is 70. Again, the GLPS is showing a decreased peak systolic strain, and compared to normal, and compared to LV strain, like in the hypertrophic cardiomyopathy, we have this preserved function at the apex. Remember that in the subclinical stage, the longitudinal deformation is normal at the apex and is abnormal in the base and in the middle segment, and this correlates well with the worst prognosis. Survival is getting worse in patients with reduced GLS. In the left ventricle and also in the right ventricle. In the early cardiac amyloidosis, we have preserved GLS in the apex, but not in the base and the middle segment. The most challenging population is normal ejection fraction with mild
Apologies, ma'am, but
and the last,
if
1
you
second.
could submit.
Yes. Last position paper 2021 is saying
conclusion slide.
And one symptoms go for diagnosis of amyloidosis. Think about it, because the successful diagnosis comes from the high clinical suspicion. Thank you very much for your attention.
Thank you for the great talk. I think because of shorter time, we will have just 2-3 questions, because Dr. Chopra was very keen to have a question from Lisa.
Lisa, if she's there.
I know it's very late in Sydney, but still.
Lisa, I think my question is very relevant to the clinical practice, because you gave a very nice talk on LS strain, and you mentioned its relationship with the RAS communication, which is a very, very important marker. My question is that functional remodeling of the LA is a reflection of morphological remodeling of the LA. And morphological remodeling is a remodeling of cell or myocyte, and myocyte is a remodeling of the sarcomere, and sarcomere is a remodeling of the mitochondria. The drug like SGLT2 inhibitor or ARNI affects at every level. So what do you think? Are there any data, anecdotal data to show the reversal of remodeling in the LA by improvement in the LA strain? I am aware of your last slide, which you mentioned, that there is still limited data on the therapeutic intervention and improvement of the LA strain. We'd like to have your opinion. What do you think is the future?
So that's a great question. Typically with LA remodeling, with structural remodeling, you get to a stage where once it enlarges too much, no matter what you do, you can't get it to go into reverse remodeling. But early on, in the early stages, before it's got to that stage of, very significant remodeling, there are a few studies which have actually looked at ACE and ARB and treatment of patients and have shown that strain actually improves in patients who don't have a very dilated left atrium. Whereas in those who have a significantly dilated left atrium, we don't see that reverse remodeling. But it was small studies, and I think one of the limitations is that many of the therapeutic targets focus only on the left ventricle. But perhaps in the future, I think the left atrium will be used as a measure of therapeutic intervention.
Well, Lisa, has it come to a prime time use on a daily basis?
Sorry?
Has LS-strain come on a daily basis as a routine test or just?
No, it definitely hasn't. But say, for instance, in our laboratory, it is something that we do in special interest cases. So we certainly are starting to do left atrial strain in stroke patients, particularly those with ESUS or embolic stroke of unknown source. That's one area of interest. We also tend to use it for diastolic classification, particularly in those with indeterminate diastolic function grade. I think as left atrial strain becomes more automatic and more dedicated software packages just to measure left atrium, it will gain increasing popularity.
Just one question from Fabiola. This apical sparing, or you can say cherry on top. It has been found in other cases of also not only in amyloidosis. Is it specific for amyloidosis, or it can be found in other situations also? The cherry on top.
Yes, it's considered, yes, thank you. Thank you, it's a great question. It's considered one of the typical characteristic of GLS in amyloidosis, but certainly LVH can present in many other conditions. And that's a typical marker, but it's not the only markers. So we have to be flexible with numbers and data. Absolutely. So if you don't find it, that's not sure 100% that it's not. Many studies have shown it is diagnostic and a predictive value.
Thank you very much, our international masters from Europe, for accepting our request. And I'm sure in future also, if we try to trouble you once in a while, you will cooperate with us by giving an excellent talk what all of you have given today. Thank you very much.
Thank you so much, sir. With that, we conclude this session and immediately move to the next one. Can I request the chairpersons to please switch on the camera? We've got Dr. A.V. Anjalelu, we've got Dr. Mona Bhatia, we've got Dr. Munesh Tomar, Dr. Atul Verma, and Dr. Anil Saxena. It's going to be a debate. So can I also request Dr. Satish Govind sir to please start his screen sharing? And I request the chairperson to please introduce our first speaker.
Good afternoon. We have a very interesting debate coming up. When we all started with M mode and then went on to 2D echo, then the Doppler gave us an additional of hemodynamic evaluation. Transesophageal echo we thought is the finest thing we had, the clear images, especially the posterior structures. Then came the intracardiac echo, epicardial echo in pediatric cardiac surgery, giving much finer details of the cardiac structure. Then, of course, 3D echo took quite a long time to evolve. Finally, gave us some important images, clear images, especially with the latest edition of illumination. We are having a very fine definition of cardiac structure with the 3D echo. Simultaneously, for the last 5 to 10 years, MRI and CT also started imaging the heart, and we know we depend on them in specific situations. So in the backdrop of this, we have this debate. Dr. Satish Govind, we all know he was the former editor of the Indian Academy of Echo Journal. So he will be initially starting the debate, arguing that structural heart disease echo is the ideal imaging technique. Dr. Satish.
Thank you, Dr. Anjaneyulu, and good afternoon to all of you. So let me hit the talk straight away. Structural heart disease is a very hot area right now. And the question today is echo the ideal imaging technique? So let us see where it stands. First and foremost, let's look at the definition itself. There's been a lot of debate about what is the ideal definition. So this is something which has been settled upon, though it is not appropriate, though it is not correct. So there are no suitable alternatives there. And this was first suggested by Martin Leon in 1999 at the TCT conference. And what does it tell us? So what is the definition? It involves all non-coronary cardiovascular diseases with related interventional techniques. So this is the definition of structural heart disease. So what is the role of echo in structural heart disease? So this is the patient's pathway. So this is the care pathway. And as you can see here, the diagnosis starts at the patient, and after that, the patient is selected for intervention. And then the procedural planning is applied, and then the guidance is done during the procedure, and then there's a follow-up. So at every step, echo is required. So that is the value and the utility of echo. Now, what exactly is the value that echo provides? So when you look at echo, so this is an age-old definition. So what does echo bring to the table? So it provides complete assessment of the heart. So in terms of anatomy, in terms of physiology, functions, and hemodynamics. So that is the what is called as the standard echo. With the advent of advanced techniques, especially now, which has been strengthened with artificial intelligence, so now we sort of have more robust and more accurate quantification, especially looking at 3D of the LV, the 3D of the RV, and then the strain. So this makes it well-rounded and almost a comprehensive sort of package when it comes to evaluation of structural heart disease. Now, when it comes to diagnosis, selection, procedural plan, so when it comes to diagnosis, TT is the first line of imaging, and later on, as the selection and procedural plan sort of comes, then TE takes over. So T is the imaging modality of choice, particularly 3D-T, and that is the time when the interventions are planned. So why is it so important? Because it provides additional insights into soft tissue anatomy. So the examples are here. So these are sort of regularly obtainable images. This is how the level the imaging has reached in echo today. So as you can see here, so this is the posterior mitral leaflet. One is flail and the other one is prolapsed, and one can look at very fine details of the chordae also. And then there is the jet, the MR, where it is coming from. And now we have the recent advent of the so-called glass view. So this is a transparent tissue. So one can look through the tissue and look at the adjoining structures, and this gives us better insight. So this is the status of 3D-T today. Now, what is the scope of structural heart disease? So one can start at the atrial level. So this is the atrial septum. So there is the PFOs and the ASDs, and then coming down to the ventricular septum, the VSDs, and then moving to the chambers, left atrial appendage, left ventricular aneurysms in the left ventricle, PDAs, prosthetic valve, paravalve leaks, hypertrophic cardiomyopathy, valvular heart diseases, and others. So this is the spectrum of diseases which are which gain prominence, and these are the ones which are more sort of focused upon in structural heart disease. Now let us take an example here, ASD. So the regular echo provides us a good image of the defect. So the defect sizing can be done, the rims can be seen, measured very precisely, additional information in terms of color flow can be obtained, pressures can be obtained, any other abnormality can be also seen. And 3D T provides better understanding of the defect for the device implantation. And during the device implantation itself, so both 2D as well as 3D provides us great images and gives us the confidence to give a good outcome to the patient. So the question, so does it provide complete assessment? Going back to the checklist over there, so anatomy, physiology, functions, hemodynamics, diagnosis, additional insights, procedural guidance, and follow-up? Yes, it's a big yes here. So it does provide answers to all these questions. Another example here, patent foramen ovale, and then there is the VSD on this side. So one can look at the patent foramen ovale very closely, and then this is the device. So this is what we have done for one patient. And this is the VSD on the other side, a very small, tiny VSD. So this was a doubly committed VSD. So this again, both these patients underwent device implantation, and a good outcome was there. So the question again, does it provide complete assessment? Yes. Now, one more example. So this is left atrial appendage. With left atrial appendage, the 3D, one can look at the ostium. The measurements can be done both in the cross-sectional as well as the longitudinal one. And during the intervention itself, one can guide the interventionalist in terms of where to put the device, and then there is the device closure here, and where how many devices, where exactly are the abnormalities and the residual leaks. So this is again, I think now you got the drift. So echo can provide these answers. So what about the guidance itself during the procedure? So 3DT can visualize the entire scenario, and it can look at long segments of the catheters, tips, devices, and a lot of other things. And this is just in one single view. And again, there's a comment here about innovation and progress. So in particular, it has benefited echo, and this has allowed for a surge in the percutaneous structural procedures. So this is an example of how it is helpful. So this is intra-procedural guidance. So this is a case we did a few months ago. So this is a valve and valve. So you can see that there has been a septal puncture here. So it can guide the septal puncture and then look at the trajectory of the catheter. And then again, during the time of the implantation, guide the interventions where exactly to land and at what angle to go. And again, with the use of the explained by plane imaging. So echo can visualize the entire scenario, and again, a big yes here. So can it look at all the available information that is seen? Now, what about the combination of fluoro and 3D echo? So this is the fusion imaging. So again, here provides real-time images for guidance of interventions, and can look at fine catheter manipulations, look at anatomy, look at color Doppler, and also the markers within the echo images can be superimposed on the fluoro screen. So what happens? So it reduces fluoro time and radiation. So this again, echo plays a big role, 3D echo. So these are examples here of septal puncture. Here you can see that the septum, the marking has been made on the echo images here and superimposed on the fluoro. And this gives a very precise location for the interventionist to make the puncture. And it can define the chambers here, and complex ASDs, it can be very helpful. And also for valves, where exactly the annulus is, and then the position and the landing of the devices, that also can be very nicely told. Now, let us say that there is a time when echo T cannot be done. So there is intracardiac echo which is available. So these are the list of procedures where it is very helpful, and it provides images with high resolution, and it can be performed without sedation. So now even 3D echo is available. So ICE is a big boost. Now, the unthinkable. Can echo be done in the cath lab? Can a procedure be done in a cath lab without fluoro? Yes. So this is a study which has been done in the US, looking at children here, and they wanted to find out whether the right heart cath and the ASD closure could be done without the use of fluoro. And they compared two groups, and the result was 54% reduction in total fluoroscopy, 78% in radiation reduction. So it is feasible without the use of fluoroscopy. So what else can echo do? Valve measurements, yes, this is a weak point here. So this is again in the certain scenarios where the CT or MRI, it cannot be done in some patients. And again, data is there, which can be used as a standby here. So these are semi-automated softwares, and it can be done in mitral valve interventions and aortic interventions like TAVI. So the list goes on and on. So just one last one. So this, what else can echo do? So again, exercise echo can be done. And this is in the valvular disease, looking at clinical usefulness and then the prognostic impact. And also it is moving outside the echo lab itself. So it can be used as a screening device. And this is one publication. And also from India, Satya Sai and Dr. Shrikant Sola many years back showed that they also published data where echo can be used for structural heart disease screening. So to conclude, so echo in structural heart disease, it provides for comprehensive imaging. It is for diagnostic purposes, patient selection, procedural planning, guidance, post-procedural follow-up. And if you look at the structural heart disease management, it relies heavily on structural imaging and hemodynamics. And this is where echo brings its value. It can be done bedside, and it can be done in the cath lab, widely available, images interpreted in real time, and the skills are acquired in a reasonably comparatively short period. And now with the echo machines getting to be more and more sophisticated, they're improving dramatically. The AI is being integrated, and that is further giving it more strength. And 3D echo has been the mainstay, along with the TT and ICE and contrast echo are adjunctive. So let me finish with this: imaging in the care of the structural heart disease patients. So this is a patient pathway. So let's look at patient selection. Where does echo feature? Right at the top, and CT and CMR come below. What about procedural planning? So this is the weak area where CT comes first, but again, echo is above CMR here, and T will be suitable as the first line in certain scenarios. Procedural guidance, obviously fluoro will be at the top, but look at the wide spectrum that is available to us. And on follow-up again, echo is right at the top, and the CT, PET-CT comes below. So is echo the ideal imaging technique? So based on what I've shown, so I would say with a resounding yes, it is the imaging modality which should be used. So echo leads the pack, is the leader of the team, is a primary imaging modality, and it provides great outcomes. And the CT and MRI obviously are the supportive ones, but they are sort of less utilized in certain scenarios. Thank you.
Thank you, Dr. Satish. That was a very powerful argument in favor of echo in the evaluation of structural heart disease. I request Dr. Mona to introduce the other speaker, Dr. Johan, to counter this argument.
Absolutely right, Dr. Govind. That was an excellent part. And in fact, I, being a CTMR person, was almost convinced that that echo is the way to go. And but yet, whatever happens just before they go to the cath lab, they always come to us and they want a CT. They want everything sized. So I'm going to hand it over to Johan. Johan has been the past convener for the CSI for cardiac imaging, and he's at Care Hospital. He's a very, very senior cardiologist who wears all the hats of cardiology and imaging. So over to you, Johan, to give us a rebuttal on why not echo.
Thank you very much, Mona, and my respected chairpersons and senior teachers. So thank you, Dr. Govind, and we'll be talking about the other techniques. First, to introduce, we can realize that from open heart surgery, we're moving on to minimally invasive percutaneous procedures. We have a myriad percutaneous procedures now, and this is giving way to new imaging modalities and widening recognition for less and less invasive treatment options, ability to treat unacceptably high-risk patients, and new interventional technologies are future-proof. We do know that in 1985, the Maruti was first introduced in the subcontinent, and it was a great hit. It was the car of the year. And cut to 2021, we have the electric vehicles here, and there's been a great leap during this time. We have moved from unidimensional procedures like open heart surgery, where there is a small restricted view, to unidimensional procedures in the cath lab, where you have a two-dimensional view on the catheter and the lesions. And now we are moving on to multimodality imaging, where you have echo, T, you have the family of cath and fluoro, CT, MR, PET and gamma, and also the intraprocedural techniques. And all of these, when they're used in combination, represent multimodality imaging. So whether you're looking at the mitral complex, where you're trying to use an echo and an MR, or you're using the aortic, or you're looking at the aortic root where you're using CT and echo, or you're using the CMR and echo in myocardial diseases, the future is in multimodality imaging and using the strengths and weaknesses of each technique. Hybrid imaging, again, is an area where we are moving into, where we're looking at CT and fluorofusion in patients for TAVR, cardiac road mapping in patients for CTOs, and also using the MR and the angiogram in patients with LV dysfunction and heart failure. Now, the mechanism of imaging, as you know, is different in different techniques. The contractile reserve and the tissue volume loss is important in echo, and the nuclear images rely on the metabolic function and metabolic transport, and MRI looks at most of them. So looking at the strengths and weakness of the mechanism, we can use these techniques interrelatedly. Now, the huge benefits of multimodality imaging is in operator confidence, procedural success rates, outcome measures, procedure time, radiation exposure, and improvement of patient selection, and finally, procedural planning and success rates. Now, these are the list of areas wherein the multimodality can be avoided and can be used only as a substitute, where echo definitely reigns supreme. And this is the screening tool where echo is absolutely a very appropriate investigation, whether you're translating from an abnormal heart sound to looking at patients with valvular heart disease, looking at valves, and looking at systemic diseases. Then second is mitral regurgitation, where most of the mitral regurgitations would be happily looked at by echo or T, but there would be a few small cases where there is indeterminate mitral regurgitation, or there's a mitral regurgitation associated with ischemia or viability, where you need to use CMR. Again, for the evaluation of severe aortic stenosis, you can see that echo is an appropriate choice along with the T. But however, in patients with difficult to view aortic valves, again, CMR and CT come into the picture. Post-procedure as a screening tool for complications, again, echo is a very, very important and ideal technique. In the imaging of prosthetic valves, again, echo and T are usually the first line techniques for the evaluation of prosthetic valves. And MR comes in much later, only if it is a biprosthetic valve and you find that there is an indeterminate valvular dysfunction. But there are areas where multimodality imaging really shines through, and I would believe they are a must-have for clinicians. And the first one, and this is something that we are all in agreement, is in pre-TAVR patients. And you can see that apart from the initial screening of an aortic stenosis patient, CT and MR truly rule the roost in terms of aortic dimension, in terms of the atherosclerotic burden, and the iliofemoral vessels. The second area is a difficult to treat subset of low flow, low gradient ES, where you find that MR and CT are actually appropriate investigations. Aortic regurgitation, especially if it is chronic and especially if it is associated with dilated aortic sinuses, again has CMR and CT being important. Right-sided lesions is always the Achilles heel of transthoracic echo, and CMR is the gold standard for evaluating these structures. Inadequate images, and as our population gets bigger and fatter, we realize that echo images become substandard, and MR and CT are very, very default investigations. And whenever you have a discrepancy between the echo and the clinical findings, again, CMR and CT are important investigations to use. Now, these are the scanners that we use in MR and PET. And when you look at coronary artery disease, you can see that in CT, you have mild lesions in the LAD and left main, and this is the VRT images. The problem starts happening if you have a borderline lesion in the OM. And then if you have a SPECT CT, you can clearly see that on stress, there's a significant ischemia in the OM territory, which is normalized at rest. And the same can be depicted in the 3D model, that there is significant ischemia. And when you do the cath, you realize it's a tight lesion of the OM1, which needs fixing. So fusion imaging is the way to go. In a patient with a normal thickness wall in the LAD after an LAD infarct, you see that the whole normal thickness is actually full of microvascular obstruction and thrombus here, which is only seen on the MRI and helps to avoid unnecessary intervention in these patients. In patients with cardiac masses and unclear LV geometry, you can clearly see that not only are we finding a thrombus, but you're also seeing an LAD scar in the anterior septum. In LV restoration surgeries, again, MRI is the default tool to look at the LV volume, the LV aneurysm, and also in successfully following up these patients because the geometry and the volumes are very, very important to calculate. In valvular heart disease, the flow is to use CT, cardiac MR, echo, and fluoroscopy in a pre, during, and post procedure. And the flow chart is after the initial assessment of T, and if you find that there are any issues on the transthoracic echo, the use of T, the use of CT, the use of MRI are all acceptable in the initial assessment. During the intervention, again, echo rules, but in the post-intervention, when you're looking at the follow-up with the aortic dimensions, whether you're looking for difficult to see paravalvular leakages, MR and CT are important. If you look at the checklist for TAVR, you know that it's a huge checklist, and you have to have a multimodality imaging to look at the aortic valve, the calcification, the coronary arteries, and to look for thrombus or pannus in patients with already impacted valves and to see them properly. To look at the access route, again, CT is important, cannot be seen with echo. And when you're looking for the perfect angle to intervene with the valve, again, CT provides that answer. When you're looking for mitral valve replacement, again, the MR is a very, very important tool to quantify the amount of mitral regurgitation and to look at the annular size and the valve leaflets. And then echo can be used, especially 3D and T echo. And finally, the actual measurements are taken on CT before you implant the valve. And this is following what is happening with the TAVR. LA occluded, again, initially was evaluated by T, but with the data that is coming in from TAVR, we find that the ostium of the LA appendage has to be seen in a three-dimensional manner, not in a two-dimensional, and hence CT again is now emerging as a gold standard for the assessment of the length and the ostium for LA occluder devices. Before you put in a CRT, the role of MRI in looking for scar, looking for ejection fraction, dysynchrony, and the absence of scar in the infralateral wall and the coronary venous anatomy, especially if you have a challenging anatomy, again, MRI is an important tool. CT also has been used, and we have our own data with using CT for looking at the coronary venous system in order to make sure you have the right vein for implanting the LV lead. In terms of ICD, also before an ICD is implanted, MRI is the gold standard for ejection fraction and also for scar assessment here before you go in for an ICD. In congenital heart disease, again, ASD devices are usually seen by echo and T, but challenging anatomy, MRI is used to delineate the ASD. And also finally, after the device is put in, if there's any complication, CT is used to assess the valve location, the valve position. In post-ICR patients, initially echo has been used for the calculation of RV ejection fraction and pulmonary regurgitation, but it is MR which is the gold standard here. And you can see the MR images here with a very, very accurate regurgitation fraction, which is used prior to pulmonary valve cutaneous implantation. In cardiomyopathy, sarcoidosis is one such disease which has a regional wall motion abnormality. It has scar, and it also has lymph nodes, but also for prognosis and for follow-up, we do a PET CT, which shows the myocardial uptake and the nodal uptake. And after immunotherapy, after 3 years, you can see that it's complete absence of FTG PET uptake, suggesting there is complete resolution of the sarcoid. Hence, in conclusion, I would like to say that merging data from different non-invasive imaging modalities provides enhanced functional and anatomic information in real time. Combining information rendered by different imaging techniques in a single data set helps the interventionist to make the right decisions. Orientation in 3D is possible only with MR and CT, which are cross-sectional imaging modalities, where you look at the cardiac chambers, anatomy, and device orientation. The procedure time comes down, the volume of iodinated contrast comes down, and radiation exposure comes down. And we know the tale of two cities, and PET MRI is a perfect tool where you look at function and you look at scar. Thank you very much. I rest my defense.
Yes, Dr. Mona.
Thank you so much, Johan. That was an excellent and a very, very devoted talk for CT and MR, extending all across all aspects, going from inflammatory to structural to ICDs to TAVRs, TMVRs, LA, occluders. So you covered it all, and that was brilliant. And we're back to Dr. Govind. Do you want to make a rebuttal on this?
Yes, I would like to show a few slides. First of all, let me congratulate Dr. Johan on a wonderful presentation. He brought out a lot of good points. So structural heart disease is an integrated approach. But again, just to sort of strengthen what I told earlier, that echo is the ideals and the imaging which is necessary for structural heart disease. I'd just like to run a few slides. So one is if you look at the care of structural heart disease, it depends on the anatomy, it depends on adjacent structures and the cause, mechanism, quantification, valve lesions, and presence of other abnormalities, and then the planning and the guidance. So all of this, if you look at it's like a checkbox, and everywhere echo sort of ticks the checkbox here. And as far as quality of imaging is concerned, which Dr. Johan brought out, I think TE can, and to a large extent, does provide enough images when it comes to bad images on TT. So the use of other imaging modalities is only in certain areas, and that I do agree and I do accept it. So let me sort of give an example of where he did show about mitral interventions. So this is a head-to-head comparison of how TE and CT fares as far as the two modalities are concerned. So the ones with the big boxes, you can see that there are a lot of pluses as far as TE is concerned. So you're definitely sort of conveying that this is a superior test. And there are areas when I have to accept that CT does score. So this is where it is echo is weak. So calcification when it comes to the LVOT, new LVOT size estimation, and then the 3D printing part of it. And of course, it has no role in terms of vascular access, vascular imaging, and then the fluoroscopic projection estimation. So, but by and large, this slide clearly shows that T is very close, and in many areas it is superior to CT. Now, this is an area, the weak area, which I agree. So this is now where echo is actually sort of cannibalizing a little bit of the CT images and trying to come out with images which can combine both. And this helps us in getting immediate information next to the patient bedside. So this is with CT. And what happens now is that with AI and with this integration over a period of time, the software which is presently available for the size measurements, the semi-automatic ones, the software will improve. And this is something which is a ground where we'll see more improvement. And what about the virtual reality? So this is something which again, echo, you saw a wonderful lecture by Dr. Lang yesterday. So this will be very helpful for diagnosis, for the selection of patients, planning. And this is again something which is happening and which is going to come. So this is again, echo, which is leading the way where innovation is happening. And my last slide is to predict outcomes. So again, a lot of work is going on, and it's already where we are beginning to see the fruits of it. So where AI and computational modeling is sort of being incorporated, and this is looking at the LV shapes, looking at the remodeling, both in terms of disease diagnosis and also with therapy and follow-up, and also 3D staining. So this again, in the next few years, will further strengthen echo as the imaging modality. So I would like to rest my case saying that presently echo is the ideal technique, and in the coming years, I think it will be unbeatable. Thank you.
Thank you, Dr. Satish. We all agree that both the speakers have put up very strong arguments for their own cases. But whenever such debate occurs, we all know that the truth lies somewhere in between, being both speakers being correct in their own way. We all know that in many specific situations, we need the help of CT and MRI, especially in cardiac masses evaluation, inflammatory diseases of the heart, infiltrative diseases of the heart. We have to necessarily depend. And so the future is going to be multimodality imaging. That's what I feel about.
I think what I want to say is that it also depends on the institution you are and what is your strength, because I think what's really important is what is the strength where you are located. Sometimes the CT scan may not be as good. Maybe the MR isn't even available. Maybe the echo is the best. So I'm sure there are, sitting in the echo conference, some of our senior faculty here are so good at it that you probably can beat most 80% of the people who do a bad CT. So there is no doubt that an echo has been there for decades. and continues to stay your first line modality for sure, with a lot of advantages, especially the functional data that it gives you. So given all that, I believe that definitely it's multimodality the way to go. There are certain institutions where CTMRs are done very well. You have experts doing it because these are modalities that not only need a very good equipment, they need a very good man behind the machine, they need the technicians, they need a lot of training. And if that training is not there, it's a bad tool and it's like garbage in, garbage out. So for sure, we need to keep it at multimodality, because finally what CT does, especially in the pre-procedure assessment of TAVRs and various other devices, is that it gives you the precision without the inter-observer variation. And that is what is needed. And then the fact that you can actually merge that data into the cath lab, that is where it's really beating it. There's no doubt AI is the bad buzzword, and we hope that it will get to the point where it will be clinically relevant, because at this point, I find that most of the AI that's coming into, at least in imaging, is very piecemeal. It's giving you little bits and pieces. It doesn't give you the whole crossword, and you don't have the whole elephant. You just have bits and pieces, and you can actually read it wrongly. So given that...
Mona, I just have one comment. Again, want to thank Dr. Satish for that wonderful presentation. And I do believe that echo is the starting point for any structural heart disease. Two areas I believe, and I think he also touched upon, is in AI. AI is coming in quite fast, and CT and MR, just because they're cross-sectional imaging, is able to absorb it faster and integrate it better. And 3D printing, especially in the field of congenital heart disease, difficult to a very complex congenital heart disease, MR is turning out to be a very, very important tool in the planning and the performance of surgeries. And I do agree that the 3D echo also has the same capability. But I think these are areas in which going forward, we're going to be seeing more and more of these things. But the ideal situation is all of us, sitting together and being on the same page, exploiting the strengths and decreasing the weaknesses of each tool. I think that's the way forward. Thank you.
I think 3D printing is overrated. That's my personal opinion, because I got about 4 or 5 3D prints made recently. And the thing is that the person who's printing usually knows nothing about it. So they ask you to map it out. By the time you map it out and they create it, and then they say, where do you want it to be cut? Between the cuts, you can actually lose the relevant information. So we've had a few DORVs, VSDs, various things that we wanted to get 3D printing done. And I just found that the final image that comes is not as it is rated to be. So I think it's a little overrated for me.
I think we are running behind time, and we all agree that we don't have to be adversarial with one technique against other. We can utilize the strength of all. So thank you very much. Both the speakers have done a commendable job. Thank you so much. We can proceed.
Thank you so much.
Thank you very much. Thank you.
We would now like to move to the next session. And for the next session, I request the judges to please be with us. We've got Dr. R. Aligason, we've got Dr. Nitin Burkule, and Dr. Smita Mishra. I request the presenters to please be on standby. The total time allotted is 8 minutes plus 3 minutes for discussion. So the timer will be set for 8 minutes. Since this is going to be a competition, the timer is going to be strict. We're going to have a buzzer, and we would also stop the screen share. So kindly be on.
Actually, there are 3 judges. So
yes,
once
sir.
I think they have heard all the cases, then I think they can give their judgment. Either they will either through the mechanism they can all the 3 talk, or you can devise some method, or they can ring up.
We got the 4 numbers. We will call by we have a conference call and then get the.
Nikhil, have you got any other method in which only 3 can be joined together in a Zoom?
That's what phone call, conference call.
So, yes, as Dr. Aligason is saying that you can do a conference call. It's one of the methods. So that can be taken on an offline, because any which way that's going to be a very private call. Between the judges, they could decide if one of the judges is going to speak to one of them, the second one speaks to the second, and third one to the third as well. Apart from that, I believe we would like to then get started, because we are already running a little bit behind schedule. With your permission, sir, can we get started?
We are also in a group. I have created a group for the 3.
Okay,
Dr.
wonderful,
Nitin and Dr. Alag.
Okay, okay.
So with that group, I think WhatsApp calls can be done. So 8 minutes is going to be the timer. First, can I request the judges to please invite our first presenter?
I think Alagesan, you are the first, we can start.
Yes, yes. Good evening, Dr. Nitin and Dr. Smita. So we welcome you all to the interesting session on, say, who is the best, the study competition for the institutions. First of all, we have Apollo Hospital, Delhi, Dr. Pirzadi Zabina presenting a complicated congenital heart disease. Dr. Pirzadi, please.
Very good afternoon to everyone. Is my screen visible?
Not yet.
Not yet. I think the timer should start when they start talking, then. So let us screen.
Which one?
Nitin, you are muted.
Yeah, sir. I kept, it is.
When we are questioning, we can operate.
Started. Just.
Nice. She's there.
Yeah, share screen.
Yes. Visible?
Is it visible now?
Yes, Dr. Shabina, it's visible now.
Start.
Very good afternoon to everyone. I'm presenting a case of congenital MS. We had a 10-year-old male who presented with complaints of progressive breathlessness since birth, unable to play with peers, easy fatigability, and tiredness. On clinical examination, he had a heart rate of 100 beats per minute, blood pressure of 170 millimeters of mercury. JVP was not raised. He did not have any clubbing, icterus, pallor, cyanosis, or pedal edema. On serious examination, S1 was loud. A mid-diastolic murmur at apex was present. Systolic murmur over pulmonary area was present. This is the apical four-chamber view showing thickened mitral leaflets and body attached to a single papillary muscle and enlarged RA and RV, and a subaortic image depicting a subaortic ventricular septal defect. Ventricular septal defect, and the image showing enlarged RV with the flattening of interventricular septum, showing increased right ventricular systolic pressures. And this is the parasternal short axis view showing and the color Doppler across pulmonary valve, revealing turbulent flow across the pulmonary valve, and continuous wave Doppler across pulmonary valve showing a mean gradient of 16 millimeters of mercury across the pulmonary valve, and a TR jet with a gradient of 74 millimeters of mercury. These are 3D images, again depicting parachute mitral valve, where we have a single papillary muscle and the chordae, all the chordae are attached to this muscle, and a subaortic VSD. 3D pictures showing showing parachute mitral valve. So we had a patient, to summarize the case, we had a patient of congenital severe mitral stenosis with mild pulmonary stenosis, with mild to moderate pulmonary hypertension and a subaortic VSD. Patient underwent commissurotomy with the VSD patch. MVR was not done due to non-availability of a small sized valve. He had a mitral annular size of 14.3 mm. VSD closure was done, relief of infundibular PS and mitral commissurotomy was done. He had severe and post-op patient developed severe mitral regurgitation and pulmonary hypertension. A small interatrial shunt was created during surgery to decompress the RA. These are the post-op images which show the results, commissurotomy done, and a severe MR across this. And the shunt which was created during surgery. Shunt across, which was predominantly right to left now, severe MR. RV pressures, now the patient, post-op, the patient had developed suprasystemic pressures with a pressure gradient of 114. Dilated RV. He had a CVP of 16. Now patient had developed suprasystemic pressures and the shunt was predominantly right to left. Patient came with congenital parachute mitral valve, mild infundibular PS, pulmonary hypertension, and a VSD. And post-op, he developed severe MR with more severe pulmonary hypertension and a right to left shunt. Mitral valve replacement in pediatric patients poses significant problems because of the limited availability of adequately sized prostheses, the need for anticoagulation therapy, and the poor long-term results with a reported 10-year survival rate of 33 to 74%. Therefore, repair of mitral valve is the preferred approach. Presence of multi-level LV inflow and outflow tract obstructive lesions, decision-making regarding the timing of intervention, one-stage versus multi-stage repair, and single ventricle repair versus biventricular repair is crucial, as failed valve repair can lead to pulmonary hypertension. MVR in children, the procedure is still associated with a high complication rate, both at surgery and during follow-up, and should therefore be reserved for patients in whom valve repair is not technically feasible. Thanks.
Thank you very much.
Thank you, Dr. Pisha. Dr. Nitin, can you go with the questions?
Dr. Shabina, it was a nice case, a very nice presentation. Now I have got two questions and two suggestions. Okay, one was the first question that I wanted was you had not shown a short axis to hunt for the second papillary muscle. Okay, because you had shown a single papillary muscle only on 4 chamber views, where you may miss the inferomedial papillary muscle very easily. So we wanted a short axis view to show that the second papillary muscle was absent. Secondly, what was the incremental value of 3D imaging in this particular case? Can you elaborate on that?
3D values.
Incremental value. I mean, how did the 3D help you in this case? Because 2D images were so nice.
So,
if I forget it. See just the thing.
So
we are just trying to see the. I think since you knew that the mitral annulus, probably the mitral annular area, you could have calculated very nicely on a 3D echo in this patient. For diagnosis of parachute wall, I think the 2D images were sufficient, but I think the mitral annular area calculation or the mitral annular perimetry, you could have done very well on a 3D volume data set. And my last question is one very small suggestion is that when you are showing the color Doppler images, please turn down, please go on the 2D grayscale. Don't keep the 2D also colored. Okay, it actually reduces the appreciation of color. That's just a suggestion. And lastly, what was the cause of that suprasystemic pH? Was it only MR? Because we have relieved the mitral stenosis, we have shut down the shunt, Despite that, why the patient developed suprasystemic PH?
So severe MR and
so that takes me to the second question, is that if it is severe MR causing a suprasystemic PH, you should have shown some slides showing the severity of severe MR, like pulmonary venous flow, reversal in systole, okay, or quantification by PISA, showing that this was an acute severe MR causing it, or even the so I think something related to the quantification of the MR I expected to be shown. Okay, thank you.
Sumitra?
Yeah, I would like to know, it is 10 years old child.
Yes, ma'am.
Yeah. So didn't you expect pulmonary arterial hypertension established pulmonary obstructive vascular disease? And did you try to do something to rule out that?
Ma'am, actually, before surgery, he was not having this severe pulmonary hypertension.
No, you said VSD is 1.8 centimeter.
It was pulmonary stenosis, madam. There was pulmonary.
It was mild pulmonary stenosis.
Stenosis, yes.
It was mild pulmonary stenosis. So that could have been underestimated when PAH is there, if it is a PSPAH physiology. So that is what I mean. And there was pulmonary vascular, of course, pulmonary venous hypertension, and that may cause pulmonary arterial hypertension subsequently. I agree with that. But because the pulmonary stenosis was not much in this case of large VSD. So, I mean, there has to be very careful approach in these kind of situation. I can say only that. Thank you so much.
There are two questions from me. The patient has got a large VSD overriding pulmonary valvular stenosis. What is the, why don't you call it as a tetralogy of Fallot with a parachute mitral valve? What is the, why do you object? Why you want to object to that? That is one first question. The second question is, after mitral valvotomy, usually mitral valvotomy should not be attempted in pulmonary, usually parachute mitral valve. After that, the echo clearly shows anterior mitral leaflet, flail anterior mitral leaflet. So that's what Dr. Nitin was trying to ask you. The patient, after having a stenosis, it has been converted into an acute mitral regurgitation, which has produced pulmonary hypertension, which is of severe degree.
Yes, sir. Yes, sir. The overriding of aorta and subpulmonary, it can go with TOF physiology also.
Can you call it as a TOF?
No, sir.
Okay. Okay.
Can I request,
Thank you, Dr.
to-
Pisha. We'll go on to the next patient, next contestant. So he is from
Kim's Hospital.
Kim's Hospital. Dr. Grishma will be presenting a case of interesting case of mass over the mitral valve.
We can see your screen, ma'am. You can get started.
Am I audible?
Yes. Go ahead.
Okay. A very good evening to one and all. Today, let's see an interesting case of a mass on the mitral leaflet. 32-year-old housewife from Tirunelveli, Tamil Nadu, with history of hypothyroidism on treatment since 2015, history of hypertension on treatment since 2020. She is married since 12 years, history of PCOD and primary infertility on treatment since 7 years. She has 2 siblings with no known heart disease, no history of sudden cardiac death in the family. There is history of left-sided hemiparesis in the year 2016, was detected to have a vegetation on the mitral leaflet. She was treated with IV antibiotics for infective endocarditis and she recovered completely. In the year 2018, she had a recurrent stroke, right-sided hemiparesis. She was again treated as a case of infective endocarditis, but the mass lesion persisted. All investigations for recurrent and young stroke, including ANA profile, were negative. Examination revealed jugular venous pressure normal with normal waveform, no cardiomegaly. First and second heart sounds were normal. Grade 2/6 pansystolic murmur heard over the mitral area. ECG showed normal sinus rhythm with, ECG was normal and the Holter was normal. This is a mass measuring. This is the first echo in 2016 when she presented first stroke. There's a mass measuring 13 into 0.5 millimeter over the posterior mitral leaflet. Then this is the repeat echo taken in 2019 when she presented after her second stroke. We can see the normal AML and a mass attached to the PML, and there is trivial MR. That is, the nodule is attached to the P2 of PML, mass attached to the atrial surface of PML. This is the repeat echo taken in 2019. So what is this? Is this an infective endocarditis vegetation, a marantic vegetation, accessory mitral tissue, papillary fibrillostoma, or a secondary deposit? What is unusual? She has normal mitral valve leaflets, no other evidence of infective endocarditis, same picture imaged after 3 years. And she had 2 episodes of septal embolism, completely recovered. So we came to the diagnosis of papillary fibrillostoma of mitral valve. This is the first and the repeat echo we are seeing simultaneously. Now there's a case report of papillary fibrillostoma of mitral valve reported in 1999 in European Journal of Cardiothoracic Surgery. So we have taken the patient for intracardiac mass excision along with mitral valve repair, ring annuloplasty in February 2020. And the histopathological examination of mitral valve tissue revealed papillary excrescences. We can clearly see the papillary excrescences and the fragmented reticulin fibers. This is the elastin Van Giesen staining. It's a special stain for this papillary fibrillostoma. And this confirmed our diagnosis of papillary fibrillostoma of mitral valve. Now, she was totally asymptomatic for about 2 years. During her routine checkup, we were totally astonished to see her follow-up echocardiogram. This was the follow-up echocardiogram taken in November 2021. When she came for regular follow-up, she was asymptomatic. There is a mass 14 into 11 millimeter near the base of PML. So a bit severe MR. So present scenario is recurrence of the mitral valve mass with severe mitral regurgitation, and we did mitral valve replacement in December 2021. And the pathological examination revealed as papillary fibrillostoma of mitral valve. And she came for follow-up and is doing well. So papillary fibrillostoma makes about 10% of all primary tumors of heart. The clinical presentation varies from asymptomatic to severe ischemia with embolic events. Diagnosis is by imaging and is confirmed by pathology. Histologically, papillary fibrillostoma have branching avascular papillae composed of collagen that is covered by endothelium, which we can see in our case. Treatment is, if it is incidentally found in asymptomatic person, treatment approach is controversial. If the tumor is large, greater than 1 centimeter in an asymptomatic patient and pedungulated, surgical excision has to be planned due to higher risk of embolism. If it's symptomatic, surgical excision is generally recommended. Why is our case special? Our case is different as the average age of diagnosis is around 60 with a primarily male preponderance, but our patient is only 32 with she is a lady. And prior studies have suggested that post-operative recurrence of papillary fibrillostoma is rare or does not occur, but it has recurred in our case. Rarity of the case, it is a second case of histologically proven recurrence of papillary fibrillostoma of mitral valve. The first case is reported in Spain. It was published in 2018. Echo messages, papillary fibrillostoma do recur after surgical excision, and this emphasizes the importance of post-operative follow-up with echocardiography for identifying recurrent masses. Thus, we want to highlight this. Thank you.
Dr. Nitin.
Yeah, Dr. Grishma. Yeah, very nice case, and I think the very important take-home point that the way we know that the myxoma recurs, the PFE, the papillary fibrillostoma can also recur. I think that was a very good message that you gave, that we should do the follow-ups. Now, I have got one issue is that I did not see a single zoom image of this particular mass in the transesophageal echo, because many times when you look at the mass very carefully, you see those fronts like medusa head, and you know that this is a papillary fibrillostoma. Most of your images were with a very large depth and a very distant one. So that was my one objection. And secondly, do you have a 3D transesophageal echo in your lab?
No. Yes, sir. But we didn't do this for this patient actually.
Actually, that is really required when you are looking at this mass, because let me tell you that there is no other imaging modality which can diagnose PFE better than echo, because even such a such a mobile mass will not be even seen on the MRI properly. So I think the 3D was very important because you can see the surface of it. Okay, so it was more of a comment rather than asking you any question. But I liked your the point of rarity of this case of the recurrence. Thank you.
Dr. Sumitra.
It was well presented case and very good information. I agree that esophageal 3D is one of the most informative investigation for this kind of case. It's nicely presented.
Thank you.
Can you tell me the criteria for diagnosing vegetation? And why name it was?
Yes, sir. It has independent mobility. Should have independent mobility. Then by echo, sir. Only
echo criteria only I'm asking.
Okay. Then I'm not sure, sir. Sorry.
What is the name of the criteria? Name it goes.
Sorry, sir. I don't know, sir. Sorry, sir.
It goes by the name Duke's criteria, modified Duke's criteria.
Okay, sir.
And what are the other conditions you are ruled out? That say ANA, anti.
Yes, sir. Yes, sir. ANA profile, APLA, all we rule out, sir. Because any connectivity disorders, APLA syndrome can present with marantic endocarditis. We have ruled out that, and actually no history, no the blood cultures all were negative, sir. So actually it was negative for infective endocarditis. It didn't satisfy any other criteria of infective endocarditis except for that vegetation. So it was ruled out, sir. Infective endocarditis was ruled out. Then yes.
How do you describe the papillary fibroelastoma in echocardiogram?
Yes, sir. It is a sea anemone-like appearance with papillary fronds attached to the central pedungulated stalk, and it is well seen underwater. Actually, underwater it is well seen, and atypical appearances, small masses. Usually, we'll see a large mobile mass with a large stalk, but sometimes we'll see small masses also, and TE is important in that to rule out to find out small masses.
Since it has recurred after mitral valve
yes, sir.
mitral valve repair, so do you expect any recurrence over the aortic valve or any other valve?
And it can have it can occur it can occur, but it's not recurrence, sir, because already it has appeared in the mitral valve only. So we have done an excision and it is recurred in the mitral valve. It can appear it is more common in the aortic valve actually.
Okay, thank you. Thank you, doctor. Well presented.
Thank you, sir.
Okay. Next case is an unusual feature in a usual case of aortic stenosis by Ramit Badwa, Fortis Memorial Research Hospital at Gurugram.
Good evening, everyone. My case is the patient is 82-year-old non-smoker who admitted with who came with a complaint of cough, progressive breathlessness since 2 months, and pedal edema since 20 days. In January, he had COVID infection for which he was admitted in one of the hospital and where he was treated. And during the course of his treatment, chest X-ray was done, which revealed cardiomegaly, and echo was done, and he was diagnosed to have a moderate aortic stenosis with severe LV dysfunction. He came to us in Fortis for OPD consultation, where on examination, his vitals were stable and there was ejection systolic murmur in the aortic area, and blood investigations were normal except for NT-proBNP, which was more than 9,000, and ECG and echo was done. ECG revealed some non-specific STD changes, and echo was done, which showed severely calcific degenerated aortic valve and had moderate AR. And severe LV dysfunction was there. And if you see the septum, there is a septal bounce we can see, and there is thickened visual pericardium along the RV free wall and posteriorly. And there is a respirophasic septal deviation seen clearly in the short axis view. This is the calcific degenerated aortic valve with restricted opening. And on taking the continuous Doppler, his peak oblique mean gradients were 28/18, and my calculated area was around 0.8 centimeters square. VTI ratio was 0.23 at the flow rate of 130 ml per second, which is reduced, and index stroke volume was 22 ml per meter square. This is the apical views. You can see the septal bounce and thickened visceral pericardium and the color flow showing moderate AR. This was the calculated EF, which was 30%. There was significant respiratory variation seen along mitral and tricuspid inflow velocity. And the septal, there were adverse reversals and paradoxes were absent, but E prime, A prime, and S prime, they were all less than 5. So we kept a possibility of amyloidosis also for this patient. This was the subcostal view showing thickened visceral pericardium with mild pericardial effusion. This is the hepatic vein flow, expiratory diastolic flow reversal, and IVC was dilated and non-collapsing. Strain was reduced 13.3. So we kept the initial diagnosis of low flow, low gradient severe aortic stenosis with severe LV dysfunction with effusoconstrictive pericarditis in normal sinus rhythm. We did the calcium score for the patient, which came out to be 3906, which also suggests the severe aortic stenosis. And we did the pyrophosphate scan for the patient to rule out cardiac amyloidosis. It was negative for amyloidosis. So the dilemma was, is the aortic stenosis severe, and can we do the DSC to rule out the severity of aortic stenosis, and also what is the cause behind the effusoconstrictive pericarditis, and should we treat the pericardial effusoconstriction features? Then we decided to go with the low dose dobutamine stress echo to decide upon the future management course of the patient, as it has a low risk of complication. DSC was done. You can see the contraction improved after giving dobutamine gradually, and on 20 mics, the EF improved to almost 40-45%. The gradients also improved from 18 to it jumped up to 39 mean gradient, and flow rate improved from 130 to 240 ml per second. Stroke volume index also up to went up to 28 ml per meter square. VTI ratio remained 0.19, and area was around 0.7 centimeter square. The Simpsons was done, and it confirmed the EF of 46%, and stroke volume index increased by 22%, which is he underwent coronary angiogram, which revealed non-critical coronary artery disease. So final diagnosis was kept as a low flow, low gradient, true severe aortic stenosis with severe LV dysfunction with good contractile reserve and effusoconstrictive pericarditis, non-critical CAD. This is the algorithm showing a low dose dobutamine stress echo. So I would to confirm the diagnosis of true severe AS. So if the stroke volume increases by 20%, along with the mean gradient going above 40 and AVA remaining less than 1 centimeter square, that signifies true AS. And if the mean gradient is less than 40 and AVA is more than 1 centimeter square, then it goes in favor of pseudo severe AS. So if there is no increase in the stroke volume of 20%, then we can calculate, and area remains less than 1 centimeter square, we can use a projected AVA equation to calculate the area. And also the other modality like CT scan, as we have done, which showed the CT calcium score of more than 3000, which favors the severity of severe, true severe, low flow, low gradient AS. So patient actually went to another hospital. He underwent TAVR 10 days back, and then he came to us in the OPD, and we did the echo. You can see the prostatic heart valve with the, and also the septal bounce is clearly seen with thickened pericardium, and pleural effusion is also there. There is mild paravalvular AR. This again, you can clearly see thickened pericardium and septal bounce. And this is the gradient across the prostatic heart valve, which is 5, suggesting of normally functioning prostatic heart valve. Significant respiratory variations were seen along mitral tricuspid inflow velocity, and hepatic vein flow diastolic reversal in expiration was present, and IVC was dilated, and it was less than 50% collapsing. CT chest was done, which showed thickened visceral pericardium with pericardial effusion. This is again the subcostal view taken showing pericardial effusion with thickened pericardium. So patient at present is getting worked up for etiology of acute effusoconstrictive pericarditis. We have kept a DT of post-viral and tubercular and malignancy as possibilities. This is one study we found which was published in 2015, in which 84 participants were taken and 28 out of 84 were associated CCP with moderate to severe aortic stenosis. So they revealed that CCP is a cause for paradoxical low flow, low gradient aortic stenosis. And the patients, they were mainly post radiation and post CABG patient, those who were having CCP. And the 5-year survival of patient having concomitant CCP along with aortic stenosis, they have a very poor 5-year survival, 34% versus 89% with only isolated aortic stenosis. So this is the rare case of low flow, low gradient true severe aortic stenosis with associated acute effusoconstrictive pericarditis who underwent TAVR, and low flow state could be because of the LV dysfunction and effusoconstrictive pericarditis, and AS with constrictive physiology may confer a poor prognosis. Thank you.
Dr. Nitin?
Dr. Ramit, a very well evaluated case. I like that you had a detailed measurement of stroke volumes, transvalvular flow rates, and all the data of low dose vitamin stress echo. Only thing I missed was he's an 82-year-old, I think, isn't it?
Yes, sir.
Yeah. So anyway, he was a high risk patient to start with. Was he obese?
No, sir, not obese, but very fragile looking patient, and was not obese, sir. But he was a tall man. His BSA was around 1.97, sir.
Okay. Second, though, now the first thing is that you said the ECG was normal, but actually, if you see the limblets were very, very small. If you see the voltages in the limblets,
Yes,
it was very small.
Yes, sir.
So I think just looking at an ECG of a severe aortic stenosis with such a low, you would think of an amyloidosis. And I think now the explanation can be because of the thick pericardium and severe basis. So I think the ECG was not normal. That was one important thing.
Yes,
Secondly, was the CT, the CT is always done before the TAVR. So I think the pericardial thickness, which was so apparent on the CT, could have been known even before TAVR. So I don't know what.
Yeah, this patient, we actually diagnosed constrictive pericarditis before TAVR, but patient actually lost follow-up with us. We actually diagnosed him to have a severe aortic stenosis. Then without our follow-up, patient went to other hospital and he got his TAVR done there, sir.
Yeah. And only thing, was the CT showing any calcium in the pericardium?
No, sir. It was suggestive of pericarditis with pericardial effusion.
Pericardial. Okay. And was the right heart cath done?
No, sir. Right heart cath was not done. TR was very mild. It was the PA pressures were 25 plus 15, around 38, sir. I think the slide was not there because of the shortage of time. I think I missed that slide.
Okay, thank you.
Dr. Sumitra?
This was well presented and well investigated case, and congratulations for presenting it. Only thing, can you guess on the etiology of the effusoconstrictive?
Ma'am, patient is still under evaluation. He is having, we are suspecting this patient had COVID in January, and we are suspecting it may be either tubercular or a post-viral, or maybe there is some underlying malignancy. Patient is still getting evaluated. He is coming to us in the OPD because this is just a recent case. We are still not having all the investigations with us. So probably maybe next time when I present this case, I will be having the full detail, and I will definitely like to elaborate on that.
Dr. Alagesh, kindly. Dr. Alagesh, please.
Okay. One thing is, why you didn't go above 20 mics to 30 mics or 40 mics?
Sir, actually, the target was not to achieve increased heart rate. See, baseline heart rate was somewhere around 80, 90, and we achieved the heart rate of 180. And the parameters which we wanted to achieve was the increased flow rate. We were able to establish increase of more than 20% of stroke volume, and also the flow rate from 130 to 240. So I think the purpose of doing the low dose dobutamine stress echo was suffice with that, and the area remained 0.7, and there was the ejection fraction also improved from 35 to 45%. So there was no reason for us to go beyond 25.
Should we go?
No, sir, it is not actually required to go. We
Why?
should actually be.
Why?
Sir, if we increase the heart rate,
It's okay. The ionotropic effect is obtained by 10 to 20 mics. After 20 mics, it's only the chronotropic effect.
Chronotropic effect, yes, sir.
That's why you should not go beyond just the question.
Yes.
Actually, when you presented the first batch of echoes, I was not convinced about the septal bounce. But the second echo after surgery, after TAVR, it clearly showed the septal bounce.
Yes, sir. The features got unmasked after doing the tower, sir. They were the septal bounce was more pronounced after getting the tower done, sir.
Okay. How much was the improvement in the LV function before, say, compared to the?
So when he came, his ejection fraction was between 35 to 40%, and before tower it was around 30-35%. So definitely there was improvement, sir. And it's just only 10 days after this after the procedure. Maybe with the next follow-up, he might improve it further, sir.
Yeah, as Dr. Alagation had pointed out, why the constriction features augmented after the TAVR? Why did they become more obvious after the TAVR? Can you give the explanation, hemodynamic explanation?
Sir, possibly because of the obstruction in the release in the obstruction of the LV outflow, the LV end diastolic